Good morning and welcome, everyone. I want to first thank you for coming out and being with us this morning. I think you're going to find we've got an exciting program for you today, but really going to start off with a bang-up plenary session and have a conversation with some of the folks who are really leading the way in cancer care. I first want to turn to Lisa Lacoste from the American Cancer Society Cancer Action Network to talk a little bit about what they're doing at the Action Network.
So good morning, everyone, and we all braved the rain instead of the snow, so I guess that's good. And a little gloomy, but I think this is going to be a sunny room today. Much to talk about and a lot of progress, but obviously an incredible amount of work to do. And I want to just thank Dr. Parkerin and NMQF and the Roundtable, just elevating these issues are so critical. Having the framework of the Moonshot has been game-changing over these last few years, and we are extremely grateful for the partnership. So for those of you who don't know, Lisa Lacasse, I'm president of the American Cancer Society Cancer Action Network, and we are the advocacy affiliate of the American Cancer Society, and I'm part of the executive team of the American Cancer Society. So everyone knows ACS, this iconic 110-year-old organization. And our work at ACS CAN is really about engaging elected officials, policymakers, and government officials at all levels of government because of the incredible role that they play in the fight against cancer and reducing the cancer burden. And so foundationally for our work and to achieve any goal as it relates to cancer and reducing the cancer burden, you can't achieve any of those goals without reducing disparities. And I know that's a lot of really the goal and the lens of today. Health equity is so critical. And what we know is that although cancer affects everyone, it certainly doesn't affect everyone equitably or equally. And so our job is to really look at how we intervene from a public policy standpoint to reduce those disparities. And we organize in sort of three big categories. We do a lot of access to care work, as you can well imagine. Foundationally, if people don't have health insurance or some sort of health coverage, there is no ability for someone to prevent their cancer, detect it early, treat it in the most innovative way, and certainly to have good survivorship. So that body of work is critically important. We do a lot of work around emerging issues. The science of cancer is so exciting right now. There's so much innovation coming on the market. But what we also learn and are seeing more and more is that there is not equitable access to that innovation. So what happens? Innovation comes onto the market, but everyone doesn't have equal access to that innovation. So unfortunately, that means we're increasing disparities as opposed to reducing them, which is really what we want innovation to do. And then we have a huge prevention portfolio, which we do in partnership with so many others. Certainly tobacco control, a very hot topic right now, and nutrition, physical activity, so a lot of areas there. So at a very broad level, our public policy agenda is really about any intervention that's important to a cancer patient and their families. And we can talk more about some of those specifically, but that's sort of our broad approach to the work that we do.
Thank you so much. I'm going to ask Jody Haas to talk a little bit about Prevent Cancer.
Absolutely. Good morning, everyone. I'm Jody Hoyos. I'm the CEO of the Prevent Cancer Foundation. And thank you all for the early birds here today. I know you guys are the change makers, and that is exactly what we need right now. And Prevent Cancer Foundation is all about that. It is time that we do things that are a bit more transformative in order to break through the noise and the conversations about equity that we've been having. It is time, and I know Gary is a very strong proponent of making real change. So the Prevent Cancer Foundation we're now about 38 years old, so we've been in the space of the prevention and early detection of cancer exclusively. So we're the only organization in the US, nonprofit, that is solely focused on cancer prevention and early detection. And there are a couple of different ways that we do our work. We are advocating at the federal level for legislation, and that includes access and funding for this field. We fund research to advance the body of knowledge. We provide community organizations with the funding they need in order to have boots on the ground to implement prevention and early detection. And this is with a particular lens on medically underserved communities. We know that that is the most effective way to reach these people that most often need the care. And last but not least, as one of our pillars, is public education. This public education is often overlooked. It is the awareness piece. Awareness is such an enormous barrier that can sometimes be trivialized. What people know about cancer is much less than we think. How people think about their own health, where they need to get it, and very importantly, why. Why is prevention and early detection important? We know from some of the work that we did, we do an annual early detection survey, and we're undergoing our current survey now. But our last survey showed that you had over 30% of people who aren't aware at all of what cancer screenings they need to be getting. And that is what they cited as the biggest barrier to getting their screenings. We have over 60% of people that are behind in their cancer screenings. But the good news there is that over 70% of people said they would be motivated to get their screening after knowing why they need it. So the awareness piece is huge, and the who does the awareness piece is a very important part. So those are the core elements of what we do at the foundation.
Well, thank you so much. I'm going to ask Marion Tybett from Merck to talk a little bit about the great work that's going on at Merck.
Yeah, no, thank you so much, Dr. Pokran. And for those of you who don't know me, because I do see some friendly faces in the room, my name is Mariana Tiabet, and I'm the AVP of Health Equity and Partnerships at Merck. And as you know, our company, really is one that has been running towards the really hard health problems and challenges, and thinking about how can we bring our scientific expertise, discovery, innovation to solve for those challenges. But I think the other thing that's important for you to know about the company is that drive to, and that mission, to save and improve lives is not just about our science, but it's about how we can partner with people, how we can partner with patients all through their lives and all across the care pathways that they are engaged in, whether it's in cancer or in other chronic diseases or through maternal health, and make sure that they have access, to the high quality care that's needed. We have a saying in the company that it's, how many people can we help? How can we help them? But the new question that teams are asking is, who are we helping? Because if we don't ask that question, then our work just reinforces the inequities that we see in the society around us. But when we ask that question and we open up our eyes, to see who are we missing, then that drives us to partnerships. And that drives us to think through, how can we partner with the ACS around screening? We had this, we've talked about screening here, especially during COVID. We saw those numbers drop. And we're just so excited that through our partnership with the American Cancer Society on their Get Screened campaign, almost, I think now over 500,000, people have been screened. And this year we're making a even more concentrated effort for lung screening, because we know that those screening rates are in the single digits across most of the country. Talked about, prevention and awareness. And again, so excited that we've partnered with the CEO Roundtable to make sure that education, information is getting to people in communities, working through the HBCUs and the Hispanic serving institutions, where I think, and this is an important piece, we are sharing these stories when people are moving through their daily lives, you know, not when there's a diagnosis or there's a big kind of health scare, because at that point, I do think it can be difficult, you know, to take in that information. And so, you know, thinking through who are the trusted intermediaries and trusted voices in communities that people will listen to and hear from, and support engagement, support activation, and how can we share those learnings and those experiences, you know, for broader efforts, you know, across the way. So those are just, you know, some of the things that we hope to be able to share with all of you. I'm so excited that we are really leaning into artificial intelligence, and thinking through, you know, also what is that handoff, you know, between you know, what's happening in technology, and what's happening at the front line, you know, on the streets. Because I think until we get that right, we're not going to solve for the cancer inequities that we see around us every day.
Great, thank you so much. Mary Elizabeth Rich has been a tremendous partner and friend. We've been excited to partner with the CEO Roundtable on Cancer, particularly for this event. And I'd love for you to tell people about the organization and the work that you're doing.
Thanks, Gary. We're lucky we found one another, actually. It was really just by chance, and from that, a budding partnership really formed, and that's why all of us are sitting in this room today, because partnerships find solutions. And we're not going to solve the cancer equation sitting in a silo. So thank everyone for being here today. You play a critical role in our path forward. And I would like to also recognize that we have a few people that have hosted for us some watch parties and town halls across the country. You actually mentioned, Dr. Idabet, that our schools, we work closely with HBCUs and HSIs, and we have town halls that are actually having viewing parties and discussions as follow-on to this of how they can bring about better activation. And I just want to recognize those. It's Shaw University in Raleigh, North Carolina, and that actually was brought to by Dr. Barbara Powell Jackson. We also have North Carolina A&T in Greensboro, North Carolina, and that town hall is being hosted and prompted by Dr. Raymond Samuel. UNC Pembroke, Dean Eva Suka, and also Dr. Jess Boersma are both hosting there. UNC Pembroke is an indigenous institution in Lumberton, North Carolina, and they are closely linked to the Lumbee tribe. Winston-Salem State University, Dr. Cassandra Weinglass, Meharry Medical College, Dr. Al Sindor, there we really appreciate all of you there. And then also Stillman College, Dr. Christina Gladney. Certainly big shouts out to all of those institutions that have stepped forward, continuing to drive home that message into their community and being a resource in their community, a trusted resource to bring about conversations and dialogue around cancer, both prevention, screening, treatments, and access to clinical trials. We also have two additional solid partners in this, and that is RTI. They're actually out there in Research Triangle Park. They're hosting a watch party for us there. Tim Gable, we appreciate you there as leader. And also MD Anderson, Dr. Peter Pisters and the team there hosting in Houston. And we're looking forward to pulling together that work that's happening in Houston with Councilwoman Letitia Plummer and bringing those folks together. So we really do appreciate those that have brought together this town hall. So the CEO Roundtable, as you were asking, Gary, I kind of highlighted that just now. We're a convener, a collaborator, and a catalyst in the area of addressing the cancer burden. We actually started about 20 years ago, and I don't want to have a whole lot of history, but it's important because of how we came together was exactly what's happening here today. It was a call to action by then the late President George H.W. Bush. I'm going to note that he was about 10 years out of office. So this was not a political call to action. This was a call to action to do something for people, for the American people. And what happened is that he reached out to CEOs. And he started that. He said, what becomes important in the corner office becomes important in the company. And he asked CEOs to step forward and put a stake in the ground around cancer and doing something for your employees. And we have many of our employers here that are engaged with the Roundtable directly. We appreciate you. Merck being one of those. SAS, I see there. Bayer. I don't want to go. I'm going to get in trouble if I start shouting out names. I need to stop. I need to stop. But uniquely is that we share a lot of those same partners at NMQF and at the roundtable. So the stage is really set really well. From that, the call to action was, let's create something bold and venturesome. And they actually created an accreditation. That scares some people because it's like, wow, that's a lot of work. And it is a lot of work. It should be hard. It should be hard to achieve good health care. When I say hard, it should be hard for companies intentionally to make sure that they are doing right by their employees. That program has been in motion for about 17, 18 years now, and it serves as the CEO Roundtable's flagship piece around gold standard accreditation. We refer to it as CEO Cancer Gold Standard Accreditation. We have about 200 companies that are involved in that program and have received accreditation, and that actually represents over 7 million lives are covered. From that, we actually springboarded into Going for Gold, and that is our work within the community. So we're actually taking that Going for Gold effort and launching that into the universities, HBCUs, and HSIs, only because in that space, not only because in that space, but because they are such flagships, as I mentioned, in their communities, they're trusted partners, and helping them create not just campus cultures of communities, but creating communities of health culture. We want them to actually have healthy communities around the campus. So those are the coupling of areas there, but also as we're talking about AI, Project DataSphere is a huge flagship as well for us. We have 3 areas. We have the gold standard, Project DataSphere, and then we also have our member ideation. But I'm going to talk about Project DataSphere for just a minute. So Project DataSphere, and so I'm not the science person, so I want to make sure that I get this right specifically. But it is an open access data platform. And the Project DataSphere platform provides a place where the world's research community can broadly share, integrate, and analyze patient-level data from academic and industry cancer clinical trials. And by the way, this actually is powered by SAS, a great partner in this space, and we appreciate all that they do there. Also, our collaborative research programs, which is also hoisted up in our scientific portfolio of Project DataSphere, and it explores all the leading areas and issues in oncology using machine learning. So really diving deep into that space. So I know this partnership that we are building out here in this room, we're all going to play a significant role in how we move forward together and address the burden of cancer.
Thank you so much. For the uninitiated, HBCUs is historically black colleges, and HSI is Hispanic serving institutions. We get into our, yeah, okay. One of the things that I've come to appreciate, particularly living here in Washington, is that health policy is a branch of medicine. You may not think it is, but it is actually a branch of medicine, because if you're not advocating, you're not getting. And so I want to have Lisa take a little bit of a deeper dive into the kind of advocacy and policy work that ACS CAN is doing, because it is spectacular.
Thank you. We appreciate it. We are spectacular because of our ability to mobilize patient voice. And so when you're a grassroots advocacy organization, your power, we have lobbyists, we are in all 50 state capitals, we have a powerful team here in Washington, D.C., but our power really comes from the voice of the constituent and really making sure that they understand how much influence they can have with their elected officials. And our work is to, as Gary said, there is no question that we can't have the impact that we need to have if elected officials, candidates, government officials don't really understand how much power they have in their decisions about what their priorities are and how they, at the end of the day, how they vote on a piece of legislation. And so as we think about organizing that patient voice and focusing on specific pieces of legislation, let me just give one, I'll give you a state example and I'll give you a federal example. So I spoke earlier about innovation that's come on the market in cancer. There's just so much happening. And part of that evolution has been around personalized medicine. So, cancer is an extraordinary complex, issue, and there are incidents now where you have a particular mutation, and they've learned through incredible work with our biopharma partners that a specific medicine can be very, very effective. But you have to know that you have that mutation. The only way you know that is if you get what's called a biomarker test. And so this, personalized medicine's been on the market for a while, but what we learned over the past few years is that access to biomarker testing is very unequal because it's not covered the right way. So what do you do? Like, if there's not coverage, even though it's on the market and it should be used and it's medically necessary, but it's not being, it's not, the uptake is not there, you pass a law, right? And you require that medical necessity is covered through insurance. And that has to be done it's being done at the state level right now. So we have been successful in passing a model piece of legislation requiring biomarker coverage, testing coverage in 14 states now. And what it's a pathway, right? And what that means is that now insurance that is being regulated in those 14 states must cover that test. So now clinicians know if they prescribe the test, it is going to be covered and it's accessible. So that's a very specific example of like a piece of legislation that has been designed, is introduced, and it's being worked on literally across the country to make sure that there is equitable access to personalized medicine if you get a cancer diagnosis where you can benefit from that. At the state level, I'll talk about PSA for Him. This is a prostate cancer screening coverage act that is at the federal level. Again, we know through the evidence that any barrier to early detection and screening, cost barrier in particular, means that people aren't going to comply. And Jody, we've worked really hard on this. I think the awareness that you brought up is so critically important. So we are working to gather champions and make sure that everyone understands that any sort of copay for a screening means that people, if you have to pay money, there are many people who won't get it. And the other thing that's happening in our space as we learn more and more about the science is your actual own personal risk. So coverage for prostate cancer, it's a complicated issue related to insurance coverage, but we know that Black men have extraordinarily higher risk in prostate cancer, particularly more advanced prostate cancer and mortality. And so if you're a 40-year-old Black man, you should be talking to your doctor, getting screening. And so this law will ensure that if you have a family risk, some sort of risk, that you will not have any copay for that screening. And again, just lowers the barrier. So a couple of examples of really specific pieces of legislation that we mobilize to make sure that elected officials understand how important the legislation is and get them to support it and ultimately pass. So a couple specific examples.
Very important examples for sure. Jody, you mentioned that Prevent Cancer is also making resources available at the community level. Can you take a little bit of a deeper dive into that?
Sure. So, there's two ways that we do that. I think Marianne pointed to knowing who you're talking to. And we spent a lot of time trying to understand the different audiences that need messages and how those messages need to be delivered. And sometimes we are working at the national level and very specifically making outreach through digital campaigns, through radio, TV, print, and actual printed materials that are speaking directly to that community. I mean, we have a campaign that would be a little on the edgier side called Too Young for This Shit, and it is about young onset colorectal cancer. And we made sure to have focus groups to understand how those messages would resonate and whether or not they would resonate with different audiences. In particular, we had a focus group of Black people from different communities, different segments of different socioeconomic status, different settings, rural, urban, and understanding how these messages were received, because that is a group we want to make sure is seeing and hearing the messages and having the ability to act on them. So, it's knowing who you're talking to and whether we're working through our community grantees and supporting them and delivering the messages through their trusted partners, or working at the national level through all different mediums to reach them. That is how we do it, and then measure it. Yep.
Thanks so much. Mary Ann, can you talk a little bit more about the work that Merck is doing, particularly in cancer and the outreach that you're doing?
Thank you so much, and I'd love to actually share what we're learning, from that work and from those collaborations. And one of the themes I'd love to be able to lean into today is when folks think that there's no hope, there's no action. But we've heard that we can change what the status quo is. And so many of our partners are telling us that, providers are not sharing the full range of options with all of their patients because they are making assumptions about barriers. They're making assumptions about people's level of education to understand, certain issues. They're making assumptions about whether people will be able to adhere to the full range of treatment. They're making assumptions about stigma. And so I think the work we're doing, all of us here, is to really poke holes, in people working because of the status quo. Yes, maybe 2 years ago, before the amazing work of the ACS network, not everybody had access to those diagnostic tests, but now more people do. And so I think we need to get the word out that there is a lot happening to change the status quo, and folks can get engaged in their care to fully inform about what the different options are, and what the different pathways, to getting access to those options. And so I think that's what we're learning, that there's still a lot of, assumptions about access to cancer care that we need to actually start to poke holes in.
I want to just jump in for a second. I was talking to Mr. Woodson. Did I get your last name right? Yeah, all of a sudden, as I was saying, I was like, I'm saying it right. Earlier, who's from Flint. And I think that you're bringing up a really important point, that there are the connection between the resources that are available and the people who need those resources is not really evident. And I think that also is a big part of the gap. And one of the things, an issue that we've been working really hard on, and I want to give a shout out to the Moonshot for really helping push this forward, is around patient navigation. And so patient navigation, I mean, everyone needs patient navigation. This is not an issue of a disparity. The healthcare system for any of us is so unbelievably complicated, and the complexity of trying to work your way through, if you have, a serious diagnosis like cancer, it just elevates much higher. And so how do you help people, if they get a diagnosis, understand what their next step is and help them reduce the barriers of that pathway? And so up until just January, patient navigation has not been a reimbursed service. So patient navigation has been pocketed in certain places, funded through the generosity of, organizations like the American Cancer Society, again, companies like Merck, but it's been very targeted in specific places depending upon the funding stream. We need to sustainably create a workforce across the cancer continuum for patient navigation. And I think that intervention is a true game changer in helping people to connect from where they are in their community to the resources that are available either in their community or in some place like Ann Arbor, a little bit further away. And no one can do that on their own. And certainly people have a lot of other barriers, transportation barriers, maybe not access to good primary care, or any sort of medical establishment. And so that is something that, from a community standpoint, the more we can organize around the importance of that intervention, and elevate the science that patient navigation has been proven. We don't need to study it anymore. There are different ways in which we want to make sure we're doing it right. But now that we have, a reimbursement strategy that is a first step in a process, there's going to be much work left to be done from a public policy standpoint. But this issue of identifying the resources that are available and the innovation that's important to someone's outcome is not as evident as many would think. Oh, you go to the doctor understands what your cancer is, they tell you what you need to do, and you go do it. Like, there's so many steps in that process, and patient navigation is going to be a really important way that we can really make a change in the way people experience the healthcare system that will result in better outcomes.
Thank you so much. I want to position this conversation for the rest of the day. First of all, what's really important about this room is that we have AI specialists here. We have public policy specialists here. We have oncologists sitting in the room. We have patient advocates. We have all of the power that we need to actually do really effective changes. And NMQF, in our contribution to the Cancer Moonshot, we've launched a program called Cancer Stage Shifting Initiative, because what's happening in minority communities and poor communities is that they're getting diagnosed with metastasized cancer. When we have the capabilities and the science and the capability, and everybody in this room is part of that, that can move them to stage 1 and 2. Because if we can move them to stage 1 and 2, we can improve their survival rates. At least that's the general sense, right? And that's what the Cancer Moonshot is saying. The Cancer Moonshot is essentially saying that it wants to reduce cancer mortalities. So I want to be very specific, right? Because at NMQF, and I was telling some folks last night, we spent the first 10 years of our existence, every meeting like this, listing the disparities, right? They die more from cardiovascular, they die from kidney disease. We don't want that conversation. We want to be very action-oriented. We have 2 communities that we're focused in on right now. Flint, Michigan, and Arthur Woodson has been a real champion of Flint, and has brought that certainly to the White House's attention in 2 hours, and Houston, Texas. The conversations that we are having today is, so how do we bring real resources and capabilities and talent into those communities to transform them, to bring state-of-the-art cancer care? So don't think that this is just a bunch of conversation stuff going on here. We got your email address, and we're coming after you because we need you to volunteer. We need you to work with us, right? Because that's what communities do. That's what we do. And so I say this to Lisa because ACS CAN, their power to help shape cancer policy cannot be ignored. I say to Jody, the work that you do in Prevent Cancer, you got to listen to these stories in these communities. We got to get there and help them. I say to Merck, your technology is so important, but it's not getting to them, right? It's not. We know that. And so we need your help. Mary Lisa, she and I, we talk about this all the time, so she's got it. And I'm saying to all of those watch parties that she has helped to organize, we need your help too, because those 2 cities that we're looking at are really to build the template, to learn how do we do this. Because the science and the technology is there. We can change the rate of cancer. We can do that. We can lower the it's not, you know, I know Angela's going to tell me to get off the stage in a second, but I got to make this point. So I tell you my doctors in history, you know what I studied? I studied classical medicine. I studied Aristotle and Galen and bloodletting and leeches and stuff that didn't work. I remember this one patent medicine bottle was in the, it was about 1630, and it listed all of the things that it would cure, the whole list of things, everything, right? And at the end, it said, remember, we all must die. So my point is, we're at that place. What's missing is our collective will. That's what's missing, is will, organization, to build the infrastructure, the supply chain into those communities and transform it. That's what this conversation is about today. So I don't want you to walk away thinking that, oh, you came to a talking head meeting, because that's not what this is, right? This is not what we want to do. And as soon as we leave this meeting, because you have to listen to the presenters today and what they're going to say to you, and then we need you to take that home and think inside your organization. So what can I do for Flint? What can I do for Houston, Texas? How can I change that, right? And then work with us to put that stuff on the ground. So anyway, I want to thank our panelists. They are the leaders, and they have done so much, and we want to amplify and take their work forward. So thank you so much. Hello. I am really excited about our next speaker, Annabella Esperis. She's Assistant Director of the Cancer Moonshot Engagement. So NMQF, Annabella and us go back ways when it comes to the moonshot. We were there when then Vice President, yes, launched the first cancer moonshot. We were extraordinarily excited about it then. And when President Biden took office, he launched the revised cancer moonshot. We've always understood this to be a transformative event. And so I'm going to ask Annabella to talk to us about the Cancer Moonshot, its goals and expectations, and how can we all help?
Thank you so much, Gary. I want to start by saying hi to everyone in the room, but also hi to everyone who is joining us via live stream. This has been a spectacular event so far. I was here yesterday, and I'm so excited to learn from what will happen today as well, and from all of you folks who are joining us virtually. Your voice is here with us. Now I've forgotten the question. What is the Cancer Moonshot? Well, before I answer that, so Gary and I do know each other from 2016 when the Cancer Moonshot was launched under then Vice President Biden. And I think a takeaway that I have from that iteration of the Cancer Moonshot was how it started this. Everyone here in this room has understood the need, the pressing, the urgent need to solve the problems associated with cancer. What I think the first Cancer Moonshot did was start that drumbeat that has not stopped, and I just want to commend the National Minority Quality Forum for continuing to be part of that drumbeat today. So the Reignited Cancer Moonshot is a White House-led national effort to end cancer as we know it. Gary alluded to this. We have two audacious, but we think achievable goals. The first of these is to decrease the death rate from cancer by at least 50% in the next 25 years, effectively sparing 4 million lives by 2047. And then the second goal is to support patients and families who are living with and surviving cancer. And I'm so glad that Lisa Lacasse did some of my work for me to talk about the navigation work that we've been leading from the White House, but I'm sure I'll come back to it as well. But when I think of that second goal, I think about what are the strategies that will really end cancer as we know it for folks living with and surviving cancer today. I'll jump in the interest of time, I'll jump straight into our priority actions as well. The way that the Cancer Moonshot is organized is that the president made this an all-of-government approach. He pulled together what we call a cancer cabinet, consisting of about 17 federal agencies and sub-agencies, and they were allocated the budget that you see in the news for the Cancer Moonshot to either create net new programs to achieve those goals I just listed, and or scale existing programs to make sure that we can achieve those goals. They also established 5, we call them priority actions. And I'm going to run through them quickly, but I'm sure we'll come back to them each in turn. The first is to close the screening gap. This means ensuring that everyone has equal and equitable access to cancer screening so that we can detect cancer early when outcomes are best. Number 2, and something that we talked about a great deal yesterday, is understanding and addressing toxic and environmental exposures like air pollution, forever chemicals, the things that we know today cause cancer. Number 3, decrease the impact of preventable cancers. This includes reducing, essentially we need to stop cancer before it starts, and this includes reducing tobacco use. I know my former panelists brought that up. It is a hot topic. It's so important as well because 130,000 deaths we think could be preventable if we can tackle smoking. Reducing tobacco use, ensuring that folks have access to good nutrition, and also increasing HPV vaccinations since we know that HPV causes certain cancers. Number 4, bringing innovation through the pipeline to patients and communities. I think the panel that was before me did a really good job of explaining that innovation has the potential to really leapfrog us forward. But if that innovation isn't equitably distributed, it could cause barriers and rifts to grow even larger. So how do we ensure that we are investing in the infrastructure that will allow every community to benefit from innovations as they come out? And then last but not least, supporting patients and families. And this includes our efforts to make drug prices more affordable to everyone, and also that critical work around navigation. So that's us in a snapshot.
Well, it's an amazing commitment and opportunity for us all. And the thing I'd love to underscore with you is that it's just not a government program. You're looking for everybody in community, wherever they stand, to help.
Thank you, Gary. I appreciate that. You are, and that's the first time I've called you Gary. I've always called you Dr. Puckran, as he should be referred to. Absolutely right. Danielle, my boss, spoke here yesterday And she reiterated this number: 100 private sector organizations, institutions, academies, companies, for-profit companies, have stepped up to join our effort. Among them, the National Minority Quality Forum and the CCSI, Cancer Stage Shifting Initiative. These organizations have stepped up to join our cause by committing new actions and new resources to the fight against cancer, to us ending cancer as we know it, excuse me. And that is because we know that we cannot achieve our goals through government alone. The Cancer Cabinet is huge and mighty, and like the president said, we need an all-of-government approach, but we also need an all-of-society approach, and that's why I'm motivated in rooms like this to see all the many folks outside of government who are here to join our efforts.
That's super. I know Lisa talked a little bit about the patient navigation. Do you want to talk a little bit more about that?
Absolutely. So yes, I appreciate the opportunity to answer that question. So in his State of the Union a year ago, I realize we're coming up on the State of the Union of 2024, but in 2023, as part of his unity agenda, President Biden set the goal of making navigation services a covered benefit for as many Americans facing cancer as possible. When I say navigation, I am referring to the services that community health workers, patient navigators, nurse navigators, social work navigators provide to help move patients through an incredibly fragmented healthcare system. And we didn't do introductions, but I say that as a nurse. I was bedside for almost 7 years before I went into oncology administration. And a quote that has always stuck with me from one of the physicians that I worked with is, "It is a marvel that people survive the healthcare system." And I was like, ooh. Anyways, so these services, which include education, advocacy, health promotion, explaining your symptoms, explaining your treatment plan, and a work that was very near and dear to my heart, explaining goals of care, even if those goals are not curative. This work, Lisa said it earlier, we didn't have a strategy for paying for this work. So unless you were a well-resourced cancer center, for example, who could use overhead budget to hire the staff that I mentioned, it wasn't happening. Lisa also mentioned this, but cancer navigation has been shown to address some of the mistrust in the healthcare system that has historically left groups behind. And that cannot be understated, especially at this forum around equity. So those navigation services that I just described, there was not a pathway to pay for them. The president said we're going to change that. I was thrilled to be part of that effort, both as a nurse and someone who understands the value of navigation personally. So the way we went about that was to work with our CMS colleagues and the American Medical Association. The American Medical Association are the gatekeepers of a set of codes, commonly, that's my gatekeeping gesture, are the gatekeepers of a set of codes called CPT codes. And those codes are used often by, I'll call them commercial payers. So we worked with both of these groups, and we're thrilled to announce in November, although they hit the market in January, half of these codes, 6 new codes. 6 codes, let me say 6 codes. 2 of them were net new, and those were principal illness navigation codes that were released by the Centers for Medicaid and Medicare. These cover the services of non-clinical navigators, including community health workers, to provide those critical services I mentioned, health promotion, advocacy, navigating them through the healthcare system. The AMA, so those are 2 codes, principal illness navigation codes, and then 4 codes from the American Medical Association. These are 4 CPT codes that did exist. They're called principal care management codes. And what the AMA did was to update the guidance for these codes so that they could be used to cover clinical navigation services, meaning services provided by someone with clinical licensure, nurse, licensed clinical social worker. And those services are those critical, how am I helping this patient navigate their journey, either through the diagnosis to screening to diagnosis or diagnosis and beyond. So very, very important. I'm just gonna point you all to a resource for many things, including the just broad array of work that the Cancer Moonshot is doing. OSTP, which stands for the Office of Science and Technology Policy. We have a website, and the staff at the White House write blogs, myself included. There's a blog around navigation. It says, I already forgot my title, but it's Navigation is Important, Paying for It Matters Too. It has links to all of the 6 codes that I just mentioned, in case you're like me and you want to look them up yourself. I would also just point, folks, you know Grail. My colleague, we do a lot of work in the clinical trial space. I don't think we're going to have a ton of time to get into it, so I want folks to go to a blog around clinical trials readiness, which speaks to the work that we are leading, both the Cancer Moonshot and a division of OSTP called Health Outcomes, around making sure that clinical trials are more equitable and more equal.
Great. Go.
I want to give you a shout out to you because I'm a practicing oncologist. And in the last 10 years, what you've done with this principal illness navigation and the other G codes, this is going to change the equity equation because up until now, collecting social determinants of health and reporting Z codes was not being reimbursed. But when you look at, say, for example, I found somebody who didn't have food, connecting them to the community health resources, CHI, use G019, would be an incredible help. So big shout out to your team. Just want to commend you for that.
That's very kind.
I'm
I
just
really
going to
appreciate that.
follow up to say, for the folks in Houston and Texas, these codes mean something to you as well, right? And that's part of the reason why I'm saying to you, this is not just a conversation, but an opportunity to get resources where they need to be. So thank you so much, Dr. Patel.
Shout out.
Yeah,
Really,
yeah.
10 years as an oncologist is the biggest change that would change the equation of the disparity.
I'm flattered and deeply appreciative of that praise. Yeah, I'm sorry. I just wanted to say that I'm flattered and deeply appreciative of that praise. Obviously, it is very helpful that President Biden said this was important. It allows us to go out and repeat that to the folks who needed to hear it to get this work done. But I want to, in case folks on the live stream couldn't hear his comments, I think you were referring to some of the social determinants of health work that came out of CMS. And again, if you look at those links, you'll see it will link to CMS so you can see the physician fee schedule that spells out all of this work. And I think it is so important in this room to reiterate social determinants of health. Kathleen, who was a speaker yesterday, said something that gave me chills, which is that, and I'm paraphrasing, but at yesterday's press conference, she said, "I'm thrilled to be here today, standing on the shoulders of the folks who have been doing the work to improve health for minoritized communities before caring for minoritized communities became important to the majority." And it just gave me chills because it is so true. I worked for 10 weeks in New York City in the emergency room at the start of COVID. So I have a lot of trouble saying that there was ever a silver lining in COVID. But one of the things that it did do was to lay bare the reality of health disparities that everyone in this room who has worked with patients knew about, but that the nation writ large was not talking about yet. So I am grateful that social determinants of health are now part of the parlance when we talk about healthcare, because it is unblocking the necessary policy steps that need to happen to get us to change cancer care, well, and healthcare writ large.
Last question. I'm going to, and just about everything you talked about, implicit in it was health equity. But, you know, we got some hard-headed folks out there that you don't need to be subtle with, that you have to talk directly to about how the Cancer Moonshot, what does it mean for health equity and the cancer inequity?
Absolutely. Can I take, would it be beneficial? I find that it is still helpful to explain the difference between equity and equality. Is that okay?
Yeah, absolutely.
I think often of this, it was almost a comic that I saw many, many years ago. There's a baseball game in the distance, there's a fence, and there are two boys trying to look over the fence to watch the baseball game. Equality is that both of them are at the fence. The taller boy, but I should have said, the boys are different heights. One is much taller and can see over the fence. The taller boy goes and gets a crate and puts a crate on the ground so that the shorter boy can also look over the fence. Equality is that they're both at the fence. Equity is the path so that they could both look over the fence at the same time. So when we are talking in these forums about health equity, what we are implicitly saying is that people face different barriers due to socioeconomic status, due to rural versus urban, due to all of these reasons that if we do not acknowledge, if we do not fully appreciate the challenge, we will not design the right solutions. So I just want to say what we mean when we say equity over and over and over again, because I think that unless we draw out the definition, people might not understand why we're solving for it. So let me step off my soapbox now and address your point. In those 5 priority actions that I said, equity is deeply, deeply implicit. I will point you all to a second resource. The White House Cancer Moonshot website has a list of fact sheets. Those fact sheets spell out all the new announcements coming from both our federal partners and the private sector to support our work. And you will see implicit in them, particularly from the CDC, the Centers for Disease Control, the VA, so many of our partners who are designing programs to address equity gaps. So it is absolutely implicit in our work, in our goals, and in our deliverables. And I know I said it already, but navigation, I think, speaks volumes to this. Because, like I said, navigation has been, all of us have said it who have been on the stage, has been proven to reduce those systemic and structural barriers that have kept certain groups not able to achieve the same benefits as others.
Well, thank you so much. We love the Cancer Moonshot. We love the work and the challenge, really, that the president set forward. And just want everybody to know that Annabella and the rest of the team over there at the Cancer Moonshot have been deeply committed and has worked closely with us as we try to get into various communities and make a difference. So I want to thank you so much.
Absolutely. Dr. Puckrian, thank you. And thank you all for the work that you're doing.
Hello, good morning, everyone. Can you hear me? My name is Anna Norton, and I am the president of the Center for Sustainable Healthcare Quality and Equity at the National Minority Quality Forum, and I'll be moderating today's session, The Community Experience with Cancer Care. I would like to introduce this very esteemed, and I'm very honored to actually introduce this esteemed panel today because they are the nitty and gritty of cancer care in this country. To my right, I will introduce Dr. Helen Arteaga Landaverde. She is the CEO of New York City Health Hospitals in Elmhurst, New York. To her right, Joette Walters, CEO of Tuba City, Arizona, of Tuba City Regional Healthcare Corporation, representing the Navajo Nation. To her right, Lindsay Livingston of Houston, Texas, founder and executive director of Survivor. And finally, but certainly not least, Arthur Woodson, activist and advocate, F3, Flint, Michigan. We've heard a lot about Arthur Woodson yesterday and today, and the work that he's doing in Flint, Michigan. So I would like to start by having all of you please share a little bit about the work that you're doing and what your community has experienced in cancer care over the last several years, and what you are doing in your communities to share about that work.
So good morning, everyone. I hope everyone's super caffeinated. I'm coming from New York, so we are hyper already. And I'm in a hospital, so, you know, we start early. So for me now, it's like midday. So one of the things that we do at Elmhurst Hospital is, you know, as you know, Elmhurst Hospital, we were the epicenter of the epicenter. So our lives are like pre-COVID, post-COVID. And one of the things now that we can call COVID part of the endemic, right now we're trying to get our patients back to our hospital, getting back them to their care, getting over the fear. Because believe it or not, communities of color still are traumatized from what everything has happened in the pandemic. You know, when I know the young lady was speaking about the equity issue, about the fence, you know, in communities of colors where we serve at Elmhurst Hospital, that fence is not even a fence. Right now we have a cemented wall. And that's what the pandemic did for us. Not only did it show us we didn't get to see the baseball game, it said we weren't allowed to be in the baseball game. And I think one of the things that we do at Elmhurst Hospital is making sure that we break down that cement wall. We don't even want a fence. So for us, when we serve 1 million people a year at our hospital, we take that seriously. So any decision we make affects 1 million people a year. And in our outpatient services, we do about 700,000 visits. And I have my team here who do that work. So it definitely takes a team. But when we look at our size and we look at our population, and out of that 1 million people we serve, 64% of them come from foreign communities, foreign countries. So that means the first time they're reaching the healthcare system is with us. So you take the pandemic, you take the equity issues, you take being from culturally diverse communities. And at Elmhurst, we speak 125 different languages. Just FYI, we speak more languages than Google. Google only translates 109. We do 125. Google's gonna catch up to me any minute. So when we look at our cancer work, we saw it was a huge disparity issue, and we wanted to make sure we started addressing it. And the work that we've done with great partners that we have here, Gary, he's been an amazing partner for us as well. We looked at what's one way we can help. So definitely colon cancer was one. Lung cancer was our major one that we just started this year. When we look at the things we've done around lung cancer, it's huge. You know, with the pandemic, a lot of people were smoking and then only make smoking more of an addictive pattern. So when we looked, how can we help? It literally started by just, let's do the screenings. So we had to get the physicians on board, created a process in place. And believe it or not, all that boring work was really what's making us successful now. I'm happy to report that we've had 96 patients go through the lung cancer screenings, and we'll be able to get these individuals from detection to screening to diagnosis to on a healing journey. And when you take a community of color that has never had this type of like complete continuum of care, because remember, in our communities, we don't have a fence, we have a cement wall. And so the fact that we were able to drill just a little hole in this world of cancer was a huge thing for our hospital. Because not only did the patient feel not only safe and connected, we actually took the patient everything from every single step. And for being a public hospital with low resources and taking this community from, again, from the diagnosing, from the screening, all the way to back to healing is a huge thing for us. But again, we couldn't have done it without the partners in this room. So we're really excited to be here, and hopefully we can share some of our lessons learned.
Thank you, Helen. Actually, I wanted to mention, you know, Annabella Espira, she mentioned some of the action items of the Cancer Moonshot, and one of them is expanding access to care screenings. And Elmhurst is already doing that, right? So that is something that's really transformative and grassroots, and something that's already happening. So that's something to really think about when we think about what communities are already doing. And something that really has to be thought about when we're thinking about what we are doing on such a small scale and what can be done. When we think about payers, when we think about what partners can do, what we think about what funding can do. And I think about what this panel does and how that can really affect change. And I want everyone in this audience and everyone that is watching on the live stream about what you can do. And what Dr. Puckrin said earlier this morning, you know, we have all of your emails. So we will be reaching out after this. And what can you do to continue to affect this change and to transform lives in communities that need it the most? So I will continue to move down the line. Joette, please tell us about what you're doing, the innovation that you're creating, because what you're doing for the Navajo Nation is very, very important as well.
Good morning, Yate. I'm Joette Walters, the CEO of Tuba City Regional Healthcare Corporation. We are a 73-bed hospital, but a very big health system serving the western part of the greater Navajo Nation located in northern Arizona. In 2019, we opened the first cancer center in the lower 48 states on an Indian reservation. We understand we are the first and the only organization to do that. Prior to that, our patients would go greater than 150 miles round trip to get cancer care, and that's a personal story for me as well as my family's had that impact. So the innovation was, this is the first time. There was a reason for that though. Back in the 1950s and 60s, the United States, the federal government had started doing uranium mining to support the war efforts. Those uranium mines then since have been abandoned, and they continue to remain abandoned, uncovered and open. And since then, we've seen a high incidence of cancer among our Native people, particularly Navajo. And so the need was there. We were seeing high cancer incidence. We didn't have a cancer center that was local. And so we decided, our board of directors and then the CEO at the time, Ms. Lynette Bonar, I'd be remiss if I didn't mention her name here. She opened and helped develop the first cancer center in the lower 48 states. Since then, we've been able to serve 900 unique patients coming to our center. So parts of the innovation is two things. One, we need to bring cancer care home, not just geographically, but also home in terms of cultural sensitivities that we can provide. Our Native people, our own Navajo nurses, doctors, physicians, are able to provide that cancer care in a more culturally sensitive way, speaking the language, knowing the beliefs and the customs of our community and our people. So that's what we've been doing for the last 5 years. Where there are still obstacles, that brick fence, the cement wall continues to remain because there are still some structural pieces that need to be addressed before we can continue to add more treatments, add more modalities that our patients need. And so there's still certain cancer cares that we can't provide, pediatric cancers, neurologic, specialized OBGYN type cancers. They still have to go outside of our reservation to get that care. Thank you.
Lindsay.
Good morning. Good morning. I'm Lindsay Livingston. Thank you. Good morning. I'm Lindsay Livingston, the founder of Survive Her. I think it'll be important that you understand my why I am involved in community work. I am a triple negative stage 2B breast cancer survivor. I celebrate 4 years of survivorship next month. I underwent 15 rounds of neoadjuvant chemotherapy, bilateral breast mastectomy. I learned I carried the BRCA1 gene mutation, had ovaries and fallopian tubes removed all within the span of 15 months. And after I underwent surgeries and treatment, COVID happened. And so I had to make a purposeful pivot from working in media to work that would make an impact in my community. So I founded Survive Her to inform, inspire, and empower women, especially those who looked like me, because I was very ignorant of breast cancer. I had no idea that I had a family history of it. And so my goal was to educate, because I know there's power in information. And so the work we do through Survive Her, I have pamphlets if you like more information. The work we do is to support her, impact her, and offer wellness for her. So that support model looks like offering access to screenings. Early prevention saved my life. Early detection saved my life. I discovered the lump in my right breast. I immediately took action. So I understand for women that mammogram could mean life or death. So we offer access to screenings. We partner with community-based organizations. We support women financially, underserved women to pay for mammograms, and we're in the communities really galvanizing and mobilizing around screening. And education, we partner with organizations to provide genetic testing and genetic testing kits. Under that Impact Her pillar, we are in the communities. Our successful model has been hosting lifestyle-based events. So we meet women where they are. We host a breast cancer awareness brunch during the Essence Festival, which is the largest convening of Black women in New Orleans. So we're educating while they're sipping their mimosas. We host a health fair, a block party in the heart of Harlem, New York City, at which NMQF has been a part of that, tabling. We have also hosted a huge soiree in the city of Houston to bring our community partners together. And then our Wellness for Her pillar is hosting, I understand the importance of living a healthy lifestyle as a survivor. So we host a yoga experience, which was led most recently by our Houston's Mayor Pro Tem. She led that yoga experience with our survivors. We host spin events, wellness events. So our model is all about educating meeting women where they are, in those community moments, but offering the access to treatments. So if you're at a brunch event, we may have a table on the side at which you can sign up for a mammogram, or you can sign up for our financial assistance to pay for a mammogram. So our model is all about informing, inspiring, and empowering women, not only around early detection, risk reduction, but genetic testing.
Thank you, Lindsay. Arthur.
Good morning. Name is Arthur Woodson. Let me start off by thanking Vice President Harris, because she made a promise when she came to Flint to me that she was going to help us with what was going on in Flint, and connected us with Cancer Moonshot, and Cancer Moonshot connected us with National Minority Equality Forum. And from there, National Minority Equality Forum took off with 2 health fairs, 2 planning sessions, and they have been there for resources for me to be able to call. The narrative has been put out that the Flint water crisis is over. It's not. Our water is still not safe. This is what got me going. When they put the narrative out there, it was just lead. We had TTHM in our water. When we had TTHM in our water, I'm a veteran advocate also. In 2013, I was helping a veteran that was stationed in Camp Lejeune, where they had TTHM. So in 2016, I started seeing multiple myeloma, I started seeing leukemia, I started seeing non-Hodgkin's. By us having TTHM, that's the data that I needed. And I didn't need data to tell me that we have an issue. I know that Camp Lejeune had an issue with the same thing we were having. Every day, I am getting phone calls about someone having multiple myeloma. I found 10 patients in one block within 20 houses, multiple myeloma, leukemia, non-Hodgkin's. It's aggressive. You diagnose January, you're dead in June. I got a phone call right before Thanksgiving. My friend's sister, she was diagnosed with multiple myeloma in August of last year. She died the day before Thanksgiving. I got a phone call, a lady that was supposed to do the press conference yesterday. She was in the hospital the night before, spitting up blood. She was diagnosed with breast cancer last year, non-Hodgkin's this year. It's a lot of questions to be answered in the city of Flint. Me, myself, I'm like Dr. Puckrin. I'm tired of meetings. Everything is there. You all are there. Everybody is there. Why do we have to keep on having meetings when we have the technology, when we have everything else? I shouldn't have to keep asking. If I ask more than once, I'm begging. You might not like the way that I go about doing things. You might not like the way that I say things. You might not like the way that I address things. But in order for us to get things done, in order for Flint to get the things that we need, we have to speak bold. We have to ask. We have to tell you, hey, listen, you're missing what I'm saying, because your vision is not the vision that I encaptured. You take my vision and then you do it yourself. And then that's where we have the conflict. It's about the people. It's not about you. It's not about anything else. It's about the patients. That's it. That's all we need to see. It's the patients. So if you can, I'm begging, because I'm asking more than once, because I've been up here twice. I'm begging now. Can you all please help the people? Can you please come together? Can you please get with the people who bring you in the community? Because it's a lot of organizations, it's a lot of people that just want money. They don't care about the people. They just want the money. If somebody brings you into the community, work with them. Work with them. They are the ones that's dedicated. They are the ones that's looking out for the people. Work with them. Don't drop them off once they get you in the community. Don't drop them off, because you're going to end up coming into a territory that you know nothing about, and it's like a mafia up in there. I'm serious. We know how to navigate that community. Once you fix that one underserved community, you basically done fixed all of them, because all of us have the same story. So please, I don't want to talk too long. Please, would you please help us? Thank you.
Thank you, Arthur. I want to bring it to Joette, just to piggyback on what you're talking about, Arthur. You're talking about a toxic environment, the environmental exposures of Flint. And Joette referenced the uranium crisis on the reservation. So Joette, can you share with us what your community has done to navigate that crisis, and perhaps shed some community perspective with Arthur, and what maybe he can bring back to his community members in Flint as he navigates this challenge?
Thank you. Thank you, Mr. Woodson. That was very important. I think people fail to understand or fail to recognize that the community has the answers. They know their community. They know what the community needs. When it comes to uranium mining in Tuba City, in the area that surrounds Tuba City and the western region, this problem has been taken to Congress. EPA is involved, but nothing's been done yet. So we opened a cancer center and other things that have, I'm going to go a little bit more into this. Some of the other things that we've done that remains a barrier. One is we still have the issue with the uranium mines not getting fixed, not getting covered, there's a lot of conversations, but we still haven't seen change. Other things that our cancer center struggles with is reimbursement. We are part of the Indian Health Service. We have a compact with the IHS, or Indian Health Service. So we act in lieu of the IHS to care for the beneficiaries, which are the Native American tribes that we serve in the region. There are payment reimbursement issues that we're tackling. And so there's inequities there. There's also issues with getting providers to rural areas. And so we struggle with getting providers. We work with a lot of contractors, and of course when COVID happened, that's become all the more. We've lost a lot of people with the resignation of some of our providers. You know, this COVID just devastated so much of our healthcare infrastructure there. Data is another area of where we don't get to see over the fence because we're not counted. We're not included in data, or we're misrepresented in the data, lumped into maybe Indian or Native American or other. It doesn't specify Navajo or the different tribes that are affected. So there's a lot of ways that we've been affected and those challenges that remain. And so I don't know that I answered the entire question, but I think I wanted to make a point to say that there are so many of those things that we've been saying to Congress, to CMS, to a lot of our legislators, to say, we need help. We need, in order for my healthcare organization to continue to have cancer care, to provide the cancer care, we need to overcome a lot of those barriers to solve those issues around reimbursement, to get counted in the data so we can give folks a clear picture of what's happening, a better picture. And so until then, I think we're going to, hopefully we're not the only Native American community that has a cancer center. There are many more Native Americans across the nation, across the United States, that have the same challenges. And we don't want to be the only one or the last one.
Thank you. So what we're hearing is that we're partly there, right? We're not even halfway there. Yes, Arthur.
Real quick, I have an axe. The axe is like a one-stop shop because you have to navigate through automated systems and the people are already frustrated. So can we get a better line to get to navigators or financial aid? Can we get things in writing like a care sheet where if I have cancer, kidney cancer, this is the number. Where I have rare blood cancer, this is the number. Where I have this is the number. We need something similar to a one-stop shop because there's so many different cancers and people don't have the patience to navigate a health system that's so huge. So that's one. Can we get doctors that specialize in certain waterborne carcinogen cancers, rare blood cancers? Can we get funding, for early detection? Because y'all say early detection is the main key to helping survive the cancer. But we don't have the money or the financing to be able to get early detection in for rare blood cancer if it's a serious problem in the city of Flint or Houston, Texas, or carcinogens. It's a lot of different things that we need, and that's why I'm begging everybody, can we just be all hands on deck and help in the underserved communities?
Well, that raises a really great opportunity for both Helen and Lindsay to share about the work that they're doing in both New York City and in Houston, and talking about the community. I mean, Helen referenced, a hospital that's serving a community that speaks over 120 languages, and Lindsay talking about meeting the community exactly where they are. So if you can shed some perspective about meeting a community where they are. And Helen, you can talk specifically about the lung cancer program that you're working on right now, like in the works the moment that we're speaking. And Lindsay, about that your work doing in Houston, and you can talk, in
Lindsay, so I really had to commend all the work that everyone does here and in the panel. I think at the hospital, we could be so big, and yet sometimes nothing is simple in a hospital. So, I'm with you. I wish we could have a one-liner, one number, but, a hospital our size and our health system our size, because Elmhurst Hospital is part of a network. So we're 10 hospitals. We're 10 public hospitals in New York City. And when you look about what we're trying to do, and what the borough of Queens could be a little different from the borough of Brooklyn, and it could be a little different from the borough of the Bronx. So when we try to think of streamlining some of our things, we also have to be very flexible in when we streamline, and I think that's what makes the lung cancer program so unique. We saw a need, we saw a disparity, we saw no one was really addressing this, and we wanted to do it in a way that was equitable for our community. And we didn't say, oh, let's us create it. We asked community members, we asked patients who had lung cancer, or those who weren't aware, and we had focus groups, and we had physicians come on board and say, what does this program look like? So the hospital didn't create it. The patients and the physicians created it. Because we also have to understand the community, the patient, the caregiver is also part of this as well. So I think when we look at our lung cancer program, it wasn't created by the hospital, the community created it. And it took us a little bit to get it up and running, but when I see these 96 patients now on their health journey, they feel complete. They felt not alone. And I think that's why we're all here this morning, because I know a lot of us are very busy. Our schedules are packed. We probably left loved ones at home, had to travel, had to cancel meetings, came here. I mean, we really came here because we want to be the call of action. Because I think all of us have been either asking way too much. We're also begging, we're begging the state, the federal, the city. And I think we're all here because we want to create some type of action. And for us, especially me as the CEO, I can't remember in the last panel, someone said whatever is in the corner office is the main focus. And I think this is a good reminder of us here today that whatever we set the stone, I mean, most of us are senior leaders in this room. I think we need to say again what the focus is from the corner office to make sure that the lung program that we have at Elmhurst, that I multiply it, that it's not only lung, that I move it to cancer, and that I join forces with my fellow brothers and sisters. You know, I think this was a good reminder for me. But again, how we did the lung cancer program is we asked the community what they needed, and we designed it around them.
As a patient advocate and the leader of a community-based organization, I can tell you we have boots on the ground. We're a tangible organization. There are larger organizations, nationally based organizations, but we are in the streets. We're in Houston. We are in New York City. And the reason why I like to serve New York City is because I lived there for 9 years, so I understand the needs there as well. But one of the challenges we face in order for us to do this critical work to move the needle is funding. And Arthur, I'm going to repeat what you said. In order for us to reach and touch and provide mammograms and screenings and genetic tests to women who have told me personally, I don't have access, I can't afford it. We need funding. And there's power in partnership and collaboration. So if you have an organization that wants to connect directly with women of color, then you can reach out to Survivor. Partnership has made our work even more meaningful and impactful. Last year, our data capture says that we touched 484 lives. That may not sound like a lot, but that's 484 families, 484 mothers and aunts and cousins and sisters who would otherwise not have a chance to get a mammogram or screening. So just think about that collaborative effort, think about funding. If you have an opportunity to fund a CBO, that is what we really need to move the needle. And I look forward to partnering with you further in the work that we do in New York City. We bring together 20+ organizations at a health fair style concept to reach women in the heart of Harlem who, I'm telling you, they forget about a mammogram. They don't schedule their mammograms. They don't know about screenings. They're not educated. And so we need partnership. We need funding.
And I would go back to the partnership too, because our patients, our community members, they know when we don't have it put together. They know, because they would not trust you if they didn't know, like, okay, because the biggest fear when you go to any type of these screening, especially the word cancer, is like, what happens if it's a yes, that you do have cancer? That moment is a very scary moment. So individuals, especially communities of color, where our health literacy rate, forget about our education rates, our health literacy rate is super low. So when you hear you have cancer, the fear is bigger than not knowing. So you prefer not to know. So when our community members come to these events or they reach out to you and you say, hey, go get a mammogram, and they say, oh, what happens if I get a bill? What happens if I get a yes? And if the answer is like, well, we'll talk about it later, that's the biggest turnoff. They know if you haven't put it together, but if the answer is like, I got you, girl, don't worry, here's a taxi, here's a health educator, for us as a community health worker, here's the physician, don't worry about the languages, we got 125, we have a path for you, we'll be with you from like yoga, healing, medication management. They want to hear that piece, not only that we just have your mammogram to get the screening, and I think that's what makes it different too. Because community members will trust you if you are put together. So we need partnership, we need the funding. So I totally agree with her.
Okay. As we wrap it up, I just wanted to mention one last thing that we have not actually brought up, and that is the topic of culture and cancer. And that can be very, very scary for Hispanic, Latino, African American, Native American, Asian American, the word cancer, because of the myth and misconception that comes with the word cancer in our communities. And so meeting our cultures and our races with the word cancer can be very daunting. And so in 2 or 3 words, how do you address your communities when you talk about cancer? And how do you educate there and meet them where they are? If you can just share that. I know it's a loaded question, but just to give some perspective there, because that's very important.
I the first thing for us, you know, Elmhurst Hospital sits in the most diverse district, literally, of the world. So for us, it starts with trust. It starts with that hello, and that hello comes to us in 125 different languages. And for us, that hello is super important, because if we're not able to start that 30-second trust, getting rid of the stigma of cancer and the fear can become very difficult. So for us, we really try to have even though we're a big hospital, we try to be warm. You know, we have, believe it or not, when you walk into our hospitals, and no matter which entryway in our campus, we start with aromatherapy. So you come in, and we have a beautiful, relaxing scent that comes in. So you come in, you know, we're not the Marriott, but we smell like the Marriott. And we have carpets, so, you know, it starts with that, like, I know it's stressful, I know you don't trust me, but hello, come and we're gonna guide you. So it starts with that, and then we start the education. We don't try to throw all the kitchen sink at them, but we start, okay, if you do the screening, this is the path, and we're gonna make sure we follow and hold your hand through the whole continuum of care. So that's how we do it.
Thank you. It's a very good question. I think that was one of the reasons we built the Cancer Center in Tuba City, was so that we could provide that cultural sensitivity that many of our patients don't get when they go away from, when they go off the reservation for care. One of the things that our organization does, well, first of all, trust is really important. Your patients have to trust you if they're going to come, if you're going to enter that dialogue with them. One of the things we have done is we do have, prior to opening Cancer Center, we have an Office of Native and Traditional Medicine. So we have resources for them to seek traditional healers if they need to have those conversations, to connect with somebody who might not practice Western medicine, but traditional Native American Navajo traditions. We also have folks that speak the language. So there's a lot of, just in that language, a lot of things that you can communicate in a hello, in sitting and talking to someone. There's a lot just in that communication, and when you have it in your own language. So we do those things as well. I think one of the things that we are challenged with still is a lot of the inequities around our patients don't have running water. A lot of our patients still don't have running water, do not have the resources to even come to the hospital. In some cases, don't have vehicles. We don't have a lot of paved roads. So having that understanding and trying to help bridge those obstacles that they face is another challenge that our team has to kind of help in building that trust. So those are a lot of challenges that we encounter, but I think giving them the sense that we care about them, we're going to do this as best we can for them, doing it in our language with people who respect the culture is really important.
As we work to mitigate the challenge of reducing the stigma around and the fear around breast cancer, specifically in the Black community, is we just make it fun and exciting to learn about breast cancer. So again, through our community-based lifestyle events, we meet women where they are, so that while they're enjoying a fun activity, they're learning about risk and symptoms. Or if if they're getting a mammogram or a screening, we make that environment fun and exciting and warm and community and familial. There is a lot of fear in the Black community around breast cancer, about mammograms. If I am diagnosed, I will die. Because my aunt so-and-so died of breast cancer, my mom died of breast cancer. They don't know the why, they're not having the conversations about family history. But we say through Survivor, if you are diagnosed, here is what will happen, here is how we can support you. I use my story, my personal testimony, to encourage women, to inspire women, to inform women that I went through it because I detected a mass early, because I took action, and I'm surviving and thriving, and you can too. But that has been really the success rate for us, is just packaging it with a pink bow. That breast cancer is not a death sentence. Breast cancer simply means if you are diagnosed, you can do something about it, you can take action, but early detection is key. So that has been really the success formula for Survivor, and how we're able to really get into the community, the heart of the community, to educate women.
Real quick, trust, transparency, honesty. That's basically it. In Flint, we had the water crisis. While we was having the water crisis, we had COVID. We have been through a lot. They have been through a lot. If they have someone that's consistent in the community, that they know stands on morals, integrity, honesty, and have character, they will listen and trust that individual or that group. And once you have that, you have them. You're able to talk to them. You're able to work with them. You're able to come to them. They want to know about cancer. They want to know if they have cancer. But they want to know that somebody that they're dealing with that's honest and that's going to be there to the end. That's going to hold their hand to the end. So I'll wrap that up.
Perfect to wrap up. Thank you so much. I understand you guys have a 5-minute break now. So thank you so much. We are on schedule. Thank you. Thank you, everyone, so much.
If we could have everyone start to make their way back to their seats for the next panel. If we could have everyone please start to make their way back to their seats for the next panel. Thank you.
I don't work here. Huh?
Hope you don't mimic my voice.
Sounds like a greeting. Hey, hi.
Hey, hi. Hey, hi.
Please take your seats. We intend to start on time with our next session.
Morning.
Again, if you can please take your seats, we'll begin the next session on artificial intelligence for cancer care equity in 1 minute.
Good morning, everyone. My name is Dilip Mahaske. I recently joined with NMQF as a director for AI and data science. I really want to start with thanking all the panelists coming here. We have Darlington coming from all the way Accra. Then we have Dr. Marvison coming from South Africa. And then we got really walkable distance, Dr. Sebastian and Dr. Margaret. The idea here is if Darlington and Dr. Marvison is going to do the AI work in Africa, and when we compare Africa's resources with the United States, the disparity between the resource allocation is really completely different. If they can do it, why can't we here? Why can't we start here? So I want to give a global perspective from Dr. Sebastian, like Eagle perspective. They are the one who are building the policies for worldwide, all the countries, and then really deep down research by Dr. Margaret, and then case studies from Dr. Marvison and Darlington. I want to quote Dr. Arthur. He said, "Please help us," from Flint. And Lindsay said, her story, life story. In my own family, last 3 years, we had 3 days because of the cancer. I just lost my brother-in-law like last month, 38-year-old stomach cancer. So these are most of us in this room has personal stories. And I believe AI is the best innovation in the human history after electricity. And that's where we are bringing all the panelists here. So Dr. Sebastian Garcia Sasso is director at Department of Evidence and Intelligence for Action in Health, which is a WHO's branch. So Dr. Sebastian, please take a podium. Thank you.
Thank you very much, Dilip, and thank you for considering the World Health Organization and the Pan American Health Organization to participate in this very important event. It's a pleasure, it's an honor really to be here and be able to speak on something that has become one of the most highly demanded technical cooperation activities with a significant growth of the past few, I would say, years, but it's mostly months from all countries around the world. So it's something that's catch up now, because we know it's not new. It's been with us for quite some time, decades even. And we've developed this, but now it's catch the eye of the public. So it's really a good time now to discuss how do we take this globally and regionally, and of course in each one and every country, to a point where then we're able to use it to harness the power of science and harness the power of these technologies that we have currently available. And that's what I'm going to focus a little bit now on, this global perspective, on a little bit of the landscape and how do we present this, and how after these few months of very intense dialogue and discussions in countries and with countries, we've come up with tools, guidelines, and elements that can support countries to develop an agenda on how to harness this technology's power, so that we all move towards this collective goal of achieving health for all. So how do we speak of the use of these technologies to reduce inequalities? Because we've made great progress globally. We know we've improved the health of many over the last few decades, but how do we reach those that haven't been reached by this progress? How do we make sure that everyone benefits by this technology, by the science that we have currently, and of course, by better outcomes overall? And what does this mean for care equity in cancer? And what are this vision that we share at the Pan American Health Organization and the World Health Organization, with some final reflections to lead to the following presentation. So I don't need to go very deep into health inequalities. They exist everywhere. They are in every single country, they are in every single setting. But we do need to be aware of what generates this. What are the drivers of these inequalities? And how do we first identify them? So if we don't see them, if we don't know they're there, it's very hard to tackle them. And how do we then make efforts to close them, to bridge them with the available resources? So this is very important to understand that it's not the same everywhere. So in a region like the Americas, going all the way from Canada, the US, all the way to Argentina, and the Caribbean, So we have many different contexts, and in each and every one of these contexts, we have different inequalities and different drivers that we need to understand, and different populations that we need to bring into the analysis, into the available information, so that we're able to better serve them. And in all of this, artificial intelligence and other emerging technologies that are associated then give a unique opportunity to be able to identify this and to improve services and access to these services so that we reach a more equitable, accessible, and personalized care, especially in underserved communities. So this is a massive landscape. This is all of the things that are happening and have been happening for some time now in terms of using technologies and using artificial intelligence as a transformative agent to reduce health inequalities. From access and equity monitoring, how we can now analyze health service utilization patterns, data that has been around for many years, but now we have the power to really dig into that data and find those elements that we weren't able to do. And we've been able also to use this in settings where we didn't have that capacity before as well. We're better able to find disparities in access to care. And this is also better able, or we're better able now to transform this into policy and into action, to translate this. So it's not just enough with having the data and having the analysis for a few to understand and maybe give a very important lecture on this, but we also need to translate this into something that we can all share and transform it collectively into policy. It's also very important on how algorithms can rapidly analyze medical data. So not just admin data on access, but also medical data. And this has led in a very short time to improving diagnostics, to have early detection and early intervention associated and link in the paths of care. And this is especially important in areas where we might not have enough specialists. And this happens in all countries. So it's not just a poor country's problem, it's something that we see everywhere. We also see and have this very important focus on AI-powered tools that can provide real-time translation services. So now we see more people accessing information, accessing evidence, because they can use these tools and engage with data, with knowledge, and use it for better personal decisions. These tools can also, and we've seen how they can be trained to recognize and adapt to also incorporate cultural issues and adapt it so that we're better able to transmit messages to populations that have been marginalized in access to this vital information and vital knowledge for decision making. Now, this is how we see this integration of many of these initiatives and how this brings into a cycle. And we can do diagnostic enhancement and treatment processes so that we are better able to suit populations. For example, we've all seen it with radiology and imaging lectures, and how this improves not only access so that we can process more image studies and at a faster rate, but also in places where we don't have that capacity. Now we have screening. And this applies for many areas, and particularly in cancer and what we want to do in terms of reaching more and making sure that everyone is diagnosed in time and has access to treatment in time. Well, this is a huge difference. We've worked now very closely with genomic characterization and drug discovery using AI. And this has sped up processes intensely. And now we have more research groups working on this globally. We have worked on policy and regulation implications. So what does this mean in a collective environment in which we need to make sure that what we put out has the quality and the safety so that we can all benefit from that access? And this also involves speeding up on digital literacy, on what is required for people to really engage with these technologies and make the best use of this, including healthcare professionals. There's a strong resistance in many health professions on the use of these emerging technologies. We need to build trust. And sometimes we forget that this is very important also with specific populations, not just the general trust on technology, but how is this perceived in particular populations that may have particular considerations on the use of these emerging tools. And we need to always ensure transparency, as we do in many other things, but also in AI applications. And this is linked to building something that is being described as a diverse research community. So not just focalizing in some opportunities or groups, but making it as diverse as possible so that we incorporate experiences from across the field. And I celebrate that here we have, just in this panel, several initiatives and experiences that come together to build this research community. And I end with the beginning, which is an element that needs to be present for all of the other possibilities to exist. And we all need to understand, as we've had with many other technology implementations, that if we don't consider for potential bias, then we are risking leaving people behind, we're risking creating damage. And this links to being transparent on how we produce AI and how we use AI. And for example, just in treatment, we've now known that applying an algorithm may produce different results and recommendations for different populations. How is this linked then to the capacity of those people using the technology to incorporate this and make sure that the decision based on AI tools is transparent and it's controlled in terms of bias? This links to what member states have recognized and have aligned to and adopted over the last 3 years, regionally and globally, defining 8 guiding principles for the digital transformation of healthcare as a mechanism to speed up processes that are way underway for decades in many of the countries in the Americas, and that propose as one of these areas of prioritized work and accelerated implementation, the use of artificial intelligence and the development of artificial intelligence within local contexts and having particular populations in place. So I don't know, you're not seeing it, but here you can access all of these documents. You have the QR codes for this. It explains some of these guidelines and elements that countries are incorporated in local legislations, in particular program policies, in research initiatives, and that help then build this shared environment in which countries can all develop and participate. Some final reflections on equity in AI development. We need to make sure that we serve all communities in this fast-paced development. We need to make sure that models are trained with data from people in every place. And that means looking and identifying those in underserved areas, underserved places where we might not be including them. And this is something that we've seen with clinical trials before, and this is something that we've seen with many other examples, but we need to make sure that this is, from the very beginning, incorporated in our policies on how we use and how we train artificial intelligence. We need to make sure that models incorporate diverse data sets from different regions and making sure that the ethical principles on how we engage with the technology are at the center. And if we are to make artificial intelligence truly a force for good, and particularly in cancer treatment, we need to broaden the scope of data collection, and I'm sure this has been at the center of the discussions of this forum as well. These are 5 publications and guidelines that have come out over the last few months from the World Health Organization and the Pan American Health Organization to guide countries, research institutions, partners, and others in how to engage this. how to engage with this topic and how to do it in a way that we have ethics, that we have transparency, and that we have equity at the center of what we do. With this, I thank you, and I have the great opportunity to invite my colleague, panelist, Margaret Bjarnadottir, to the stage. She's an associate professor of management, science and statistics at the University of Maryland, and she's also a member of the Center for Digital Health and Artificial Intelligence at Johns Hopkins University. And as a side note, she's also the founder of a pay equity startup called Pay Analytics. So welcome, Margaret.
Thank you. Thank you so much. First of all, I'm super honored to be in this room, in the presence of so many people making actually a real difference. So I just wanted to state that. So I've been doing machine learning and AI for 20 years, always in the context of social good. So how do we use data to make better decisions for problems that have social impact? And Sebastian kind of perfectly laid things up for me, so thank you. So I was allotted 10 minutes, and let me take a look at my clock so I stay within my limits. So what I wanted to do with my 10 minutes was to dive a little bit deeper. So it was like now we have the overview of AI and what AI can do. So what I wanted to do was to take you on a journey of kind of my journey of AI in healthcare and get a little bit more specific. So hopefully that can give you some ideas about what machine learning and AI can do in terms of cancer and equity and etc. So I'm an internal optimist. So my first slide says perils and promise of AI in healthcare, but really I'm going to stick to the promise of AI and ML in healthcare because we have gone through a transformation. I don't think anyone here believes nowadays that we can, take data and run a model and everything will be awesome. We are all aware of that data is biased, our modeling decisions are biased, and therefore, when we create these systems, we need to be aware of it and account for it. So I think there's a great promise. So, to take you on a little bit of a deeper dive into some of my work. So this is one of my early papers, just out of my PhD. And here, we wanted to provide a comprehensive view of colorectal cancer survival. And why were we focused on a comprehensive? Why was that the theme of this research? Because as an academic, so I'm a data nerd. I'm not a physician. I don't know a lot of medicine. One of my physicians that I worked with actually once gave me the Bible of internal medicine. It totally put me to sleep. So what do we do as an academic, as a non-physician, when we are trying to understand these problems? Well, we go to the academic literature, right? So we were trying to understand colorectal cancer mortality. So we went to the literature and we found that Caucasian patients are significantly different according to a study. But then there was another study that said race is not significant. Okay, so then, well, we took a look, and young patients are different from older patients, but then there's another paper that says there's no difference between young and old patients, right? And merits is significant when it comes to survival, says one paper, but then there's another paper that says, oh, it doesn't matter. Right? So this is how we end up. We have no idea what's going on, right? So what we really wanted to do was to provide this comprehensive modeling approach that could understand what's important, not only at like one point in time, but across different time horizons. So that's what we did. So we were seeking a comprehensive understanding. And one of the things that we found was that different things are important for different time horizons, right? So are we looking at 30-day survival, or are we looking at 5 years survival? So we found, for example, obvious, probably to all of you in this room, that the stage of the disease is important, whether we're looking at 30-day survival or 5 years survival. But other things like disposition or chemotherapy is important when we look at specific time horizons. So another thing that we found was, I can pause. I'm okay. So another thing that we found, and this was a study done in collaboration with Stanford Medical, And this was in part motivated that we saw overuse of chemotherapy in the last 30 days of life. So what we found, and this picture is not important. If you know data science, you can read what this means. But what we found is that what we can do with our models is that we can be very accurate for a subset of the population. So we can't predict mortality for everybody with great accuracy, but there are for certain people, we can say very accurately both whether they are very, very likely to survive 30 days or 5 years, and vice versa. We can be very accurate about a set of the population that is not going to survive 30 days or 5 years, right? So for these sets or these parts of the populations, we can then start thinking about, okay, how can our models then inform clinical decision making, right? And all of this came from this idea that we wanted to help avoid overuse of chemotherapy in the very last days of life. So I'm going to move on. So that was one of my early works. So then we have a couple of papers talking about and kind of spreading what we need to know about AI bias. And Sebastian has already talked about this. So in 2019, the Oppenmeier paper was probably the most famous paper, or most infamous paper of AI gone wrong in healthcare, right? So I think everybody's eyes are open. In fact, I'm going to show you this picture. This picture. So I've been doing machine learning and educating students about machine learning for 20 years, right? And when I started doing AI in healthcare, we were kind of at the left-hand side of this graph, right? We knew nothing, right? We were just excited about machine learning, right? But then, you know, as our awareness has grown, nowadays it's simply not acceptable to build a machine learning model that is biased. If you do, you know, you need to do better. So I think we are spreading the word. We are educating our data scientists to do better, right? So I think we can move on to then talking about, okay, how do we build AI models in today's world? And what we are doing together with you know, a lot of collaborators is actually building a framework around how can we use AI to quantify and set a framework to discuss the health inequities in cancer, right? So we know that there are all of these correlated factors that actually affect how these inequities and why they happen, right? And with all of these correlated factors, you know, access, education, you know, screening, you know, the list goes on. How do we, you know, grapple with it and put up a framework so we can start talking about, oh, you know, this is the absolute difference in cancer survival, let's say, then what explains this difference, right? And what we are doing in this paper, we are saying, okay, here's the absolute difference. Now let me take all the different things that can explain these differences and see what impact they have. And then after I have accounted for all of these different factors, is there still unexplained differences that we can then start thinking about as systematic biases in decision making, etc., and start to get at the root of that problem. So that's what I'm doing now, and I've been very inspired by some of the discussions this morning, thinking about, you know, how can we use AI not only to make better decisions, but at scale quantify the inequities. So there's a lot of, you know, conversations about access, right? So we can use AI at scale to look at the access barriers and difference in treatments and map those out. So I'm very excited about the work ahead. I'm honored again to be in this room, and I'm even more honored to then introduce our next speaker, Dr. Nneka Mobison. I hope I didn't butcher that too badly. She's the founder and CEO of MDoc that provides AI-enabled self-care solution. She was previously the executive director for Africa at the Institute for Healthcare Improvement. She's a trained pediatric physician. She has been at McKinsey, the World Bank, Merck, CDC. The list goes on. So it's my pleasure to introduce Dr. Mobison.
Thank you so much, Prof, and also a huge thank you to then MQF. It's a real pleasure to be here, and it's a pleasure to be here as a Nigerian American who grew up in Nigeria, trained here, did a lot of work here, and then went back to the continent. I've often felt frustrated that we're not working together across the oceans to collectively try to address the challenges that are all facing us as humans. So it's a real pleasure, and I'm really particularly grateful to Dilip for having the audacity to bring both Darlington and I here today. So I'll be really sharing about our work at MDOC. I co-founded MDOC really because my father died prematurely, preventably, from complications from a massive stroke that ended his life too soon. And I was frustrated and I was angry when I saw that years later, the status quo hadn't changed. So in terms of, I know that Gary said we really shouldn't talk about the disparities, but I will quickly just highlight for Africa the reality. Because I think a lot of times people think of only a couple of conditions when it comes to the continent and don't often think about cancer or other chronic conditions. The reality is globalization, urbanization, the rise in sedentary lifestyles, exposure to the environmental risk factors that we've talked about today are really setting up a catastrophic burden for our communities across the continent. The Lancet Commission on Oncology predicts that at least 1 million Africans will die prematurely from cancer by 2030, double what we saw in 2020. We conducted a prevalence study with funding actually from Merck, from others, in 2019 that showed that 40 to 60% of women of reproductive age are living with obesity, overweight. And our supply, from a health workforce perspective, it's dwindling by the second. COVID actually has led to more and more of our health workforce leaving Africa and coming here. And so we've really been struggling with that burden. And then when it comes to funding, only 2% of all global funding has gone to chronic conditions, and included in that is cancer. And so the reality is we really just don't have the ecosystem that we need to support people living with chronic conditions such as cancer. Just wanted to share with you just some data from the prevalence study that I mentioned. 75 to 86% of women had never had their breasts examined by a healthcare worker. It was worse when it came to cervical cancer screening. 88 to 94% of women had never been screened for cervical cancer. This is in Lagos and Abuja, which are big cities in the most populous country in Africa. And yet, when it came to HIV, 60 to 70% of women had been screened for HIV. Now, if we know about some of the funding initiatives, a lot of funding went into HIV years ago. So just showing when investment is made, access can happen. And we've heard about kind of the ask for funding to really make a difference. So that's where we come in. I co-founded MDOC to essentially optimize the end-to-end self-care experience for people living with or at risk for chronic health conditions, leveraging quality improvement methodology, so think Lean Six Sigma, data, technology, as well as behavioral science. We leverage a 4-pillar approach to what we call integrated high-tech, high-touch care. So our key platform is Complete Health. It's an omni-channel, AI-enabled platform that provides virtual coaching. We've talked a lot about patient navigation, which has just blown my mind today, because that's exactly what we do. We provide virtual coaching, supporting people, what we used to say for the 99.9% of the time they're out of a healthcare facility, but now we're with them right when they're in the healthcare facility as well, helping them advocate for their health. We also, because we don't prescribe and we don't diagnose, we've created a geocoded directory of healthcare services, facilities, and providers that actually also has a review system aligned with the National Academy of Sciences quality domains, the 6 quality domains, so that our members are able to review their experience of care across those quality domains, so that healthcare providers don't feel defensive, but are actually more motivated to leverage quality improvement to address those specific elements. In addition, we recognize that mobile phone penetration rates are not appropriate proxies for digital literacy. And so we created an in-person experience, essentially community-based nudge hubs, health kiosks, which are not a destination, but rather a pass-by, where people can learn how to work with the digital platform, meet with a coach in person, and a lot of the people that we serve cannot afford monitoring devices, and so there they can track their blood pressure, track their glucose, and meet a friendly face. And then the final piece of what we do is teleeducation. The three pillars are really member-facing, but the fourth pillar is very much provider-facing. We realize as we're investing in digital literacy and health literacy, our members were going to the healthcare facilities and weren't getting the right kind of care at the right time. And so in partnership with University of New Mexico's Project ECHO, we've now trained over 15,000 healthcare workers, not just in Nigeria, but in Kenya, Ghana, South Africa, to really focus on really providing the right kind of care when it comes to cancer, chronic disease, and so much more. Today, we're serving over 110,000 members. Majority make less than $3 a day, so low income. 67% have smartphones, about 82% are women. We prioritize chronic conditions. In terms of our members with cancer, about 80% have metastatic cancer, so they are coming very late stage diagnosis because of the same issues that we've heard about today. And we're doing our best to serve them. In terms of how we work, we partner with other organizations around providing innovative financing mechanisms. We've created a digital affordability algorithm that allows us to leverage other metrics, not the typical income, et cetera, to understand their ability to pay, also understanding that they're surrounded by a community, and that we leverage crowdsourcing in our cultural context to support care. And so therefore, leveraging that to identify what tiers of subsidy they may require from partners such as pharmaceutical companies and corporates. And then we provide AI-enabled self-care support, which I'll get into shortly, through our coaching model, as well as community outreach. Here you see we offer three to four community outreach programs every single week, really meeting people at the churches, at mosques, in the markets, really meeting them, leveraging our roving community ambassadors who carry a backpack of devices and provide cancer screening and other comorbidity screenings right there for them. We work with the police force, customs, etc. This just is a very high-level view into kind of the journey. When they sign up onto our platform, they have access to our AI-enabled chatbot, Kem. Kem, essentially in the Nigerian Igbo language, stands for Nkem. Nkem means my own. And Yoruba language, also Nigerian, it's short for Kemi. Kemi means pamper me, cherish me. And so the idea is really around teaching our members to care for themselves, leveraging the power of technology. And so through our virtual health coaching, every member gets their own dedicated health coach that's backed by a fitness coach, an emotional wellness coach, a nutritionist that provides virtual support to them, digital nudges, health education, appointment reminders, medication adherence support, all of that really around the clock. Our fitness coaches meet with them not just virtually, but also in person at the markets, at the nudge hubs that I highlighted, and we've seen an improvement in terms of the average exercise duration. Not at all close to what WHO is proposing is ideal, but it's a pathway. We also provide emotional wellness guidance, as I highlighted, through our coaches, and then teleeducation collectively so that our members are not walking alone. At MDOC, we are so excited about the power of responsible AI to transform the lives of members living with chronic conditions such as cancer. I can tell you personally, it's allowed me to sleep better at night. So here we go. Sorry, I think I pressed something on the screen. No, okay. Yeah, so how? So we, when COVID hit, literally overnight, we were met by healthcare facilities, members asking us for more than self-care. They were asking us for urgent care, talking about being at the healthcare facilities and gates being closed. And we literally were so worried about our ability to serve them 24/7. And because we kind of created this pathway for digital, everyone was relying on us. And that I could not sleep those nights. And so in that time, we were able to, with funding support, initially build KEM, the chatbot that was initially just rules-based. Because majority of our members, and about 60% of our members with cancer have hypertension, we initially focused on hypertension, really to help us address kind of the expansive inquiries of our members. But there were many limitations with it. It had limited conversational engagement depth, limited multilingual support, scalability issues, and really a dependency on predefined questions and scenarios. We had used the interactions of our members with our coaches to essentially build the bot, but it wasn't sufficient because what we realized is that if you're really supporting a member in her or his journey of care, you have to meet them where they are, means to truly meet them where they are and understand what matters to them at that moment in time. So a grandmother with breast cancer may not want to talk to her coach about her next appointment or how she's feeling about living with cancer. She may want her coach to answer whether she should put palm oil on the umbilicus of her newborn grandbaby. And in order to really meet her where she is, you have to be able to answer that question and support her appropriately. I was having sleepless nights because I was worried about our ability of our coaches to be able to provide that expansive support in an evidence-based, contextualized way. That's where large language models came in. With the advent of generative AI, we've really been able to expand our ability to provide personalized care supports to people around the clock and really answer what matters to them in the most empathetic way. With support from the Bill and Melinda Gates Foundation, HASH, which is a network out of Uganda, as well as Google, we've really been testing the integration of these large language models into KEM and testing for accuracy, completeness, quality, safety, contextualization to the African context, friendliness and equity and gender inclusion, and it's been incredible. In terms of kind of what we focused on, specifically really about KEM's ability to meet people where they are, as I've highlighted, and really answer the expansive nature of their inquiries, the breadth and depth. And then second, KEM's ability to be an intake coordinator when people enroll onto the platform and we're helping them co-create their health goals aligned with their shared goals with their healthcare providers, really helping understand what matters to them at that point in time. KEM has been able to do that. And then the last piece is really serving as a virtual assistant to our health coaches who often get really burnt out because they're dealing with the realities of the lives of their members. We co-design with the members that we serve. It's from them that we learn, and we leverage their input and put that into our models. We have been able to leverage thousands and thousands and thousands of our own interactions between members and coaches to form our data sets, so really reflecting the population we serve to train our models. And we do rapid cycle testing, iterate with our machine learning team and our clinical team, and then test it with our community members. Leverage their feedback and put that back in and go back at it again. Iterate, 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 but always having their voices in what we do. This is just a snapshot of KEM answering in Pidgin English. So today we're able to leverage both Pidgin English, which is one of the key languages in Nigeria, as well as English. And you can see some of kind of their feedback here, as in, wow, so if you reply me for Pidgin, it makes sense, meaning like actually it makes sense. It's replying to me in Pidgin. And I can't tell you how many people would carry the phone and say, please, I want to talk to KEM more. Why must it be written? Can I speak to it? Why can't it start speaking to me? And so many folks have said to us, like, this is going to allow me to have more confidential conversations and really have the access that I've been really wanting more of. So with our early results, we're hugely optimistic and we're seeing in terms of KEM supporting our coaches. To be frank, we're actually seeing KEM doing better than our human coaches across many of the dimensions, across safety, across completeness, across accuracy. And we're expanding that study to look at how large language models in the context of our health workforce shortages can do and potentially provide similarly effective, if not more effective care with the appropriate human guardrails and having the right humans in the loop. We can potentially truly meet people much more appropriately and deliver the outcomes that we're trying to do. You can see here we've been able to show improvements in terms of controlled blood pressure, improvements in treatment duration, improvement in self-efficacy. And so, we're doing this with very limited resources. And so I've learned that from this kind of journey in terms of generative AI, that it's teaching us that building that contextual relevance, cultural sensitivity, and gender inclusiveness, it takes time, it takes iteration, and it takes working with the communities that we serve to build their trust. Also, all of us must become AI literate. I've had real challenges in my team seeing kind of the breakdown from a gender perspective in terms of clinicians all of a sudden feeling very uncomfortable because they're not the smartest people in the room. And so we've had to invest in building their capability in terms of AI literacy and so that they can appropriately pressure test. But truly building that AI literacy is key. So for us, what's next for us is really expanding CHEM's ability to, essentially we're trying to ensure health coaching is now 80% CHEM and 20% human. That will allow us to scale. That will allow us to have impact. That will allow us to ensure that people are living healthier, happier, and more productive lives. In addition, we're going to be leveraging more African languages, leveraging those data sets, so that, and also doing the voice to text features as well that have been asked from our community. Just again, it's a real pleasure to be with you all today. I really want to highlight we can work across oceans to do this. AI really can transform all of our lives, but we've got to be part of the solution to ensure that we ensure a healthier, happier, and more productive world. Thank you. And now, it gives me my greatest pleasure. Sometimes in these journeys, you feel alone, but especially when it comes to AI and the large language model work that we've been doing. But I haven't felt alone because of Darlington Akogo. We've been seeing each other in this AI journey a lot. I consider him my brother. He is a brilliant, he's a founder of Mino Health AI Labs. He is one of the most brilliant people working today as a global leader in the AI space. Talk to him, talk to him, talk to him. He's truly focusing on democratizing quality healthcare for all across the world. So it's my pleasure to have him speak with us today. Thank you.
Hello, everyone. I'm Darlington Akogo, and thanks so much, Neka, for those kind words. We have all types of experiences we can't even see. Yeah, it's been an interesting journey. Okay. So at Mino Health AI Labs, we looked at a number of problems, and that drove us to start working on what we are working on. So if you look at cancer, for example, there are about 800,000 new cancer cases worldwide and about 500,000 deaths. No, this is not even worldwide. This is just in sub-Saharan Africa. If you take specifically breast cancer, you're looking at about 130,000 cases, and cervical cancer over 100,000. And this is responsible for 3/10 of the cancer cases that we have in Africa. The highest breast cancer mortality rate globally is still within the African continent. If you look at other cancers like lung cancer, a man has 1 in 17 chances of developing lung cancer within their lifetime, and for women, it's 1 out of 16. There have been over 2 million cases per year, and then 1.8 million deaths. And in Africa, you are looking at about 45,000 cancer cases and over 41,000 deaths, which is really, really high. Then you have pneumonia. It's one of the single largest cause of infectious death in children. You have tuberculosis, also one of the leading ones. You have malaria, still a big killer. As a matter of fact, more people died from malaria in Africa. Yeah, I don't want to misquote this figure. It's either just only Africa or maybe even globally, but mostly concentrated in Africa than even COVID. So malaria is still a very big deal. So looking at all this problem, we're asking the question, what is the fundamental root cause of this problem? Because if you look at the problem from the branches, then it feels endless and you can never solve it. So fundamentally, we realized that in places that had highest disease prevalence, highest mortality rates, there are two key issues. One is the shortage of clinicians. The other is infrastructure. Infrastructure is an investment problem. Shortage of clinicians is a bit tough because, You can train medical doctors, but as Nneka just said, we're actually losing them. Because, if you can't pay them, and then medical school is no short journey. The population is growing faster than we can train enough clinicians. And this is not an African problem, it's a global problem. And which is why we are getting a lot of people relocating within the medical field, because there's a shortage everywhere. There's a demand for it. So if you look at the numbers, in Ghana, you have 1 doctor for every 11,000 patients. Malawi is 1 doctor for every 60,000. If you take specific domains like radiology, it's 1 radiologist for every 100,000 people in South Africa, and about 800,000 people in Ghana. And Liberia has just about 2 radiologists. So looking at this, we started Mino Health AI Labs. The goal was to automate medical diagnosis, prognosis, forecast, and everything else in healthcare. And that's exactly what we've been doing in the last about 9 years. And so we've worked extensively within the space across the globe and supporting facilities, both to provide them solutions in AI, then also the biomedical research space, where we develop solutions that help with everything from drug discovery to better therapeutics. So one of our key focus tends to be radiology, but then we also work on broadly infectious diseases and even much more broadly biomedical research. So we built this AI platform, the Mino Health AI. So it's available online platform.minohealth.ai. And so this AI system is able to pick up about 14 chest conditions. And one of those conditions are nodules and masses. So this is connected to lung cancer. Our AI system is able to detect this. And then in addition, several other conditions are connected to everything from tuberculosis, pneumonia, and the list goes on and on. So it's a super simple system. You just upload the image, our AI system analyzes it, and then generates a report for you. It's super fast. It takes about 5 seconds for the AI system to look at these radiological images. It is very accurate. We did a clinical study, and also it's very affordable. So with the clinical study, we actually did one of the few AI studies that looked at multi-continental data. So we used data from Ghana, which is Africa, Vietnam, which is Asia, and then USA, which is North America. So we tested our AI system across data from this whole pool on some condition, working with radiologists. So the radiologists generally had 5 to 20 years experience. We tested it against our AI system. This was the result. So the AI system outperforms individual radiologists. But the results are comparable if it's a group of about 4 radiologists working together. But as we said, there's a shortage. You can't have 4 radiologists looking at just one patient globally. That is not feasible. So our AI system is meant to assist clinicians across the board, not just the radiology solution, but it is very important to us that the performance of this AI system is good enough so that it's not just, it's not doing a good job of assisting. So that's why we did this benchmarking test. So we got our AI system certified by FDA Ghana, which also is one of, I think, the only AI standalone system that has probably been certified within Africa, I think so, at least, yeah. So we got it certified, and then, we rolled it out. We had users from around the world, over 50 countries, including the USA, actually. So we got people signing up to our platform, using it. Currently, we are forming partnerships around the world on a national level. So we go into countries and then scale up these AI systems across the country. That's basically what we've been up to. There's our AI system being used in a facility in Ghana. And they mentioned that even tiny nodule masses that they usually wouldn't pick up on because there isn't enough time, the AI system can pick up on it. And if those tends to be cancerous, a life has just been saved. So that is super rewarding to hear such feedback from clinicians. So the goal here is that we are democratizing access to early detection. And if you do that, then it allows for early intervention, which then improves survival rate and quality of life. These are the partners we've worked with on our journey. You have everyone from the Gates Foundation, OpenAI, Facebook, and then universities like Oxford University, Imperial College, and the list goes on. So this is a very important initiative we're involved in. So there's a WHO with other UN agencies initiative. It's called the Global Initiative on AI for Health. And so I chair the topic group on radiology. And so over here we look at, on one hand, developing AI solutions that are relevant within radiology globally, but also developing the global standards, the global regulations, policies along those lines. So we've been doing this for some years now. And this is an initiative we had with Oxford University and 13 partners from around the world. This was especially during the COVID period. We leveraged AI solutions, we built insight, coordinated, even worked with Alcro, which is the team that developed the AstraZeneca vaccine. So worked with them, shared ideas, contacted regulators in Nigeria, in other parts of the world, in the UK, and it was quite a rewarding initiative. And this is an ongoing one we still have. So we are developing a handheld molecular diagnostic device. This is LambTech, so it's comparable to PCR, which you use for COVID and other stuff. But we are developing something much more low cost and much more mobile. So basically, you could go to tiny villages, use this device to test people for malaria or some other infectious disease. So yeah, there's an initiative we have with Imperial College, funded by the UK government. And so we serve as the AI partner on that project, using AI for signal processing, disease forecasting, estimation, and everything else. Yeah, we did some stuff during the COVID period. We set up a platform that tracked COVID across African countries. We've run AI for Tuberculosis Challenge, and then got submissions from over 40 countries, over 1,000 submissions. People develop solutions for TB. Yes, I'm out of time. Yeah, so malaria detection. We've built AI system for malaria. This is the most exciting thing I'm currently working on. So foundation model for healthcare, or as I prefer to call it, AGI for health. So basically, we are building one AI system that can do everything within healthcare. So radiology, microscopy, hematology, oncology, the list goes on. And we've built different versions of this. The current version we're building would probably cut across over 30 specialties in healthcare and do over thousands of tasks, including diagnosis of almost all the cancers. That's what we are going for. Of course, it's still an early version, but this is what we're working on. So this is an example. We passed it, and it's a dialogue system. So imagine like GPT-4, but that's an expert across the health field. That is what we are working on. So we gave it an image, it looked at it, we had a whole conversation. It said it found a nodule. I asked it to explain what it is, what's the difference between pulmonary nodules and benign lung tumors. He explained all of it, and it's going to have expertise way beyond just what I'm currently showing. But yeah, so this is what we are working on. Towards this goal, the goal is build the most powerful AI system in healthcare, or basically build the most powerful system in healthcare and make it available to everyone on the planet. And so to pull that off, we need to work with everyone. And that is the reason why I'm actually here. This conversation and this panel, we didn't have much time, but I wanted to be here just to see who we could work with to pull this off. So we are open for business, we are open for partnership. I'm happy to be here. Thank you.
Thank you very much.
Oh, yeah, so we are now at the Q&A session. No, okay. Oh, no?
Okay, sorry. Due to the time limitations, I just want to thank you, each one of you, and as a NMQF partnership, we want to extend our partnership with you, and let's save some lives, whatever we can do for our way. Thank you, everyone. Thank you.
He's in there.
Hello, Dr. Nguyen, if you can hear us, please turn your camera on.
All right, so the beauty of technology, right? Greatest opportunities and greatest challenge sometimes. So it's a pleasure to be here. And can you hear me? No. Can you hear me? All right, it's great. Well, I will start by thank you all, both here in the room and those that are following us remotely on live stream, for what you do, for your support, for fighting cancer, as a patient, as a healthcare professional, as a researcher, or all of the above, or just as a learner. My name is Salvo Alesci. I lead the Center for Clinical and Social Research at the National Minority Equality Forum. I'm a physician scientist, and today I have the distinct pleasure to moderate the panel on clinician on cancer care and research in underserved community, or probably I should say for underserved community. We set two very clear objectives for this panel discussion. One, it's really present what the current state of inequity in cancer care is with data. We at NMQF are very keen on the importance of data, but perhaps the most powerful data that you have heard today are those that came up from Arthur, in the community. The second objective is really provide some perspective on what clinicians can do, not just to identify barriers to access to modern therapies, diagnostic and treatment, but to address them. And I think that's important. This, for us today, it's a call to action. I could have not asked for a better panel of speakers. I feel that one thing they all have in common is they walk the talk. That's very important. And I don't think I would do justice in any way, shape, or form of introduction that I would do, because their accomplishment has been so much and their impact really on cancer community care that I wouldn't do justice. So I rather you hear from them directly, and hopefully we're going to have a time to bring them all together virtually and physically at the end for a few questions and panel discussion. I can see Dr. Nguyen on the screen, but I don't know if he can hear us. We can't hear you, Dr. Nguyen. Can you hear us?
Dr. Nguyen, if you can hear us, you're muted. Can you hear us, Dr. Nguyen?
I can now. Great. All right. Can we bump up the volume a little bit here? Well, Dr. Nguyen really doesn't need any introduction to begin with, and everyone knows his work and his contributions. He's the director of the VCU Massey Comprehensive Cancer Center. I think the breadth and depth of his expertise, but his also warm approach to cancer care is nothing short of inspiring. So without further adding to that, please, Dr. Nguyen, share a bit of your work and the impact that he's doing.
First of all, good morning, and again, I want to thank the organizers for inviting me here and having me the opportunity to talk a little bit about my work. I know I only have a few minutes to do that. I was going to frame my work in the context of an aha moment, in that while I was certainly at the bench and taking care of patients, it was clear that most of my early research was focused on how do I get a molecule to become a medicine. It turns out that I think that is absolutely critical in the context of the fight against cancer and making an improvement to everyone's life. But it's also that much of what I was doing at the bench was really not getting into the communities that I was really passionate about serving. It turns out that there were, I guess, two influences in my life. One, many, but Harold Peace and Francis Collins. So there was this collision, if you will, of those two worlds of how the basic science actually matters that drives to the translational, but also in my other ear, Dr. Freeman's work, in which how do we get it to the community? In that context, I, over the last X number of years, have really paid a lot of attention, certainly to the biological outcomes and the DNA, but also there's, now an example of that ZNA, that is the Zip Code Neighborhood Association, and why, I'll give you another example of why I've moved, not moved away from, but have expanded beyond just the idea of a zip code. It turns out that for me, and the work that I've done both in Chicago and now in Virginia, that we recognize, as many of you know, that structure matters. It turns out that we all know that. We all know that where you live, the place and space you live, probably has more to predict and determine your outcome than sometimes even your genetic code and the DNA. My work has really been in trying to understand that intersectionality between ZNA and the interplay between the Zip Code Neighborhood Association and the DNA and biological outcomes. In that context, we've done a couple really cool things about, for example, won't show you today, but looking at where people are at high stress levels, if you will, and not only correlating that to essentially their outcomes, but actually what happens from signaling pathways in genetics. An example is with Sage Kim. We have a grant that we've worked on now for a few years in which we're able to show that in Chicago, for example, if you look at the 50 wards, which there are 50 wards of Chicago, that if you look at just solely Black men from the areas that actually have the greatest stress and even the greatest violence, that's not surprising that they have the poorest outcomes on, in this case, lung cancer. We took cortisol levels from barbershops and all the rest of these other things to sort of get there. I think the thing that was surprising, though, for us is that when you look just at Black men and you sort of look at areas of high stress, lower stress, you know, the higher economics, lower economics, all the rest of that, the cluster that had the worst outcomes clearly had the highest stress. But interestingly enough, that we could look at their genetic signals and see that there were disruptions. In most cases, even before they wind up with the cancers, and I'll get to that in a second. Surprising, or maybe not. It turns out that those people who lived in those areas with the highest burden of lung cancer and the poorest outcomes, interestingly enough, African-American men, not even compared to white, actually had things with their cell cycle, their DNA repair, and other things that were already disrupted and deregulated in this group of African-American men, even before they got cancers. Now, the cool part was, we then went back to these same neighborhoods with people with cancer and said, were these genetic signatures, you know, we always say Blacks actually have the worst outcome from lung cancer, particularly Black men. So we took out all the noise and just said, well, let's about Black men living in place and space. It turned out that among this cohort of men, that those people living in the place and space where there was more exposure to stress, more exposure to highways, more exposure to, you can name it. Not only did they have higher stress levels, but we, for the first time, can say that the people, even before they got cancers, had signature changes relative to the group of African-American men that weren't exposed to that as much. But the people with cancer had really robust changes from those neighborhoods that were under the most stress relative of Black men relative to those who were not. This is my first clue into the context that we certainly should focus on our biology, because the reality is biology and DNA does matter, but so does structure. And so I've moved away from talking about African-American men. In this, we can use other groups, but in this case, let's focus on African-American men as an example, as essentially just being more predisposed and just biologically having more predisposure to actually having poorer outcomes in, for example, prostate cancer. Turns out the literature and some of the studies may not be entirely so. It's a little bit more complicated than I grew up black, therefore I'm gonna have worse outcome in prostate cancer. I think work by Brent Rose and others have shown that. Why I love this particular meeting, and I wish I could be there with you in person, and hopefully the next time, and in fact, Dr. Buckley and Gary Baum and the NMQF, I love what you guys do. But what I think is important with what you all are doing and what we're doing is we're elevating the discussion now that the reality is it's not just because of my blackness that I will actually have worse outcomes of prostate cancer, but where I live. Interestingly enough, we always look at this as if we blame the people, right? We say that you do that on the south side of Chicago and 24th of Inglewood, which, by the way, if we were looking and picking still on Chicago, if you look at the Loop, I'll make this easy. The Loop is where Keanu Reeves, Beyonce, Jay-Z, and Oprah go to. It's the part of Chicago that's happening. It has something called the Magnificent Mile, because it is magnificent. Shops, foods, places, green spaces, all the rest of that. Interestingly enough, you could literally get on a train and take it 8 miles south into what's called Inglewood, hometown of Bernie Mac, for those of you who know that, and Derrick Rose, and have a 30-year drop in life expectancy. Now, when I originally saw that, and I know I only have 2 minutes and I'll be finished, but when I originally saw that 30-year drop, most of the common questions came up. Dr. Nguyen, you obviously know that that's one of the most violent places in the country, right? So there's lots of gun violence. So Steve Wolf and others had accounted for that and found out that those things were pretty much negligible. So we're dealing with this issue about structure, not only redlining, but remembering the urban renewal processes that had happened in the 1950s, where you build where you build white roads through black bedrooms and decimated many of these communities. But these communities are living next to highways. These communities are living in areas in which you don't have access to fresh foods, i.e. the microbiome gets changed and all this. And yet, when we come in, we still have the same old song that African Americans are just simply predisposed, just simply because they're African Americans, to prostate cancer without actually understanding the environment in which they live. I.e., we've focused so much on the DNA that we've forgotten the importance of the ZNA, and yes, made up, and genome. I know, made up word. We'll do something with it at some point. This concept of the exosome that people talk about, for me, is even more dynamic in this concept of the genome, because it's all the active things that are actually going on, not just the exposures. I think there is a place to come together in the context of policies where we're now looking at not just can we get a molecule to become a medicine and the medicine to become in a clinical trial to actually do good, but where are the interventions along the way, and what's the data within those areas that we can get. I'll end by saying that we have paid so much attention to the omics, and I know I'm at time, proteomics, genomics, there's a whole bunch of omics. But one of the omics that I think we need to be better at, if we're going to really have impact, is what's called the community omic, the missing omic. That is more data within our communities, better data within our communities. Because it is true we have data deserts, and many of the people and places that have gone that are suffering the worst, when we go to get their data, we have the least. I think we have a lot of work to do, but I hope you are as excited as I am about what the future holds, because I think we now are not only having like-minded people, but understanding that if you create a new medicine, you better create a new navigation strategy too, and you better take into account what's actually happening in those neighborhoods. So with that, I know I'm at time. Maybe I'm a minute over. I was supposed to be 10, but I will stop now. And
Thank you.
You know I can go like a Baptist preacher, but I'm not going to do that today.
Thank you, Dr. Nguyen. First of all, I can tell you that it was felt like you were in the room. Although we would love to see you in person here, and that was not because of the technology. I mean, I think the message is clear. Personalized medicine in cancer should be also about community medicine, community cancer care. That's the next stage. That's where we should be. Hopefully you can stick around for a little bit, if you can, for some panel discussion if you have time later. And with that saying, I'm gonna introduce Our next speaker, who also doesn't need introduction, he's the CEO of Carolina Blood and Cancer Care Associate. He's the past president of the Community Oncology Alliance, Dr. Kasha Patel. For me, he's the renaissance man of cancer care community. That's the way I like to think about Keshav and the new friend. So without further saying, Keshav, thank you for being here.
So do we have a clicker here? Oh yeah, great, thank you. So I just want to give you a brief introduction of why I got into this healthcare equity and inequities. I was about to retire in 2019, spend more time on the golf course. I live on a beautiful 18th hole. And coincidentally, our association, which is Community Oncology Alliance, asked me if I wanted to be the president, which is the largest association of independent oncologists in the US. I took up the challenge in 21, and the first thing I saw was the ACR report, which is going to be the next slide. I saw this report that was published in the fall of 2020, and these are all the slides from the kind of summary. 1 in 3 cancer deaths in America is preventable if we didn't have disparities. Even if you are, say, I'm not a philanthrope, I'm a capitalist, when you look into this central slide, we could have saved about $230 billion in direct medical cost over 3 years and over $1 trillion in indirect cost in 3 years. And then the slide below that financial number is the genomics. The Genome Wide Association studies that tracks the human genome samples analyzed across the world for healthcare purposes identified that out of over 35 million plus samples, 2% representatives was African Americans, 1% Hispanics, and less than 1% other groups. So biologically, we all are different. And going back to Dr. Wynn's comment, our constant struggle, the interaction between the epigenome and biology continues to change. So if we do not understand the biology of each human being, we cannot have designer drugs under personalized medicine. And I felt that I had a huge task to undertake. So instead of playing golf, I started devoting time to understanding healthcare inequities. And again, I came across this slide, going back to Dr. Wynn's point. This is about 15-mile radius difference between the French Quarter and Navarre, and there's about 25-year difference in life expectancy. So the place, the zip code that you're born defines how long you're going to live. So all of these factors compounded my mind and said I had been probably selected to change the way we deliver care. And so I spent over 3,000 hours reading probably over 300 papers over 3 years and summarized, as any scientist, what are the causes of cancer health disparities? Lack of cancer screening, lack of access to clinical trials, access to care with financial toxicities, peer-related factors, social determinants of health. So even before that word became popular in 2020, I started kind of rhyming that words, and I started working on that. And the lack of NGS testing, which is again defines us who we are as a human being. So then I thought, okay, I tried to reach out to different entities in the government, and as usual, I realized that government will not solve the problem overnight. We had to take action in our own hands. So I started my own not-for-profit, and as a part of my giving back to the community, I've decided that every year I turn one more year, I multiply my age by 1,000 and put that money into foundations. So 61,000, 62,000, 63,000. My partners were nice enough. They joined me. They said, we also want to pull the money together. So with that, we started a foundation called No One Left Alone. And we started, S2S data collection, identifying how do we improve the care, how do we improve the biomarker testing as well, and how do we increase the clinical trial participation. These are the few things that were within my payroll. I mean, these are things that I could do in my clinic. So we are 9 product clinic,
in South Carolina. We have one office that is in typical rural part, one is more like suburban. And we decided that not a single cancer patient, no matter what ethnicity is, should ever worry about their financial part, and not a single cancer patient should be deprived of standard of care. So we decided to take things in our own hands. And you can see the 2 years outcomes. So when we looked into cancer screening, we are deluded because we find 900 patients, 900, that did not have USPSTF recommended cancer screening in our region, just one region of about out of 4,000 patients. We raised close to $3 million help, either direct medical cost or indirect donation by pharma companies for free drugs, to help our patients to make sure that they do not lose their sleep overnight. We started germline testing because I felt that without appropriately addressing every part, which is the variations in genomic data from just the inheritance, we also started 3 large studies to increase the biomarker testing, and I can say that we've reached about 80% plus biomarker testing in our patient population. And we also started clinical trial expansion. And this is a summary of our data that we collected up until, I think, October. I was out of country for 3 or 2 months, so I just came back. I'm updating data. But out of 10 patients that we analyzed data on, we have about 200 data point form that we've created to make sure that we collect data on SDOH, income, their ethnicity, their nationality, their kind of literacy level, along with cancer screening and their health literacy. We found about 589 patients with unmet health needs, 1162 patients with unmet health-related social needs. So about a third of our patients, or 35% of the patients, have unmet health-related social needs, which can lead to adverse outcomes. Studies have shown that unmet health needs can kind of reduce survival chance by about 15 to 17%. There was a paper in Cancer Journal. And what are the needs? So 426 patients had issue with cell phone, bill assistance, food insecurities. Food insecurities within our area, about 10% patients were telling that they may not have food next month. And 16 patients were living in the car. We were not aware of that. Since we started collecting data, we were able to provide them shelters. When you talk about the testing, so look at the number of different data points that we had. And one of the avid researcher who was at Mount Sinai, Dr. William O., he told me that as a part of our study, he found some mutations that he cannot explain based on geography or race. So he did tell me that there could be dynamic evolution of additional mutations that can be either based on geography, could be based on stress level, could be based on lifestyle. So we have a lot more learning to do. And again, looking at the germline testing, we found so many possibly actionable mutations that could translate into going into the patients and impacting their family members. These are some of the clinical trials that we've opened up, beginning from the registry trials to the phase trials. And again, we are not a big health system. We have no federal funding. We did this all because I believe in giving back to the society as a part of my duty. And so this is a slide that if we digest the message completely, this will solve the problems of humanity. Because we are moving to a level where from imaging we are shifting to liquid biopsy. So for diagnosis, for example, we can identify cancer detection early on. We can identify possibility of patients developing dynamic mutations during the course. We can look at doing MRD testing. And if we are able to translate this one single slide into reality, Imagine a patient living in Africa, India, remote part. You send a mobile phlebotomy van, collect the blood, do the testing, and do what you have to do as part of your social responsibility. So I think in next 10 years, the more intelligence we have in liquid biopsy in terms of, depending on the blood testing, that probably will be solving the problem for foreseeable time. And this is something like just-in-time trial, and that's probably talks about how can we do remote trials having one PI and multiple kind of investigators locally, and you could open up trial only when the patients are to save money. So with this, I'll end by saying part of my background involved growing up under the man, my dad passed away, but when he was 4 years old, Mahatma Gandhi came to his village and he lifted up in his arms. And so he said his life had completely changed. And he would take me to Gandhi Ashram every single weekend, dump me there and say, you spend time here, the place where Gandhi spent most of the time. And I didn't know why he was doing it. I thought he was kind of treating me differently. But now I remember that he wanted me to have my formative life programmed based on what he thought I should be doing as a growing up. And as a result, I'm here today. Thank you very much for this opportunity.
Thank you, Kashyap. I actually don't see how anyone just looking at this data as well as at the data at the community level that Arthur was talking about can still talk about the economic of cancer care don't make sense. I mean, how can you just don't see the economic impact of lost life, of the impact on the community, on the society at the time where you can just detect a lung nodule from an app on your phone? I mean, this still drives me crazy, and I think that's something probably that we're gonna discuss further. So let me move to our last but definitely not least speaker for the panel session, Dr. Rajbir Singh. He goes by Raj, right? He's the Executive Director of Precision Medicine and Health Equity Trial Design at Meharry Medical College. Actually, I think it's great you have both these two titles and do these two things, because I think that his work has really been fundamental in bridging the gap between not just bed and bedside cancer research, but particularly in addressing the gap in inclusiveness, participation, inclusiveness, representation in clinical trial. So without further saying, Raj.
Oh, yeah.
Thank you.
So thank you, Salvo. Good morning, everyone, if we are in the morning right now. So I'm Rajbir Singh. I'm from Meharry Medical College. And I'm honored to be here. And thank you for the invitation to Salvo and also to everyone else at the NMQF. So while having discussions yesterday during the dinner, it was surprising for me to hear from folks, where is Meharry Medical College? And I was like, okay. And then another question, okay, what are the other historically black medical schools? What are you talking about? So, and I was talking to Salva, okay, I'm going to talk a little bit about historical black medical schools in the country, because you should know when you are at a National Minority Quality Forum. So, Meharry Medical College is one of the 4 historically black medical schools in the country. One of the oldest, Harvard, is in Washington, D.C. Morehouse School of Medicine is in Atlanta, Georgia, and Charles R. Drew in L.A. So these are the 4 historically black medical schools. How did you change this slide? All right, so Meharry Medical School or Medical College was established in 1876. As I mentioned, it's a historically black medical college in Nashville, Tennessee. There are 3 HBCUs. There are 111 or 114, more than 100 HBCUs, which are historically black medical colleges and universities, but there are only 4 medical schools, as I mentioned. So Meharry, Fisk University, and Tennessee State University. They are within the radius of 1 mile from each other. They make a HBCU triads there, and we collaborate very extensively with each other for all kind of research, including clinical trials. And a goal of Meharry basically is to train African Americans and underrepresented minorities in health and biomedical sciences for minority health disparities, healthcare and research. So, we talk a lot about, having researchers and clinicians from the background, from the same background, what we want to address, like the kind of communities we want to address. So this is where Meharry, Morehouse, Charles Dew, and Harvard are contributing a lot in terms of producing researchers from minority background. So we have 5 schools right now: School of Medicine, School of Dentistry, School of Graduate Studies, School of Global Public Health, and newly School of Physician Assistant. So 85% of our student population is African American, and more than 40% of African American and black dentists are trained at Meharry Medical College. So one of the top 5 colleges awarding PhD degrees in biomedical sciences to African Americans. So we have a partnership with Nashville General Hospital, and we also have a partnership with Meharry, which is called Meharry Vanderbilt Alliance, which I'll talk a little bit more in details. So diversity, we always talk. I mean, everybody has talked about all these things. Participation being low is still less than, in all clinical trials, less than 6-7%, especially from the African American community. Less than 2%, as Dr. Kashyap just mentioned, in genomic trials. Very important to address this, and if we want to achieve the goal of health equity, we need to have a representation in clinical trials. So data cannot be generated without participation. If we want to, if we have data, only then we can have effective analysis and we can find solutions. So that drugs and other things can be effective for all, and so we can do a lot more when we have more representation in clinical trials. So what do we do at Meharry? So we have Center for Excellence of Clinical Trials and Center of Women Health. These 2 centers primarily focused on conducting clinical trials, which are minority focused. And we do a really good job. I'll show you the numbers in following slides in enrolling participants in clinical trials. And community engagement, we talk about, all omics, like Kashyap mentioned, community omics, somebody mentioned, and we have a community engagement core, very strong. We conduct community engagement very early for clinical trials. We talk to the stakeholders, patient stakeholders, physician stakeholders, and engage them early, and also conduct studios. These are paid members from the community who provide input onto the clinical trials, that how they should be presented to the community. That is done before we start initiating the trial. We are participating, Meharry is the only HBMS in PCORI network, Patient Centered Outcome Research Institute. And this is very important because our 65% of the patient population is from minority background, African American or Hispanics, and the PCORI being patient-centric, it gives us the opportunity for our data to be represented, and also gives us the opportunity to bring trials which are minority focused. Once, if you don't know what PCORI is a network of multiple institutions, and they have a data sharing, they have called Common Data Model, and where if you are a researcher, you want to conduct a clinical trial, and you want to know where your patients are, that query is sent to all these networks, all these colleges, and they conduct that query, and a researcher comes to know who are the partners available for that researcher to conduct the clinical trials for them. It's very good. And in the PCORI, again, I'm stressing, we do not fund any clinical trial or any grant unless there is a stakeholder engagement policy included in that grant, meaning that they need to have stakeholder engagement, like what are their stakeholder, patient stakeholder and physician stakeholder, how are they going to conduct this study, and how it will have impact in in the community. School of Applied Computational Sciences, we have 2 supercomputers now, and this helps us getting to know, like, early on that whether we should spend resources in these trials, do we really have the, patients. This helps us a lot. Recently, we got funded for Diversity Center for Genome Research to advance genomics clinical trial and research. I'm one of the PI of this grant. So genomic research is very important, as you know, for precision medicine, for cancer research and all other research. And there are only 3 centers NHGRI funded so far in the nation. One is in Texas and other in Hawaii, and Meharry is one of the 3. And our focus is to create data bank of African American genome at Meharry. Meharry is also participating in AIM Ahead program, NIH program. AIM Ahead is Artificial Intelligence and Machine Learning Consortium to advance health equity and researcher diversity. Meharry constitutes the Southeast Hub. I'm co-investigator. Dr. Anil Shankar is the PI. So what we do in the AIM Ahead initiative, we have research fellowship programs, leadership programs, program for AI readiness, and few other programs. And researchers from all over the country apply for the grants. And we review those grants. And I can tell you that we have funded so many researchers who are from minority background and also doing cancer and social determinants of health research with existing data banks, like existing data available, whether it's all of us data or other OCHIN data bank or other publicly available data sets. So, and I'm leading IGNITE consortium at Meharry. IGNITE is implementing genomics in practice. We have 2 clinical trials currently ongoing at Meharry. Meharry was part of eMERGE consortium also, which is electronic medical record and genomics. So who are our partners? We have very long-standing partnership with Vanderbilt, which is predominantly white institute, and this alliance has helped researchers from both institutions, Meharry and Vanderbilt, to collaborate with each other for all kind of research, whether it's clinical, translational, or basic science. Meharry has one of the longest, long-standing Meharry Vanderbilt TSU Cancer Partnership Grant, U54, and which is entirely focused on addressing cancer health disparities. And Chen Zuckerberg initiative to build the genomic initiative. So I would like to talk a little bit about T4C initiative, Together for Change initiative we recently launched. And this is a public-private partnership. Meharry is leading this initiative to build a genomic database of 500,000 people from African ancestry. And Regeneron is leading the pharma consortium alongside Roche, Novo Nordisk, and we are still looking for more partners. So before I close, I wanted to show you what our successes are. If you look at the numbers enrolled on different clinical trials at Meharry right now, 63% in the ADOPT, which is a depression and opioid pragmatic trial. We test the participants for PGX genes, CYP2D6 and CYP2C19, and basically provide recommendation based on that for antidepressants. If you look at the numbers, more females and 63% of African American patients are enrolled in that trial. The second is GUARD. genomic testing to understand and address renal disease disparities. In US, 100% African American minority focused trial, we enrolled 525 patients in that, which is more than Vanderbilt enrolled. I just give you a number that we are doing much better than even very bigger institutions. Harbinger, and Roche are cancer screening trials. If you look at the numbers again, 210 females and 247 African American, which is these numbers are very, very significant for us in clinical trials, and then also emerge. And all these numbers are from the last 2 years. So this is also done in a very short time. So I think my time is over, and then these are the normal strategies: education, education, education. That's what I would stress on. That is what we do. All coordinators which we train, they undergo trainings, cultural sensitivity training from the HR, and their goal, we always tell them to educate first, not to go with the intent of enrolling the patient. Just go to and talk to them and learn their problems and educate them about the disease purpose, process, and also how these trials can help. Future direction, enhancing infrastructure at institutions who has built trust with the community. And that was the reason I mentioned for historically black medical schools, that we have built the trust. We have built the trust with the communities. You can see with the numbers we have shown. And this is where the infrastructure needs to be enhanced, and public-private partnerships or federally funded dollars should come to the institution who has already built the trust. I mean, we can do much more. We are doing much more. We are the boots on the ground, and we are very effective in addressing disparities at our institution level. And I mentioned, early diagnosis screening trials. These are very, very important. Everybody has stressed on that. Yeah, thank you.
Great. Thank you, Raj. So we are running out of time. Perhaps only one question that I would like to ask the panelists. I don't know if Dr. Wynn is also still with us. And I think it's the question that everyone in the audience is probably thinking of, is you have successfully really set up the ground here for work. We heard the importance of building trust with the community. I don't think that without doing that, you would have been able to make progress. So does any one of you give us an example, an anecdote, or just some simple share a story how you were able to build that trust? Dr. Wynn, I see you're virtually raising your hand.
Yeah, so I'll keep this real short. So I think that we have, and many of us in MQF and in the field have been thinking about building trust for a very long time. One of the things I think I would like to put and change the conversation a little bit about how do we measure institutional trustworthiness. It turns out that you can go out and build trust all you think you want to, but without actually having a reflexive mechanism of figuring out and trying to struggle with what does that look like when we look at our institutional trustworthiness, I still feel that we'll miss the mark. There's a lot more to be said about that. I think that I've learned this from, lots of people like Ruben from Beck and Tuskegee and other things, Ruben Warren and others, Dr. Warren and all the rest of these. But we really are going to have to struggle with, we were able to measure quality and safety. At one point, we couldn't measure quality and safety. They said, well, you can't do that. Well, I'm a believer that trust is something that someone gives us. Trustworthiness is something that actually we need to struggle to figure out how we can be better so that we can actually have a reflexive model about how we look and how we're doing. Because right now, I think it is so loosey-goosey that in general, we're so focused on building trust that we forget that we have to be trustworthy. Nobody trusts Snidely Whiplash, by the way, in Dudley Do-Right. I'm just saying. So I'll end there.
Thank you. Keshav?
Sure. So I think, first of all, we have to create an ecosystem of trust. And going back to what Robert just said, at our office, we don't have clocks in patient examination rooms. Patients share it at a higher level than doctor's office. So these are like some visual clues. And when you put your hand on patient's shoulder and tell them, make them feel relevant. I think the most important thing is if we treat that person as a fellow human being and ask about the family background, how much do they have. So you break the ice by making them feel relevant. And when we talk to the patient, we tell them, right now, you are the only focus of attention I have. We don't have computers in examination rooms. We actually do charts after going out of the room. And the perfect kind of success story was I think an old lady, about like 72-year-old African American, and I was telling her about, the gallery trial we are doing, and then also another study was INVITE, which was like study for the, germline testing. And I would tell them that, listen, I don't think, we'll have enough information that may or may not make difference in your life, but it may impact the future generations down the road, because collecting data on minority genomic information would be something that can define future generations. She would say, hallelujah, I don't need to read a consent form, where can I sign? I've not had a single instance that any patient of color brought out the issue of Tuskegee. When you talk to them eye to eye, when you put your shoulder on their hand, when you make them feel a relevant, respectable human being, I think that's a breaking the ice.
Thank you. Thank you. Thank you very much, Yeshas. Maybe one last question for Ash, because I think I want you be part of this discussion as well, but slightly different. You have been very successful with this partnership. I mean, the Cancer Stage Shifting Initiative is first and foremost a partnership. What can you tell us in terms of things to keep in mind for us to partner all together to achieve something that is measurable, actionable, actionable and measurable? It doesn't take 20 years to happen to have an impact on the community. So anything that you can share with us and for us to keep in mind?
So measurable, I think everybody has talked about the same thing, early detection. If we are going to talking about stage shifting and early diagnosis, early treatment, early screening methods, and they can be easily measured. Within few years you can see the result. And the more effort needs to go in that direction, and and creating data from clinical trials, more representation in clinical trials. I think I believe if we put all stress in this direction and making them accessible to everyone, that is the key. If we keep it limited, we can. When we talk about health equity, that is for all. It has to go to everyone, and we need to increase our outreach, and not outreach for enrollment in clinical. Outreach to provide them with care, provide them with screening modalities available, provide them with new technologies which can detect cancer or other diseases early on. I would say that would be
great. Thank you. On that note, I'd like to thank you all of our speakers for sharing their wisdom and for staying here with us in the room, outside the room. And I thank you all for listening, and feel free to reach out to them during the break, because I'm sure you have more to talk with them and ask them. Thank you.
Thank you, guys. I wish I could be with you, but take care.
Okay, everyone, hang tight. This is the last panel before lunch. Please take your seats. And if you need outside conversations, please go in the hallway. Thank you. Okay, the panel's about to begin. Outside conversations in the hallway.
Good afternoon, everyone. Thanks for being here today. My name is Seema Singh Ban. I have spent over 25 years now in public policy, healthcare, and trying to work to bridge the gap between innovative technologies and our public policy. I spent 15 years on Capitol Hill, and now over 10 years in the diagnostic space. So I'm really excited today about the esteemed panel we have here, and thank you to NMQF for pulling together this forum. We know that the team here is committed to pursuing the Cancer Moonshot Initiative, and especially focused today on medically underserved care communities. As you know, all of you here, fostering early detection and ensuring advanced care reaches underserved communities has the potential to really change the landscape of cancer. We are on the precipice of transformative innovation in earlier detection, not only of traditional single cancer screening methods, but what we're now calling multi-cancer early detection. And that's the ability to detect cancer earlier through a blood draw. And the idea is that there are similar biomarkers across cancers that can be detected effectively, safely for most people. And how do we bring forth this innovation, this truly transformative innovation, to everybody? Because the technology is here, the tests are here. It's not a one company, two company. This is a platform that will be available and is available. So the panel here today has extensive experience on a wide variety of issues, but especially in innovation in cancer care. And I'm hoping we have a discussion here today, a conversation about how we can all work together to bring this forth. So hoping we could start with some introductions. Elise?
Can everyone hear me? Perfect. My name is Elise Levan. Thank you so much for the invitation to participate in the panel. I am part of the Division of Cancer Prevention at the National Cancer Institute. So just a little bit about my background. I'm a colorectal surgeon by training. After my training, I pursued a Master's of Public Health from Hopkins University with a focus in health disparities, and was working in clinical trials primarily related to HIV and vaccines when I got a phone call from the NCI about a new network that they were starting for cancer screening research specifically. And so I've been with the NCI for about 1.5 years now, and we're starting this exciting new network with a real focus on underserved communities and trying to bring new cancer screening technologies to everyone, and to be able to test these in ways that make sense and really looks at the full spectrum of how can we use these technologies, how can we get them out to communities, and how can we maximize cancer screening, because preventing cancer and detecting cancer early in a way that can really affect treatment will be the best way to reduce cancer-related disparities and save lives. So very nice to meet everyone.
Hi, everyone. Can you hear me? Good? Okay. I'm Lauren Lyman. I'm the Executive Director of BloodPAC, the Blood Profiling Atlas in Cancer. It was actually I started it when I was the head of external partnerships at the first White House Cancer Moonshot many years ago. Our idea for the consortium is to accelerate the development, the approval, and the accessibility of liquid biopsy technology for patient benefit. And we started with a group of 20 different organizations back in 2016 that committed to create standards and frameworks for liquid biopsy in the community Step two, aggregate data through our BloodPAC Data Commons to support the creation of those standards and frameworks. And most recently, over the past few years, adding the accessibility piece. I think we've been quite successful in actually getting these tests, as Seema said, developed, approved. But if they don't get into patients' hands, what's the point of actually going through all this work? And so today we focus on those three pillars, if you will. We've grown from our original 20 different organizations to about 65, 66 organizations today. We run across all stakeholders, diagnostic partners, pharmaceutical partners, academics, nonprofits funding and working in the space, several government agencies, including the NCI, and payers as well. So everyone at the table to hopefully accelerate this field forward faster. And most recently and excitingly, which I'm not sure if, I don't think I'm supposed to talk about it now, but I can talk about it later if y'all want, we just published a paper on access and the barriers and challenges to accessibility to these tests on two different paths. One, kind of broadly, the reality is these tests are not being widely used yet, and there are still challenges in that space for everyone. And then on the second path, there is a priority to how do we make sure these tests are being provided in underserved communities, and most importantly, especially I think in the screening and MCED space, how do we make sure they're decreasing disparities and not increasing them? Because they have the potential, I think, to do both. And so we want to make sure we're addressing those issues up front today and accelerating the time frame to get them utilized. We can talk about it more later, whatever Stephen wants.
Hi, my name is Jeff Allen. Thanks for the invitation to join the discussion today. I run a group here in DC called Friends of Cancer Research. Much like my colleagues, I've been in cancer research for quite some time. I'm a cancer biologist by training. Spent some time working with the NCI, doing some early stage drug discovery research. But that's been a while ago. For about probably at least the last 15 years, I've been working in healthcare policy, all related to cancer research. With the topic at hand for the panel today, we have had the pleasure of working with our NCI colleagues and Lauren's organization on a number of related projects. The area in the liquid biopsy space that we've been particularly focused on is looking at how measures from the blood can be early indicators of response to treatment. So this is a large-scale partnership across a number of different clinical development programs to aggregate data across, at this point, over 24 different clinical trials to determine whether changes in circulating tumor DNA, the biomarker that is measured by many of these liquid biopsies that we've started talking about here, how changes in that may be detected far earlier than a clinical outcome. But in order for that to be a useful measure, it needs to be well validated in terms of understanding whether that correlation is true and in which situations it can be most useful. Sort of on the flip side of that, that's also related to this, we have a portfolio of projects that is looking at better measures or additional measures to evaluate effectiveness in broader populations, and looking at ways that we can learn from healthcare that's delivered as opposed to just through clinical trials. Now, clinical trials are a critical component, of course, to drug discovery, the backbone of it. But to date, or historically at least, only a fraction of cancer patients actually are involved in clinical trials as part of their cancer care. So there's much more that we can learn if we're able to operationalize the healthcare system in a way that it actually can provide tools for research to be able to learn from the care that's given. The way that these sort of have been coming together is in the early detection space for some of these new and emerging technologies. They certainly are performing the clinical trials to understand the performance of the test. But in the long run, in order for these tests to be well understood and as accessible as possible, I think we really are going to need to align healthcare systems and various different healthcare practices across the country, across the world, to be able to understand the utilization and optimal implementation of these types of tests and actually learn from it.
That's really, really insightful. Lauren, I want to follow up on the accessibility paper, which is super timely given this conference, and hopefully we can make it available to everyone. Can you give us some of the highlights on, you said these technologies can widen the disparity gap or compress them. Talk to us a little bit more about what you found in your paper.
Sure. So we have found about 8 different challenges or barriers, if you will, to accessing liquid biopsy diagnostic tests. And they have to do, are around areas that everyone in this room is very familiar with. Educational challenges, both for patients but also for physicians, how to utilize these tests appropriately. Around trust, around geographical access, and the list is pretty extensive. And I encourage everyone to go to bloodpack.org, and the paper's right there, and you can have it, but we can circulate it as well. I think that we are in the process of pulling together a study that will actually look at the impact if we are able to provide free testing to patients and free treatment options to patients, as well as education, so addressing several of these different barriers at one time. Will it increase the usage and improve outcomes for patients in underserved communities? I don't know the answer. And we think we know the answer, but I don't know the answer for sure. And so I think it's really important for us to figure out what these barriers are, how to best address them, if we can address them with the organizations that are working within BloodPack today, because ultimately our goal is to create a sustainable model where we aren't giving, every company isn't giving out free testing every day, and drug companies aren't giving out free drugs every day, although that is a component of what they do for different populations. But I think it's important to create a sustainable system where there is an educational process for all different groups, again, community health workers, physicians, nurses, patients, advocates, everyone, because this technology does change so quickly. But when these tests become available, and some of them are available today on the market, you've seen them, they're extremely expensive, and only a portion of the population is able to receive them. That leaves behind, in this case, a very large number of the percentage of the population. And so we want to make sure we're discovering today up front the best way to get them tests, and see if we're able to use them to improve outcomes all across the board. Just to be clear, our study that we're looking to put together over the next year is not going to include MCEDs or screening tests. It will be strictly for treatment. I don't mean to disappoint. I'm sure I will.
Well, maybe there's a conversation to be had with, I think, a good amount of people in this room on how we can all partner together.
I would love that.
Yeah. Which brings me to you, Jeff. There's some work that Friends of Cancer Research did on real-world evidence in multi-cancer early detection and other earlier detection tests. As we go out and look for the appropriate evidence that needs to be captured to ensure that we are reaching the true potential of these tests, what were the outcomes, and how should we all be thinking about real-world evidence, which really means, and what does real-world evidence really mean?
Well, it is sort of a term, but in general, I think it encompasses routine clinical practice. And the reason that this is an important component, or even a perhaps underutilized avenue for research, is because typically research is conducted in a very controlled environment, meant to reduce potential confounding variables or things that might complicate your study results. So by doing that, you tend to have patients that oftentimes don't reflect the people who ultimately use the drug or device that's in question. And that's just trying to isolate sort of variables. But it also means that these trials are oftentimes being offered at very select sites, largely academic institutions that have an infrastructure to be able to collect a large amount of data and aggregate it together, perform the necessary analyses to interpret the results of the experiment. But historically, only about 5% of adults with cancer are involved in clinical research for a variety of different reasons, and we can go into that in today's discussion if that's of interest. But that means that 95% of cancer experiences are not necessarily as well documented, and we may not be learning the maximum amount of information from those experiences that we potentially could. And I think this is particularly important in the field of early detection because of the large number of experiences one would want to have in order to understand the ramifications and optimal use of these types of technologies. So it doesn't mean that one has to choose one or the other. It's not a matter of, is a clinical trial the only source of information, or can clinical practice replace that? What we hope to do by looking into this was to try and develop strategies where the real-world clinical practice, or outside of a clinical trial, the information that could be obtained from that would be able to supplement and augment some of the shortcomings or challenges associated with a clinical trial. The clinical trials are going to be the basis for understanding the really deep information around the performance and validity of these tests, but they're not going to collect the information on the breadth of individuals that are important and necessary to understand what the ramifications are, both from a biological standpoint, but even from a healthcare implementation standpoint. You know, thinking about some of the real world challenges that might be faced should tests be made more widely available. Things of what happens next. You know, what do people do if they receive a negative early detection test? What do people do if they receive a positive early detection test? And how can we make sure that we're helping to inform those guidelines and those recommendations? Because ideally, that's the information that's going to be really important. What action do you take on the basis of these types of results? The results is only the first step, be it positive or negative. We really need to focus on identifying what those most appropriate next steps are and helping to inform the patients that receive the test, the healthcare professionals that are administering them, the healthcare system that needs to support whatever those optimal decisions are, because right now I don't think that streamlined infrastructure is in place, and that's something that we really need to work at if we're going to see effective implementation of these types of technologies.
Thank you, and I think we'll probably have a number of follow-up questions and thoughts on that. Dr. Levan, turning to you for a moment. Are you able to share any insights on how MCEDs and other screening diagnostics or screening tests are being prioritized at the NCI? How are you thinking about this? And specifically, you know, to Jeff's point, how is the NCI ensuring that the project on MCEDs and other earlier detection tests are engaging with the right people?
Really excellent question. So this was really at the forefront of creating this new network for emerging technologies related to cancer screening. We didn't want underserved communities to be an afterthought at all. And so from the onset, the institutions that we engaged, we asked them to describe how they're going to engage underserved populations, what historical relationships they have with these populations, and have they been able to engage communities in clinical trials that have been traditionally underrepresented, to your point. So there's a huge focus in this network on, as we begin to identify and test the utility of these new technologies, we want to make sure that every step of the way we're thinking of equity, and these technologies are unprecedented and so exciting. The opportunity to screen for multiple cancers at the same time, for example, it's fantastic, but there are also a lot of questions whenever you introduce a new technology that doesn't have a lot of data behind it to see how it works in the real world setting. And so questions arise like, what have these technologies been built with underserved communities in mind, and have data from those individuals gone into creating the algorithms? I guess one important thing to talk about MCEDS is that there are two parts. There's a scientific recognition of a pattern within the blood test itself, and then an algorithm that tries to find out whether or not that data means that this person likely has cancer or not. And unless the test was built around underserved communities and looked at those individuals' data, what comes out may or may not be relevant to underserved communities. And so one thing that's really important is to test whether these tests do work in underserved communities. And then the follow-ups to your point, if I got a positive MCED test today that indicated I might have colorectal cancer, for instance, I'd still need a colonoscopy or some other diagnostic test to really verify the diagnosis of colon cancer. And so if I'm somewhere where I lack access to those follow-up steps, I'm not going to be able to realize the potential of some of these emerging technologies. So when we build our clinical trials through this new network, we want to be looking at all of those elements simultaneously. What do we do with this information, and how can we really support underserved communities such that they can realize the benefits of any technologies that we find to be effective?
Is there an effort to engage with community leaders for their unique expertise in medically underserved communities to get that input and then go back to the collaborators to ensure that that's incorporated in the thinking?
Yes, so I think that part of the plan is to have an external advisory board that really does incorporate ideas of patient advocates and community leaders, but that each of the institutions that have applied to be in this network also describe their community partnerships and how at a local level they're going to be advised by the communities who potentially have been underserved in the past. And so we're definitely thinking about this at the forefront, and those voices are going to be valued and incorporated in really the infrastructure of the network, rather than trying to provide recommendations at the end of the trial, which is something that I think the clinical trial community has had some shortcomings in the past with waiting too long to engage those voices.
Yeah, and I think if it's okay with you, I believe there are people in this room and those listening online that would really be of value to you all as community leaders leaning into this conversation. And I'm looking at Gary, and Gary can surely help with, I think, pulling together a core group of people to help talk to the NCI about some of what you're seeing and what you believe potential solutions are. Lauren, you and I worked together on BloodPAC in the past, and way back many years ago, we wrote this paper called this article called Collaborating to Compete, which to me just summarizes how BloodPAC works with the whole ecosystem of industry and advocates and clinicians and academic medical centers. How do you think in this specific space of liquid biopsy earlier detection, what can we do to change the paradigm of the past of this? There's so many barriers we have to overcome and it's going to take a while. How do we expedite progress? Because science is moving faster. We've got to close this gap in a more deliberate manner. And do you see the will to do that within your organization? And how do we partner across? It's for everyone. The question's for
Ema's
everyone.
being modest. She was a founding member of BloodPAC, so there's that. And I feel like she kind of gave away the punchline. But it's really, we did write a paper called Collaborating to Compete. And I was very excited to start BloodPAC for a number of reasons years ago. But I think the number one reason remains the same. I feel very strongly that bringing people in different groups together to work on a problem is stakeholders from across the field will inevitably allow you to accelerate development progress and in a more efficient and effective manner, period. So that's what we try to do at BloodPAC. Both sides of me, NCI and Friends of Cancer Research, are both members of BloodPAC. The idea is to, again, bring together all these stakeholders that have different expertise, different perspectives, different opinions to all address challenges in the space and overcome them together using kind of different ideas and perspectives, really. I should say in the pre-competitive space for BloodPAC is where we've been the most successful. I love to say that I would love BloodPAC to be a demonstration project for all areas, right? Not just, liquid biopsy, not just cancer care, but anything in the medical field and frankly beyond. People should be, I think, partnering this way. So, for example, we have spent a lot of time thinking through accessibility from a number of perspectives. Part of our accessibility working group includes a number of pharmaceutical companies who are thinking on how to best get their treatments out into the public, how to create the best treatment options for a variety of patients. We also have diagnostic partners working on accessibility to say, I have this test, how do I actually get it to the appropriate right people? We have nonprofits who work in advocacy and say, how do I make sure the language we are using when we create these standards and frameworks will actually be usable by a variety of people. So for example, that group has reviewed all of the lexicons that we put out into the marketplace, if you will, trying to create standards for both early detection and screening or molecular residual disease. How do we make sure we're all saying the same thing across companies, but also around patients? How do patients understand what we're saying to them? How do advocates understand? How to translate what the doctors and physicians and clinicians and the test developers are saying? And so our access group was able to sit around the table with all of these different partners and address these questions holistically. So it cuts, I think, the time frame of bouncing these ideas for years potentially around the table to, okay, here's what we have to do, here's the goal, here's who we want to reach. And that's just for, it's just for a lexicon, right? Which I admittedly thought wouldn't take very long, and it's taken a very long time to actually move through the system and get published. But we also create, less exciting things like an analytical validation protocols for the community to actually make sure for the NCI, the FDA, and others, here's how you analytically validate your test. But we have 80 members working on that project from across the spectrum, and it's taken 3 years. It took 3 years to publish our first version of the protocol. And today I'm excited that we'll be publishing a second version of that protocol in the second quarter of this year, through even greater participation from the community. So in my mind, we have been able to make the progress that we have purely based on the participation of all of the different companies that come to the table, the different organizations that come to the table, and being able to represent 66 different groups, not just one, I think has really been able to move this field, the liquid biopsy field in particular, forward faster.
Really impressive. Jeff, you work in similar ways, and you also have, when there are tough problems that need to be solved in the policy world, the powers to be come to your organization. How do you view where we are now, and how can we help drive and accelerate progress?
Yeah, I think as a community in this space and probably in a lot of other areas of healthcare too, we need to be very deliberate. You know, I agree. You have to be collaborative. There has to be a willingness to work together, particularly in this space. You know, there are a number of different technologies that are that are out there. You know, that are available for use, and to Lauren's point around the importance of the work that they've done around setting up uniform standards, the approach should be that there is deliberate agreement among any of the manufacturers and developers of these tests that there should be minimum performance standards, that there should be transparency in terms of how the tests are working. And that's what Lauren was referring to around analytical validity templates that people can use. That should be an expectation because people are going to be making choices around what tests are available to them, and wouldn't it be nice to know that any of these tests that might be offered at some point in time have met those standards and have shown the extent to which they're able to produce these important results, because the potential is huge. You know, when you think about the current state of screening, there are only a few cancers that have a recommended screening tool in existence. And they're all individual right now. So, you know, there are recommendations from expert bodies from the government and the Preventative Task Force that recommend at what age one should receive a colonoscopy, a mammogram, you know, situations where lung screening is appropriate. But those are each individual things that one has to monitor and work through a complicated healthcare system on its own, although we have more experience with those. But I think those are important models to think about how some of those screening tests were implemented. What we're talking about here, as was mentioned, is the ability for a single blood test to potentially detect any number of different cancers or signals toward cancer. But then the responsibility is what to do next. So the standards are just the starting point. The exciting technology is really remarkable, but it's just the starting point of actually getting to a system that can optimize outcomes for anybody who gets the test. And I think that needs to be a very deliberate and well planned for endeavor. Not only in terms of sort of what the logistics are, but what can we expect? You know, in thinking about the validation process, and given that these tests are being used, there's extensive efforts to collect data in the long term to understand, are these providing the benefit that we hope? But we need to be deliberate in collecting that data and understanding what are some of the mileposts along the way? How do we know we're moving in the right direction? What are the opportunities for course correction if we're not? How do we make sure that we're engaging the communities that ultimately should be using these tests, and how do we inform them? How do we create an infrastructure to support those decisions? You know, these are all complicated things from a scientific, a policy, a logistical, you know, these all present challenges that if we're not working together.
How do we, once we are able to reach and excel in the scientific barriers and get validated, how do we ensure that everybody has access to those tests? And today's policy environment for these multi-cancer early detection tests have an unprecedented community rallying behind a policy fix that would ensure that once these tests are validated and approved by the FDA, that they have a path through CMS for coverage, just like colorectal screening and mammographies. But our policymakers have not moved on this legislation yet. And I think they need to hear from everyone about this. There's hundreds of advocacy organizations that are pushing for this, the American Cancer Society, the Prevent Cancer Foundation, Colorectal Cancer Alliance, across the board. But there's a missing link between the policymakers and the tests. So we could have the best test out there right now, but everybody here would not have access to that. And I think it's a point to be made. And I think there's a way to ensure that this happens. It's a bipartisan piece of legislation on both sides there's just no reason we shouldn't be able to pass that bill.
Yeah, and I think part of that, in order to create confidence in that type of approach, is going to be that deliberate approach to make sure that the system is ready to handle these types of tests. And that's why I love some of the things that MQF is pioneering here. Things around examining some of these mileposts, like stage shift. What can we expect? How do we collect that data? How do we engage sites that may not necessarily always have been engaged in research to be able to collect that information and help work through some of these mileposts to make sure it's not saying some of these earlier encountered measures are going to replace the necessary long-term measures, but how do we deliberately create the system that we can know when we're moving in the right direction and agree on that? And I think that will help push the policy forward, knowing that there is an infrastructure in place that is going to continue to collect information that would come with providing coverage, certainly to as many people as possible that could potentially benefit from the results of these tests.
But I think, sorry to interrupt, I also think, though, what you're saying is creating a deliberate infrastructure also requires addressing other issues like we were just discussing out in the hallway around, so what if we get everyone these tests? How do we create the infrastructure that allows for them to follow up and, if necessary, get their colonoscopy? How do we make sure that at that point they actually go and get that test and have access to that test, and it's easy for them to get that test? And then as a next step, if you need treatment, you have those options to get, you have the right appropriate knowledge to get the treatment options. I think it's a very long road, and I think, making the plug for everyone in this room to participate, that there is a role for everyone to play, that BloodPAC is very early on in the process, right, as Jeff is saying. But I think the challenge that I hear is that, just if we can get these tests to everyone, we're doing our part. But there's a lot of questions beyond that first test and then understanding the test results appropriately. What happens next, and how do we make sure that every step in the process is taken care of, especially in communities that are not being served appropriately right now? Did I just speak on your behalf inappropriately? Okay, cool, thanks. Signing.
Well, I'm going to leave some time for Q&A, but before I do that, last question: if there's one thing that we could take away, or one action item, from today's conference and bringing people together, what would that be to each one of the panelists?
This is a hard question. I think that to your recent point, that there are some deep inequities in the systems that we have right now, and that these emerging technologies are really exciting, but that having that long-term infrastructure piece in mind as we're developing them is really the only way that we're going to change our current paradigm. We have colonoscopies right now, we have screening technologies that we know work, and we also know that there are underserved communities that are getting diagnosed with cancer later and dying unnecessarily of cancer. And so remembering that just having the technology isn't inevitably going to lead to equity is a really important piece. And I think that we need to think about the equity component really from the onset and at every single stage along the way to make sure we're really delivering on a promise of improving cancer care and really saving lives in this space.
Can I give a shameless plug? Join BloodPAC. I think Seema said it, collaborating to compete. We're open to ideas and partnerships with everyone, and I think that, again, building on the trend we're having here, we can't do it alone. We play a very focused role in this puzzle, and it's an exciting role, but we need the input from lots of different organizations, especially to build on the projects we've established. So get in touch, let me know. Shameless plug, I'm sorry.
Please.
Had to do it.
I think it's hard to predict the future, but we have to do the best that we can to plan for the future. And this isn't necessarily a foreign concept to any organization or any business. You know, thinking about where they feel they need to be over the course of some period of time. You know, what needs to be in place in order for us as a community to think we have done a good job in the next 3 years to implement these types of technologies, and who needs to be doing what now in order to make that successful. Healthcare is a very complicated area. Historically, I think the healthcare, the players in healthcare have done a very good job at staying in their silos and staying focused on what they need to focus on. In some cases, that's led to great successes. In some cases, it's led to great fragmentation. This is an area that I don't think we benefit from fragmentation. And so as a community, to the fullest extent possible, that we can map out what the short-term successes and what needs to be done in the short run in order to get there across all of the different multifaceted problems that have been discussed today, I think that's the only way we're going to get there in a reasonable time, in a reasonable amount of time, and feel like we have implemented this to the best possible way.
Thank you so much. Can we open up for some questions? Do we have time, Adjoa? Yep. Any questions? No, okay. All right. Well, I just wanted to thank the panel. Oh, sorry, there is a question.
I could ask one question. I don't know if I'm loud enough to be heard, but you know, my organization works on gynecologic cancer, and if you look at cervical cancer screening rates, it really dropped over the last several years, and that's upsetting. And I think that it may have some. I think politics may have some impact on that, as we see certain states have more restrictive care for gynecologic care. But do you think that MCEDs and other types of screening technology that are broader or less requiring you to seek out care might be a way to improve that type of cancer screening that already exists?
I think we just don't know yet, and I guess shameless plug for clinical trials, but that's a reason we need to put that into the study design to ask that question, because it could go either direction. I could get a positive MCED test, and it could indicate I might have cervical cancer, and suddenly I'm really motivated to go and show up at my gynecologist's office and get a test I might not otherwise have gotten. On the other hand, I might get a negative result and not show up for the screening that I might have otherwise gone to had I not had this sense of confidence that I don't have cancer today. So I think we really need to spend the time and effort to figure out how people think about the results of these types of tests, and also preemptively how to kind of motivate the best case scenario of getting people to show up for standard of care screening that we know works, and use this as kind of a complement to motivate people who don't have standard of care screening for their type of cancer, or who might not otherwise have shown up to come to the table.
Thank you. We have some communities around the country that have been exposed to carcinogens. We can go back and forth about whether those carcinogens have a direct link to cancer, but we can certainly say it's potentially elevated the risk for cancer. I think we can probably agree to that much. Some of them are in the room here from Flint, Michigan, and Houston, Texas, are in the room. We can go back and forth about Cancer Alley in Louisiana. And those communities right now need help. Many of the cancers that they are suffering with, there is no screening for multiple myeloma, for example. And we think we ought to have a sense of urgency about getting help to those communities, because guess what? Public policy created those carcinogens. And then when you go into those communities, what you find is that they're underserved for medical care. We don't give them best modern care. They don't get clinical trials. Their cancer is diagnosed late. Even with existing screenings, they don't get those, so they get metastasized cancer and their survival rates are poor. When we look at the new technologies that are out there, you want to talk about financial toxicity? Well, that's what's happening because they can't buy those tests. They can't have access to them. So we can have an academic conversation about whatever. But the point is, when we looked at the same crisis with COVID, right, we had emergency use authorization for serology tests so we could get them into the marketplace as quickly as possible, and then we chucked those that didn't work. My point is, we got to fly the plane and build the plane, because trying to get to the perfect is going to leave those folks dead. Negative results or positive results, they die. The reason why we're in this room today, because we're saying that collectively, we got to get smart quick. We've let those folks live like that for generations. For generations, we've done that. And so we want urgency. We want our scientists to be active and engaged with us. We cannot sit around on a 10-year study trying to find out whatever. That's not going to happen. So I'm just being direct with you. I'm speaking for those folks in Flint, Michigan, because I was there. I've been down in Houston, Texas. You ain't been there, right? That's the point. So the moment is now. If you don't do it, we're going to do it. We are going there. We're going to take those technologies. We're going to find out how to make them work in our communities. And we're not going to wait 10 years to do it. So that ain't a question, that's a statement.
It's hard to follow that, Gary, and I don't have what, I think you summed it up perfectly. You've said what is on a lot of our minds, and I'll go off script a little. It's the reason I'm here today. It's the reason I want to work with you, is because you're action-oriented. And I'm sure a lot of us on the stage and in this room feel the same way. So thank you for the work that you're doing. And it's a perfect way for me to end this. I actually wrote down the words you said yesterday. And you said, this here, this conference here, and this initiative, and this movement here is about being intentional. We have to learn to do big things together, big transformative things together. That's what Dr. Puckrin said yesterday, and I just want to end with that. Thank you.
Okay, thank you, everyone. At this point, we'll break for lunch. We have about a half hour for lunch, and we'll be back here for the next panel on innovation in cancer care. Please head out to the left side here. We have a buffet. You can bring in your plates and eat right at your seats if you'd like, or if you can use the time to network. Thank you so much.
come at different times. This is just happened to be this is the largest that they built. This is
Good afternoon, everyone. If I can have your attention just for 1 second, and then we're going to get back to the program. I just want to say thank you to NMQF for being here and welcome you all on behalf of the AAMC, the Association of American Medical Colleges. My name is Danielle Turnipseed, and I'm honored to serve as the Chief of Public Policy here. And it's through the connection that I had with NMQF, specifically related to hosting a reception from Congressional Black Caucus, that we said, hey, let's do something else together. So wanted to welcome all of you, and I hope you enjoy our space. Want to let you know that we just absolutely love these kind of discussions that you're having right now. If anyone is interested in using the space, you can talk to us. We'd love to welcome you. We're centrally located, of course, right here in DC, but we're also centrally located in these kinds of conversations. So I want to let you know about on behalf of our 158 medical schools all across the country, including 4 in Puerto Rico, as well as our more than 400 teaching hospitals and health system. You are all welcome. We want to thank you for today. And I'm looking right at the masters of the whole design with Marilyn and with Adjoa and Brandon and so many. And also, if you get a chance, please thank our team here, especially the folks in the back that have back-ended the registration. We have just loved having you all and wish you a great remainder of the conference. So thank you.
Okay, while you're munching, we'd like to invite the next panel up. Oh, okay. Oh. Oh.
Mic check, 1, 2.
Okay, if conversations can cease, but you can still keep eating. Is the panel ready?
Yes.
Okay.
Please do. I know some of you are still eating, so go ahead and continue to enjoy your food. In order to stay on schedule and get you out of here in time, we'll continue with the program. My name is Kalalai Emeru, and I am the Vice President for the Center for Health Information Strategy and Services with National Minority Quality Forum. And I'm honored to be able to moderate your next session here. And we're going to just continue the discussion right where we left off. The last session I thought was very insightful in terms of how can we diagnose cancer. And this session, the title of it is actually Closing the Divide. So we're going to talk about how do we close the divide. There's a number of innovative therapies that are now available, not just to be able to detect cancer, but to now treat cancer. And then we'll also talk about how to close the divide in terms of medically underserved cancer communities. So what do we need to do? How can we collaborate? And what do solutions look like when companies come together? So without further ado, we're going to get started. I have the pleasure of introducing the panel. We have Dr. Liz Valencia, who is a Mayo Clinic oncologist. We also have Jocelyn, I'm sorry. Yep, Jocelyn Allrich. Yes, and she is with Pharma Trade Association, vice president there, as well as Michelle Oshman. I'm sorry, Michelle Oshman, who is also vice president at Bio Trade Association, and then Brandon. We've got Brandon, who's a CTO at IBM, and to get started with our discussion, what I'd like us to do is each of you introduce yourself and talk a little about what your organization is doing specifically to address some of these concerns and disparities we talked about or spent time this morning talking about when it comes to the disparities that exist with cancer care and how can we make that more equitable. So we can get started with you, Dr. Valencia. Yeah, sure. Go for it. Okay.
All right, thank you everyone. I'm gonna use this mic instead. It helps me get more centered and be able to see y'all better. So I'll be brief. I don't think I can talk about what I do for work or who I work for without telling you where I come from and who I am and why I'm here. I'm Liz Valencia. I'm Mexicana, Chicana. I'm first generation. My parents were migrant workers to this country. And my whole life, we moved every 3 to 6 months, depending on the crop season. We lived in Washington, California, Oregon, Nevada, Arizona, Louisiana, Texas, Florida, Nashville, New York. And every time I tell that story, I think of another state. But this was the norm for me. And I knew that in my community, my Latino community, the migrant worker community, we didn't have access. We knew there were options, but we didn't know how to access them. And when we asked for help, we were told that it wasn't made for us, that we weren't going through the right pathways or channels. And at a very young age, I understood that's probably not the way things are meant to be, and we got to do something about it. So I decided to go to law school, and then I decided to go into medical school to be a physician, lawyer, leader to help change those conversations. And I will tell you who I am as a community activist. I am here for all the communities that can't be in this room who believe in us as influencers, in our expertise, in our positions, in our organizations, to advocate for them, to tell their story, and to come back with solutions. And I'm here for all the trainees who believe in us right now. The pre-med student, the medical student, the resident, the fellow, the junior faculty, who said, okay, we understand that there is a lack of equity in healthcare, so now what? What's the plan? And so I have formed a relationship with NMQF. They changed me about 2 years ago. I'm involved in a lot of spaces in government and in medicine and in law. I worked as a senior policy advisor for 2 governors in Illinois. I'm on the board of governors for the American College of Legal Medicine, which is a worldwide organization for MD, JDs, and policymakers. And I'm also heavily involved in the AMA as the chair of engagement for the Minority Affairs section. But it wasn't until I came to an NMQF meeting in April 2 years ago in DC where I felt something. This is a call to action, but there were people with expertise and influence who understood what the task was. And the way, when we talk about trustworthiness, when Dr. Nguyen talked about that, NMQF has that trustworthiness factor. And so when I heard that we were convening for this moment, I'm going to show up because I feel like, okay, I'm going to get my marching orders, and this is how we can lean in. And I will tell you that I understand, I see Dr. Pekrin as a mentor. I've adopted him as a mentor. I hear him. I felt something yesterday when he said, it is time for us to collaborate. I felt that. I can't do my job as a physician. I'm a radiologist, breast cancer imaging and interventional radiologist. I see about 50 patients a day. I hear what their concern is. Oh, you feel a lump. Let me image that. I'll do your ultrasound. Okay, I see 2 spots. Let me do your biopsy right now. I do the biopsy. I see them the next day and I say, you have an early cancer, but we can cure this because we caught it when it was this small. Or if they have high-risk screening, I'm able to use MRI. I'm able to put them in a clinical trial. I see myself as a gatekeeper, trying to kick the door open with my foot in the door for as many to come through as possible. And so I would tell you that that is what this moment is about, is how do we amplify that? I can't do it without pharma in the room. I can't do it without the physician scientists. I can't do it without tech. I can't do it with without the policymakers. I need all of you to help me, help our communities and our trainees to be part of a comprehensive solution so we don't wait 10 years for there to be change, so that the change happens now. We build it and we fly it and we make it happen now, and that's why I'm here. And so thank you.
Thank you, Dr. Valencia. Jocelyn?
Okay. Thanks again, Jocelyn Ulrich with Pharma, where I work a lot on medical innovation policies. So I'll just start by talking a little bit about, where is the cancer pipeline? And in many ways, cancer has really met its match in biopharmaceutical innovation. We are now in a time where science fiction is now a reality for many patients. So after decades of research, the kind of progress that are being made is really unprecedented. We have an average of 68% of medicines in the oncology pipeline today are likely to be first in class, meaning they use a new or unique mechanism of action for treating a disease. And the pipeline is rife with innovative therapies with all kinds of new approaches, such as immunotherapies, which include monoclonal antibodies, and CAR Ts, where we can unleash the immune system to attack cancer cells within the body. Gene editing, we can go in and actually manipulate DNA to change locations and treat and target specific cancers. Oncolytic viral therapies that work by zeroing in on cancer cells and to replicate them and cause them to rupture. And then antibody drug conjugates. If you were following JP Morgan this year, there was lots of discussion around these kinds of therapies, which can target specific cancer cells with cytotoxic agents without harming surrounding cells. So incredible advances for patients. And this is resulting in great improvements. So the death rate has dropped 33% since 1991. That's nearly 4 million prevented deaths. Taking breast cancer, which is a cancer that disproportionately impacts Black patients, earlier this month a new study was published that showed that death rates from breast cancers have been cut nearly in half. So in 1975, 64 out of every 1,000 women died of breast cancer, and by 2019 that number was 27. And the amazing news about this is that most of this is done due to better treatments, and the remaining benefit is better screening. So combination of screening and early access to the right treatment is really having a profound effect. But as we're going to talk about further in a little bit, none of this matters if you can't access these treatments and if we don't have good information about the kinds of patients that would benefit most. So I'll stop there before we go into some of those other things.
Thank you.
Thank
Michelle?
you so much. Hi, Michelle Oshman, and I lead external affairs for Biotechnology Innovation Organization. And like Pharma, we are a trade association. We represent companies from the very, very small startups all the way through the major blockbuster companies that are Pharma members as well. So we have about 1,000 companies in our membership, and again, across that spectrum of health and agriculture as well. So a few things about that I'll talk a little bit about, and I think sometimes it is helpful to share a little bit of the individual background. So I went to pharmacy school before anything ended in MAB. So I am almost not useful in any kind of clinical conversation at this point. Monoclonal antibodies changed the face of treatment and changed the face of cancer. And now you see people surviving stage 4 lung cancer that may not have had a chance before. My cancer journey, and it's not so much about me, but about my family. When I was in pharmacy school, I always tell people I went to pharmacy school. I don't tell them I am a pharmacist because I am not. The reason I am not is I had a crossroads in my third year of the program. We were starting our family, and I also got a job offer from a company, and I was really excited about that. Do I stay in graduate school? Do I not? But most importantly, I had a choice to potentially be part of a caregiving team for my best friend who had a glioblastoma at age 35. It was a very challenging time, and she lost her battle. I think the average length of survival with glioblastoma, which is a stage 4 malignant brain tumor, is 17 weeks. She did manage to survive for a year. And my baby was named after her. So my daughter, Judy, is named after my best friend, Judy. But coming into the cancer world from that perspective, as somebody who was in the biomedical field and then had this really profound experience, as I think everybody in this room has that experience, right? Either individually, a patient you've cared for, or someone in your family, it really brings to bear just the impact of the work that you all do as physicians, as researchers, and the biopharmaceutical industry as well. And you notice how Jocelyn said biopharmaceutical. I mean, we are a continuum, right, across biotech, pharmaceutical. We're really one and the same, and with unique opportunities throughout. The small biotech companies often fuel a lot of the innovation that the larger companies can then acquire, and the small companies rely on that for capital formation. So coming back then to where we are with cancer, Jocelyn talked a lot about just the incredible pipeline that is out there. Just in the last year, we've seen the first CRISPR-based therapy, again, not necessarily in cancer, but if you think about where these technologies are taking us, it's incredible. We have a cell therapy for type 1 diabetes. Whoever thought that that could be possible? And an Alzheimer's drug that was approved, and many more in the pipeline based on the same technologies or mechanisms of action. So we really think about where is the future going, but as Jocelyn said, the future for cancer care, the future for sickle cell care, the future for any kind of care is quite limited if the patients can't access that care, if the physicians don't have the choice of providing that care because it's not on the formulary or it's not allowed. And so that's really where we tend to focus and where we hope to be partners with you all. And with that, I will stop talking and let my colleague who knows all about artificial intelligence talk about his topic.
Nice. Thank you very much. Good afternoon, everyone. My name is Brendan Folks. And for all the clinicians, researchers, everyone, I want to just say thank you. It's amazing what you do. My cancer journey is 190 miles on a bicycle every August. It's called the Pan Mass Challenge. It's going to cross the $1 billion of raised for Dana-Farber Cancer Center. And the inspirational stories on day 2 when you're 185 miles in, just trying to get to the end of the Cape, those stories, those I'm alive because you ride, from a 6-year-old girl, like what you people do is amazing. I am actually our global head of technology for IBM, which is a fancy title from a software architect. I'm not a clinician, but I'm almost 30 years in healthcare IT. I've walked the halls in most academic medical centers implementing your systems. I used to write them. Sorry, I didn't know what I was doing when I was younger. I'm sorry, they're not that nice. But on a workflow. But really how we're thinking about this, and as you just quoted Dr. Wynn a second ago, that trustworthiness. And how do you scale those deliberate studies into, as the panelists were saying a few minutes ago, into practice and deliver access? There's a lot of hope with all the new artificial intelligence technologies. Generative AI can solve everything. It's great. What it's really done is expose the warts in the data that we all know is there. Data in the system is systemically biased. It just is. There's nothing you can do about it. You can't go back and fix data from the past 20 years. That's just what it is. How do we help people understand that and put that trustworthiness in the data to help it scale? So that when you're thinking about that experience and access and measuring the trustworthiness of the organization, like Dr. Wynn said, we can do that statistically with full transparency, full explainability, so when you're having a conversation with the patient, that high touch that you talked about as the gatekeeper a minute ago, as we try to scale you, someone trying to help has all the evidence behind it at their fingertips in real time, so that there is a trust in the system. And that's really how we're thinking about where we fit in. We're not the experts in what you do. Our goal is to help the experts in this room scale. We tried to be the experts once. It didn't go that well. So we're going to let the experts do what they do and empower you, and do it from, I actually was speaking on this topic this morning with the Veterans Experience Office about trustworthy AI and ethical AI. So that's really the key pillars of this and how you can scale it. And I love that comment. I'm just going to come back to it because I use the word trust and trustworthiness all the time. You can measure it. You have the power in this organization. There's only so many people. If we're going to use tech to scale it, we have to fill the tech with that same trust that you have with the local community members.
Wonderful. Thank you. So moving on to how can we then take all the medical advancements that are happening, not just in pharma and the biotech, and we purposely have it stationed so that you have the digital technology that's happening. You've got a medical health system and an academic institution like Mayo. So all of this need to work in conjunction so that we can defeat cancer, or as Dr. Parker says, write the last chapter on cancer. So Jocelyn, to you, there's a lot of breakthrough that's happening in terms of innovative therapies. You mentioned a few of them now. We're, just in the last 5 years, there's the ADCs, the radioligand therapy, there's the CAR T-cell. I mean, we've grown leaps and bounds, but those therapies are not available to the medically underserved cancer communities that we are here discussing. So how can we make that a reality, and how can the pharma industry contribute to the improvement of care of these communities?
Yeah, great question. So I would say, because cancer affects everybody, we do indeed need to treat so that our treatment plans and our access is geared towards everyone as well. As I said, we do know that there are disparities in cancer across racial lines. And there are many parts of the story to why the disparities exist. So starting first with out-of-pocket costs. We know that 2/3 of Black patients abandon their medicines when insurance imposes out-of-pocket costs of greater than $125 per patient, even with commercial insurance. And so we really need to find solutions to lower those out-of-pocket costs for everyone and make sure that insurance is working the way it's intended. Now, pharma has been working hard to try to get some reforms in this space. We support laws that would ensure that the negotiated savings between an insurer and a pharmacy benefit manager are actually being passed on to patients. And we believe that patient cost sharing should be based on that negotiated price, so not the list price. So we want to make sure that the insurance, again, is working the way it's intended and that out-of-pocket costs are being managed for patients. And we also support benefit design changes that would enable patients to smooth their costs over the benefit. So many of you may know that under the Inflation Reduction Act in the Medicare program, there is a new $2,000 out-of-pocket cost cap, and that it also will be allowing patients in Medicare to be able to smooth those patients out over the year so that they're not hit at one point in the year with a very high out-of-pocket cost. So all of those things together, I think, can make a meaningful difference. But there's other parts of the story as well. There are social factors like where someone works and lives. Are there doctors available? Is it a pharmacy desert? Pharma has been very engaged in this space. We have a CARES grant program where we have given out over $500,000 to improve health equity and to support equitable access to medicines and build infrastructure. And the third pillar is really around better data and clinical trial diversity and ensuring that patients feel comfortable that they're being approached with the opportunity to participate in a clinical trial, that they are being offered that option by doctors who look like them, who they trust, who are in their community. So pharma has been working to advance that. We've given a large grant to a bunch of medical centers, Yale, Morehouse, and Vanderbilt. And that grant is working to build a local community clinical trial site infrastructure. So very important to, again, be bringing trials to patients where they live and where they can access them. So all of these things together, I think there's sadly not a silver bullet for how we address this, but we're going to have to look at all the ways that patients access care and we provide data to the system. I'll turn to Michelle.
Thank you. So, Michelle, you mentioned some of the advancements being made in the biotech industry. From a policy environment, what are some of the things that are being explored for biotech industry? Because we talked about screening, that there's the diagnosis, there's innovative therapies that are now available. How can we think about that from a policy environment, and what's the biotech industry doing to make sure underserved communities are being considered?
Thanks so much for the question. It is really important. And I think one of the opportunities we have at BIO, we enable our member companies, right? Our companies have the labs. They're doing this incredible research. How do we create that policy environment so that they can be most successful? I think we both do that. I mean, our associations absolutely work to enable that. So it's a little more distal rather than a concrete bio project, just given sort of how we get there. But there are a number of policy issues that are really important to consider as we think about how do we ensure that every patient has access to the care that they need. When we think about the Medicaid system in particular, the Medicaid drug rebate program proposed changes will fundamentally, I think, limit access for patients who are in Medicaid. Patients in Medicaid, there is a disproportionate amount of minority representation in Medicaid for a host of reasons. The Medicaid systems really are trying to, understandably manage their state budgets, but this means that some of the most innovative therapies, including gene therapies, where you have virtually a 100% chance of that treatment having an effect on a genetic disease, may not be accessible. And so that's a significant challenge. In oncology in particular, by definition, I would say most pediatric cancers are considered rare. In this community in particular, the Inflation Reduction Act has disincentivized companies who are doing disease research in what would be called an orphan disease. Really, there is a provision that protects the company for the first drug that they get approved for only the first indication for a rare disease. But if there's no incentive for that company to do additional research for a second rare indication, because if they do so, if they open the IND to start that research, they actually then are subject to government price controls that they were initially protected from had they only done one indication. That's the Orphan Cures Act. We're really concerned about that because, again, as I'm sure, certainly as a clinician you're well aware, and as policy wonks we are, most treatments, with the exception of gene therapies, which are just so cutting edge, you utilize them. If they are effective in one disease area, it's possible that they may be effective in another diagnosis that has a similar upstream, disease biology, but the incentive is not there. So that's another piece. And there are a host of other areas where, at the end of the day, the folks who suffer are patients. Especially the patients that are in sort of the public payer systems, and we really do have significant concerns about that. And how do we ensure that, to the point that Jocelyn made, there are physicians accessible to communities, right? How do you make sure that it's not a 45-minute drive to a CVS where you feel safe walking in the door? How do you ensure that there are trainees coming out of the colleges that AAMC represents who will want to work in areas of significant medical needs? So it is an ecosystem. I know that the title of this panel was like bridging the gap or closing the gap. I feel like I'm widening it by articulating all these challenges, but it is always so heartening to work with anything that Gary does is pretty amazing. And to work with NMQF and with all of you in the ecosystem in which we all operate to work to not only bring those cures to reality, but really figure out how do we make sure that they are accessible.
Thank you, Michelle. So access and affordability is an important topic, and that's one NMQF is constantly working on and tackling. So from Dr. Valencia, from a medical institution perspective, you talked about the impact of having these advancements, but how can we now, or what role does the medical institution or a Mayo play in terms of bridging the gap so we can make sure that these advancements are a reality for the medically underserved communities?
Great, thank you. Thank you for the question. I will share a story that I believe answers, at least gets the conversation going. I lead the tumor board enterprise-wide, worldwide for breast imaging cancer workups, and we just met about 2 weeks ago, and it's international, so we have different countries online presenting complex patient care, and we've got biomedical scientists on and IT and technology on as we try to brainstorm in how do we help this patient where they're at now. And so we come together, and the patient that stands out in my mind had stage 4 triple negative breast cancer in 2017. And we met and reviewed her case then. She went back out, got her treatment. We saw her back a year later, and she was in remission. Complete response, no residual disease left. She was in a clinical trial, was doing well. We discussed, do we continue the current algorithm? Do we need to continue to blast it with everything we have, or do we hold back? And so we had those conversations. The following year, had another metastatic deposit, and we had a conversation again. Here we are in 2024 talking about this patient. And we had a moment where we said, it was a somber moment. We're all on the call, and we said, 5 years ago, we wouldn't even be discussing this patient. 5 years ago, we didn't have the therapies. We didn't have the technology. I didn't have the MRI, or I didn't have the molecular breast imaging radio tracer, or I didn't have the capability to biopsy something that I only see with radio tracer, but we don't see on a mammogram or ultrasound or MRI. I didn't have the capability. So it's a fantastic moment right now. We talk about bridging the gap. We are bridging the gap as we speak right here. These conversations, bringing policymakers, attendings, education together, we're coming together because we know alone we can only make incremental impact. I can't take care of patients without all of you. And we can't reach our communities without NMQF. The policymakers, what they're doing in Houston, what they're doing in Flint, Michigan, we have to consider models of how do we take that healthcare experience about the patient I just shared at Mayo, how do we take that and make it accessible to everyone? I worked in private practice before I went to academic medicine. I was out in Arizona trying to give breast cancer care to the reservations, to the Indian Health Services, to the migrant workers, the border towns. How do we make this accessible? Everything we're talking about here is now. And I am excited and inspired by my colleagues here and everyone who's in the room, because each of us has a piece of that solution. When Dr. Pekrin says it's time for us to do big things together, that's why we showed up. We're ready. And I would say things that Mayo is doing is we take that seriously in education. I think this new generation of trainees, they are not going to live with the status quo. They demand change. And so they're looking to us to lay out a roadmap and to change how we teach and to allow them to be part of the solution. The first day of med school, okay, let's go ahead and let's have you rotate through clinical trials. Let's have you rotate through AI. AI is part of medical education now. We have to catch up. and we have to fine tune what we're doing in healthcare for our communities, for our patients, and for each other. We're stronger together.
Thank you. That story was insightful. Brandon, coming to you, we spent, I think there was a couple sessions that talked about machine learning, AI, and predictive analytics, and how that may be very useful in terms of being able to bridge the gap or close the divide. So in terms of looking at improving cancer care using digital technology, there's one thing we can't ignore. There's a digital divide that exists currently. So, I mean, we've got Arthur from Flint. Shout out to Arthur. I've been in Flint where the average broadband access for a household is somewhere around 60%, when the rest of the nation is at 85. So before we can even use digital technology, how do we start thinking about closing that digital divide that currently exists for some of these communities?
Yeah, and that's the backbone is key, and I know there's been a lot of initiatives around broadband access with the aim coming out of the P word, things we learned during the pandemic about the need for telehealth and that access to care. But there's also two sides to this. If you think about the trust factor, because healthcare is a trust economy, and pharmacists are actually some of the most trusted people in the system. Just you're not one, you went to pharmacy school. How do we do that? How do we provide that access? When you think about your elderly patients, they still want to talk to a human being. They don't want a digital chatbot. I love mine that I have from Anthem because I don't have to call and sit on hold or any of that stuff. But they want to talk to a person. So part of bridging that digital experience is empowering that care manager, case manager with the information they need when they need it, including those complex benefits. You talked about price and cost and all the medication costs and the complexities. And a story, and it didn't have a happy ending a few weeks ago for one of my coworkers' husbands, but she works in the healthcare industry with me and has been for the 13 years I've been at IBM. So she understands how fragmented and broken the system is because we live it every day. And it still was an absolute disaster to try to navigate. And why a visit, you know, they live in the Pennsylvania area. We're going to MSK, doing some outpatient MSK stuff. He was on a clinical trial, et cetera, but they weren't going to cover the MSK location in Pennsylvania, but they'd cover the MSK location in New Jersey. Or vice versa. I forget how convoluted it was.
Yeah.
So, and that's someone who actually knows how to work this system. Giving that care manager as part of a system, the ability to answer all of those questions, trusted, have it generated for them, make it quick, make it fast, so they can comfort, because it's such a personal disease. You know, you can kind of do a lot of diabetes coaching with the chatbot and things like that. This is so different. It's the C word just invokes such visceral emotional response on people. And it is one of those things. If those care managers are empowered with these type of digital technologies where they can really answer and recommend, go here, it will cost you this versus going there, it's going to cost you a lot more. How much more empowered do they feel? They feel trusted, they feel embraced. It becomes a high touch. And that's a lot of what we're doing in just sort of, that's where a lot of the customer service side of these newer technologies is being used. And that's really, I see how the digital, until we can get in the homes, like you can only wire broadband, and there's a cost, and there's grants, and there's ways to do it. If you're, you know, based on poverty lines, you can get subsidies to get broadband in the home. There's a lot of good things happening. I'm not a policy person at all, and I don't even play one on TV. So it is one of those things. That's an option, is empower the people, the care managers. This SWAT team that's going to go hit Cancer Alley, it's going to take an army, and those care managers, case managers need to know. They need to have that 360-degree view of that patient, including all their benefits, comorbidities, structures, social determinants, everything going on, so they can really provide that high touch. That's where the digital technologies come in. On a flip side, from a pure research, back to letting the experts do their thing, the only quantum computer that is not in an IBM lab or a government facility anywhere in the world is in Northeast Ohio. It's at the Cleveland Clinic. They're folding proteins to create new meds. And if you've been to the clinic, where our office is on campus, on the back side, there was a bullet hole in it one day. I went to go to that office in Cleveland. It's not a nice neighborhood on the back side of the clinic. So they have access to the underserved community because they walk their halls. So there's a collaboration, there's a consortium. You can just Google IBM Cleveland Clinic Quantum Computer and go find them. They want people to bring their data. They want people to bring their data sets. Once again, the experts lead. We just power it. We're going to get out of the way and let them do it. IBM Research is involved. But it is one of those things. How do we do something innovative using technology and yet have access to the right community that shows a health equity effort? It's not just in an ivory tower somewhere. It's in Cleveland, you know? So
Yeah.
it's a great opportunity. But I think that's the same thing. That's where the digital can help. There's a million telemedicine companies. They're all good, but if there's no broadband, you have to empower somebody else.
Yeah, I saw something. Sure, you can add as well. I just saw something a couple weeks ago where a health plan is actually issuing mobile devices for a subset of their patients who couldn't afford broadband connection. So I think it is time to think outside the box and be a little more innovative when it comes to even cutting down on the digital divide. You want to add something?
Yeah, I mean,
Go
I
ahead,
think
Michelle.
if I may posit this sort of thought, and this is that, so you talked about being a community oncologist before coming into academic medicine, and you know, if you had to count up all the hours you spent trying to get a prior authorization for a patient, or getting a formulary exception, when you knew that that therapy was the right one for that patient, how do we enable AI to facilitate that process without the end input? Don't make it a fancier way to say no, right? How can you incorporate data to actually do, you know, sort of the economic analysis, and that the payer, if it's the right drug for the right patient at the right time, it's a no-brainer.
We're working on that. Forgot to mention that.
Okay, good.
Following the Da Vinci.
Okay,
the
I'm
Da
gonna
Vinci-
follow up with you.
The Da Vinci Project, following their protocols around the Da Vinci Project, we actually have architected some of this stuff out. I can't make them, once again, I'm not a policy person. I can't make them change their minds, but I can empower them. I had this conversation the other day regarding how do we do this, and it was just knee and hip. It wasn't complex cancer care, it was orthopedics. And the idea of having the data available, and I was talking to a doctor at Hospital for Special Surgery in New York, just orthopedics. That's all they do. Hips and knees, and a lot of them, they do them really well. They know, because of this guy's record, if he says patient not eligible for physical therapy because he or she is so debilitated, they don't force physical therapy. They approve getting the surgery scheduled before and not make them do PT when it's never going to help. And if someone who's had a hip done, it's an awesome feeling. PT wasn't going to help me at all. I did it anyways, but we are working on that, so we can chat about that. I know. I'd like to be
happening
Well,
already.
you know what?
Yeah.
You said you might be widening the divide, holding me accountable. You can't fix what you can't measure. So we got to get it all on the table and then measure how broken it is so that we can measure how much better we get at it. It's a great point.
All right, so we've got a few more minutes, and I sense post-lunch fatigue setting in, so I want to participate. I want to get the audience to participate and see if there's any questions from the audience. We may have time for one or two questions. Any questions for the panelists? Oh, YouTube, great. Our virtual audience.
Question from YouTube to this panel. While bridging the gap for organizations and clinics within one network or under one large academic medical center helps, how do you bridge the gap for community health centers without academia support? And I have to add, this is a big question that NMQF has been particularly focused on, since the big academic centers often don't have the level of reach and hard to reach populations, minoritized communities.
Anyone want to take that?
I would think the same thing, because I mean that's where the care is delivered, the federally qualified health centers and things along those lines. They're such a lifeblood to care delivery. How do we empower them to be able to provide the answers as if they're at Mayo? That's where the tools can start to, but once again, We got to get it right. It's got to be trustworthy. It's got to be transparent. But if we can start to give them that advice as if they have a specialist, like my esteemed panelists, leaning over their shoulder to help give advice. How to create that sort of coach over their shoulder. That's where digital and some of these new technologies can help, where the clinicians always make the decision final. We just provide, I call it the science behind the art of medicine.
We had Annabella from the White House and the Cancer Moonshot team this morning. So she talked about a set of CPT codes that were recently approved to do assessment of social drivers of health and just to be able to make that connection. So I think that's one where federally qualified health centers and the larger medical systems and the hospitals can now work in conjunction to take care of the patient from screening to diagnosis and finding the specialist and so on. So I wonder if Dr. Valencia, you want to add to that.
Yes, just briefly. When I practiced in Arizona, there is 5 medical schools in Maricopa County. And yet there are complete, what I would say, healthcare deserts, depending on which part of the county you're in. I think that academics has a lot of resources. The AAMC is a fantastic leader for delineating required competencies in undergraduate medical education. ACGME is another heavy player that actually gets funding from the government for our residency and fellowship positions at each academic center. I think what we need to do is have a conversation, invite them to the room, and find ways, because we need them. I always tell the medical students and the residents and fellows I work with, I mean, you aren't the future, you are the present. You are the present now. And so we need to engage that entire workforce so that this isn't something that we strive for, but something that we're actually implementing in real time in partnership. But we can't do it without the communities. We can't just be coming in as academic centers. Oh, I have residents that are gonna now rotate in your community, and then we leave. We need to learn and gain the trust of the communities, and we need to be consistent and understand what is the need of your community and deliver those services. We have a lot of siloing and a lot of resources because we're all reinventing a different version of the solution for each unique community. But what would it be like if we were all in the room like this and we said, okay, let's hear what IBM has to say. Let's hear what bio has to say, or pharma, or the policymakers in the room. What is the it factor? And let's run these 3 plays, and let's actually move the ball down the field for every community using the same funding source, and see if we can amplify and scale that up, at least as a foundation. So I think that would be an excellent opportunity that NMQF could help bring together.
I love it. Yeah.
It's,
Okay, we're out of time, but we'll take it. Go ahead, since it's you. All right, so I'm just going to repeat your question for our virtual audience. So Arthur is asking, why can't we take a lot of these advancements with respect to digital technology and others that are available, instead of someone making a decision on behalf of the community, why can't that be taken to the community and let the community choose whether or not that's a suitable solution?
So it's interesting, this morning I was with the Veterans Experience Office having this conversation, and if you put the veteran at the center of everything, it's amazing how it changes the conversation on what you go to try to build. I think we need to get these, so again, technologists, a lot of this stuff is still new, the generative AI, the summarization, we're just getting it into real use cases where it's safe enough to use. As that's ready, I firmly agree with you that the community needs to be engaged in order to make sure it's right for them. Because if they're like, I don't want this, then no one's going to use it. So I think following that model and getting the community leaders, you know, the church leaders, all these people involved in these conversations is super important, because we need their perspective of what's going to work on how they want to be engaged.
Absolutely. I know we spent a lot of this morning talking about how can we build trust with the community. And I think that's something that needs to be done. And digital technology can help us build trust and also establish that credibility. I think about, you know, I think one thing you and I have in common besides great taste in socks is technology. And what I often think about is the advancements being made with decentralized systems. So there are now capabilities in which the patients can be armed with their own medical records. They can decide who to share it with and what clinical trials to participate in. So that's the type of advancements that can leapfrog the community to where we are currently to where we need to be, or where the future is headed. So
Amen to that. I know we're out of time, but can we take a second for our teammates who are translating this live on the fly? Because this is fascinating to watch these two people translate this on the fly. I'm amazed by them. I think we should give them a round of applause.
And a round of applause for the panelists as well. So we're deeply thankful and very insightful. Thank you.
This is the last panel of the day. This is the last panel of the day. Thank you, everyone, for hanging out with us this afternoon. But this is the best panel. We're going to talk about how we're going to pay for it. Okay, good afternoon. Good afternoon, everyone. Okay, here we go. All right, good afternoon, everyone. So this is the last panel before closing. So last but not least, how many people care about money and how you pay for things? Yes, hands are going out. So this is the panel we're going to talk about money, but importantly, what are the solutions that are emerging from a health plan perspective and also macroeconomic perspective. I think the battery's dying on this one. Okay, I'll just speak through it like this. Okay, excellent. So I'm just delighted to have an incredible panel that will have a conversation over the next about half hour, 45 minutes or so. I'll introduce the panel, but then I want each of them to introduce themselves more fully. First, we have Dr. Andy Friedson, who is Head of Health Research for MI Research, which is Milken Institute. And second, we have Dr. LaShawn McKeever, and she serves as Senior Vice President and Chief Health Equity Officer at AHIP. And third, we have Dr. William Lawrence, Chief Medical Officer at Carolina Complete. So why don't we have each of you just introduce yourselves a bit more fully. Andy?
Hi, yeah, I'm Andy Friedson. I'm the Director of Health Economics for the Milken Institute. I head up all of our research projects that involve healthcare, health policy, and the just general sector of health. Previously, I was an academic. I was an economist, or I still am an economist, but I was in the economics department at the University of Colorado and at the Colorado School of Public Health. And I have a textbook on the healthcare sector and economics and all those wonderful things.
Available on Amazon.
Good afternoon, everyone. My name is Dr. LaShawn McKeever, and I'm really excited to be a part of this conversation today and would like to thank you all for having me here. So I am a physician. I've been working in public health for nearly 2 decades, and from the beginning I've focused on thinking about how can we meet the needs of medically underserved communities. And so currently I am the new Senior Vice President and Chief Health Equity Officer at AHIP. This is the first, I'm the first person in this role, and it's significant because it's representing where the health insurance industry is going from a payment perspective. I'm immediately coming from CMS as the Director of the Office of Minority Health there, and was responsible for helping to create CMS's health equity infrastructure at the start of the Biden administration, and have really helped to drive in that role a lot of the policies that we're seeing now that are helping move us in that direction. So very excited to be here and certainly to engage in discussion. Thank you.
Good afternoon. William Lawrence, Chief Medical Officer at Carolina Complete Health. I'm here on behalf of Centene Corporation, and Centene, you know, is a managed care company that serves over 28 million citizens in this country, and actually is really focused on delivering sort of locally based quality care. I am a general pediatrician. I actually trained in pediatrics here in DC, and actually just prior to transitioning into healthcare administration, used to work on the front lines right down in Ward 7, Ward 8 DC. So it's really a pleasure for me to be back here to be a part of this discussion. So looking forward to our panel.
All right, thank you all. And I'm Esther Krofa. I serve as Executive Vice President for Health for the Milken Institute, and that oversees 4 areas of work, including faster cures and work we've been doing on biomedical research and innovation over the last 20 years, and much of that work began with cancer. So this topic is very near and dear to all of the things that we care about at the Milken Institute, and then all the work that we do across health as well. Of course, this topic in particular, which is focused on how do we unlock payment and financing to close the gaps in health equity, really matter for everyone who cares about this field, because the challenges that we often talk about are that although we know what needs to happen from a community-based perspective, we've heard a lot about that today, we know all of the solutions from care navigation. The big questions are who is going to pay for it? We have a very fragmented healthcare system. We have public payers, we have private payers. How do we align payment? How do we align incentives in order to unlock all of the benefits that we've talked about in terms of better access to care and better health outcomes? So we're going to start, Andy, with you, because you have a different way of reframing this question. Oftentimes when we talk about the challenges around health equity, it feels multi-sectorial, it feels very challenging. Many people think about the long-term return on investment, and it's difficult to quantify, and who gains the benefit from initial investment. So help us reframe this question. Are we thinking about payment and financing equity from the right perspective?
The short answer is no. The long answer, we'll get into, is that this is something where technologically, as we've learned today, we're entering a space where there's investments that can be made now that are going to pay very large dividends in the future. And one of the things that I mean by this in terms of dividends is not just in terms of cash for the people who are developing these things, but in terms of human return on investment, right? That these are things where we can have interventions that if we invest in and deploy now, that we can, we've talked a bunch about stage shifting, right? We can improve health outcomes to a great amount, and to the extent that we have people that remain within the same healthcare system, this is also going to have a financial component of you're going to spend less later by putting these investments in place now. So it's getting ourselves into more of a mindset of we're reaching this technological inflection point where by deploying these resources, we can end up saving money systematically. And if we're very intelligent about it, we can get tremendous benefit. And one of the things that we tend to think about when we're thinking about questions about health equity is that having this huge divide is a major problem, and it is, but it's also a major opportunity. Because if we're thinking about where the largest returns on investment in the human sense for deploying new technologies are going to be, they're going to be the places where we are the furthest behind. If you have people that are already at close to the top level of health that your technology is capable of attaining, then you've got a ceiling problem, right? You can only push them so much higher. When you have a gap, that is a bright flashing sign to me that this is the place to be making investments if you want to get the largest return with respect to population health improvements.
That's a great place for us to segue to Dr. McKeever, because what you talk about is that we have a huge opportunity to close bigger gaps, right? So instead of thinking about limited resources that you need to spread across a population, you're looking at where do we have the biggest deficit from getting access to care, and how do you capture those benefits from an economic perspective? So Dr. McKeever, if you talk to us about, from your perspective, thinking about what you did at CMS and where you are now with health plans, from a payment perspective, have those conversations around how we pay for health equity recognize the point that Andy just made, which is an opportunity set rather than a limited resource set.
Thank you. So I was really energized by Dr. Puckrin's comments earlier, and just what we are establishing, right? This is a moment of action. And that's what's happening across the healthcare sector. In every single corner of the healthcare sector is action. And so when I take a step back and think about this from a systems level, we're doing something in the healthcare system that we've never done before in this space. We have worked, for people who have worked on issues that relate to health equity, health disparities, we've been doing this for a very long time. I remember my first position working in public health at the Baltimore City Health Department. It was essentially implementing an SDOH model for Baltimore City, and people would just stare and say, why is the health department asking us about housing? Fast forward, social determinants of health, we have a level of understanding and knowledge in how we operate in these spaces to address it. Health disparities, we're now in a different place similarly than we were before because of the pandemic. So I joined CMS prior to the pandemic, and earlier we talked about we have different seats at the table, and everyone play different roles at the table and bringing people to the table. But it really helps when you're able to change seats and roles in the table to understand how our system actually works. Because essentially, if you think about payment and how will we pay for this in the public health system, in the private health system, we didn't have an infrastructure as a country to actually get there. And so through recent policies and executive orders, it sort of forced the entire federal government to think about, if you are delivering a service, any type of service, and in particular CMS delivers care through our programs, and it regulates the health insurance industry, how do you approach health equity from a payment perspective? And that's when I started my job. So I started right as the pandemic began, and then we began this work. And so going on a journey with our agency, working with other federal partners across the federal government to think differently about how we deliver our services and benefits. And for CMS as a payer, we were known as the payment agency, the health financing agency, which prior name. But the pandemic shifted our responsibility in the healthcare system that we couldn't just pay for service any longer as just a payer. We had to become an active part of the process. And so thinking about how do we design our benefits as a payer ourselves differently? How do we incentivize the health insurance industry differently? So that work, we weren't doing that work 5 years ago, 10 years ago, but this work is happening now. So I've been really excited to see some of the work that was done during that time coming to fruition in the healthcare system. And one of the things that excited me about coming to AHIP, so AHIP is the trade association for the private health insurance industry. And I had the opportunity over the last couple of years to talk to the C-suites across the country. So I've pretty much talked to, not all, but representing all the different industries. And we're on this journey together. We're in different places. There's some systems, and so from a payer perspective, some payers who are doing this very thoughtfully. They have very advanced payment strategies in place to address health equities. There's some that are in the middle where they have enough information to move forward, but they're still figuring out some things. And then there are those, and there's still a lot of organizations and industries that are trying to figure it out. But because of the pandemic and all of what we went through as a healthcare system, it changed how we are approaching this space. And so, you know, I'm just giving you this perspective because no matter what seat I've sat in, we've all called someone else a villain, right? So I was in the patient advocacy space before that, so in the diabetes space, and it seemed like the federal government didn't listen, and you know, this industry didn't listen and didn't understand, and we're trying to get our needs met. Then I had the chance to sit in the federal seat and understand where are the opportunities, but more importantly, what are the challenges, and are they actually working on the challenges in the way that we think they are? And now I'm in this seat where I'm really trying to understand, given this opportunity, what can we do in this payer space to advance health equity? And what I can say has been uniform in all of these experiences is that we're all trying to move forward, and we're all trying to get it right. Different places, in different spaces, we're in different parts of that continuum, but this is our inflection point for this point. You know, this marker in history, this is the healthcare system's inflection point to pay for access to care that is meaningful, equitable, and accessible.
Thank you, Dr. McKeever. That was helpful for us to know, whether you're in the federal seat, whether you're with the commercial health plans, that COVID was a moment of time that's galvanized the payment part of our health sectors, right, to recognize that we need to address and deal with health equity. So is it fair to say that everyone is working from a commercial health plan perspective on solutions and strategies to close the health equity gap? You talked about everyone is at different levels of maturity, but is there a common understanding that health plans have a unique role to play in closing these gaps through their payment policies?
So I would say everyone is aware, everyone is thinking about it, and everyone is making movement forward, right? I think that's the fairest statement that I can make. And what that means is people are starting to look at their data, and they're starting to realize what information they have and what information they don't have, and how that actually is impacting their ability to provide better coverage through their health insurance. And so we are all in different places, in different spaces. One of the things that I was really excited about in my time at CMS is we issued or released a framework for health equity that is guiding how CMS is thinking about this work. And it was being socialized across the healthcare system. So I would meet with the hospital and I'd hear how they're trying to implement the framework. I'd meet with the health plan to hear how they're trying to think through pieces of the framework. And so there are 5 pieces to it, but the 3 that I think, or I would say if there are 2 that are most critical, one is about gathering the right data. So looking at your data for your system, whatever system you are, and then trying to understand who is not experiencing what they should be in your system based on your own data. And if you have gaps in your data, what are the opportunities to fix that so you can actually design interventions that may be an upfront investment now, as you mentioned, but over time, you know, will have a different economic outcome. And so the collection of data was one piece. I can say most plans are doing that. They are looking at that. It's very complicated because our data system, we said earlier, is we're integrated, but not really. We're connected, but kind of disjointed. So our data systems, some have excellent data systems and some are not collecting the right types of data. The same as with the federal government. When we at CMS looked at our data, we weren't actually thinking about it across our programs. It was sort of siloed in our, if you are overseeing this program, I'm concerned about this data. But when you take a step back from a payment perspective and say, how are people across our programs faring, then we saw where there were some huge opportunities to address where we were from a data perspective. The second piece of the framework that I'll just flag is it talks about assessing the disparities. So once you have the data, actually doing the work to try and find the best interventions for your populations. And I can say from that framework, those are definitely two things that I'm seeing in different parts of the healthcare system.
Thank you very much. Dr. Lawrence has come to you because you're going to give us some examples of how that happens in a community setting. So tell us what's happening in North Carolina.
So first, I'll just clarify when we think about Centene, and I said that Centene takes really approach of understanding its individual markets and then crafting its solutions based upon the marketplace. What that really means is the way Centene approaches its entire business is to fundamentally assess what networks are available, where the strong providers are, to fundamentally look at the community-based organizations, the other resources that are in each market, and then adapting our approach to those markets to rely upon those who are doing what they do well, and then to supplant and support those things that need additional work. And so I will talk a little bit about Carolina Complete Health. I'm a little bit proud of it, I will say, but we're somewhat of a unique partnership from, a health plan standpoint. So Carolina Complete Health is a health plan in the Medicaid and market-based space, but we are a joint venture between Centene Corporation, the North Carolina Medical Society, and the North Carolina Community Health Center Association. So this was a partnership that was built to support the transition of Medicaid in North Carolina, which used to be a state-run program, was the last large state to still be a state-run program, and transitioning to managed care. So it really gives us a unique way to, as a plan, really have engagement, buy-in, and actual leadership from the physicians in our community into the health plan's decisions, the health plan's operations, and in how we handle our business. Now, I will also speak to the point that being in North Carolina, I am fortuitously sitting here because I'm downstream from the work that they did at CMS. So in North Carolina Medicaid, with their transition 21-22 into managed care, North Carolina was the first state Medicaid program to actually have funds from Medicaid appropriated as a part of its 1115 waiver to support social determinants of health. So we are amidst, sort of a revolution in our state by having funds outside of just the care-related funds to support building capacity in community-based organizations, screening for housing, food insecurity, interpersonal violence, and transportation needs, and then being able to use those dollars to help support those needs where they're identified. So, that is a major shift in the way Medicaid has typically done business. I think a couple of other states have now gotten those types of funds approved, but North Carolina was the first. And so we've moved down that alley now to the point that the pilot areas, which covered certain parts of our states, we're going back to, the state is going back to CMS now and saying, hey, we're ready to take this statewide because it's working and we see the benefits.
And if we go back to the comments that Dr. McKeever made around the 5-step or 5 components of the CMS framework, you talked about 2 of them. One is look at your data. Hopefully the data is complete to some extent that you can do that analysis. And the second is then identify particular interventions. So Dr. Lawrence, as you think about Carolina Complete and even what you just described, how did the data inform that strategy in paying for the social determinants of health? and then for which populations, right? Because you have to target it based on, for your particular health plan, where those dollars can have the most impact. Can you tell us a little bit about how you take a framework and then do that analysis at the health plan level to determine the appropriate solutions or interventions?
So I think we're still on that journey, you know, and as it was pointed out, one of the challenges is really the richness and availability of the right data to make those decisions on. So, you know, in our Medicaid marketplace, we are still learning how to gel that data and convene it into, you know, truly actionable information. But what we do see, and, you know, we went live after COVID, but we were there planning to go live when COVID happened. So being at the table with the state, even before our plans went live, we really were able to actively see where some of the pockets of disparity were highlighted and exacerbated during COVID. We were able to see how the state and many partners in the state utilize resources to try to bring and bridge the gaps that we're seeing and intervene with local communities, intervene through our churches, intervene, you know, through community health workers. And so now the elements that we've learned from that experience are what we're capturing and bringing into our action plans as we go forward.
Yeah. You know, that's helpful just to hear the story, the narrative, because for so many there's a frustration by saying, well, the health plan should just pay for it. Why are they not paying for it now? Not recognizing that there is this journey that you have to take, right? Doing that assessment, doing that analysis, looking at your data sets, seeing what is possible, and then where the appropriate levels of interventions are going to be and by which payer. And you talked about the Medicaid as the payer for the managed care, but I know with you, Dr. McKeever, we're talking about employers who are also the payers, right? And the plans are just operating those benefits. That's a whole nother set of stakeholders that you have to think about as well. So we'll come back to that in just a moment. But Andy, I just want to get back to the earlier point that you made, which is when you have technologies, and in the room we talked earlier around multi-cancer early detection technologies, when you have technologies that can potentially be incredibly transformational, and the challenge for many is I'm waiting for the data set so I can determine whether I should pay for it. How do you think about the upfront ROI that payers, either public or commercial, should be thinking about? How do you close that ROI gap or start to think about the components of closing that ROI gap as early as possible so that you can provide access when those are like, well, we'll wait 5 years or 10 years for the Vanguard study from NCI to come out? That probably is a little too late. So how do we shift that whole process earlier?
I think you have to do this all in the field, right? That this is the rationale behind phase 3 clinical trials, right? You want to do things approximating clinical practice, and this is the same thing. As soon as these are approved, you need to be piloting them. And as we've been talking about the idea that there are places that are underserved, again, these are places that are going to get huge returns to deployment. So I think the answer is you've got to deploy things and you've got to track them in real time. We can't let the perfect be the enemy of the good when we have something that is this transformative. This is exactly what happened with COVID vaccines, right? That COVID vaccines did not have full FDA approval. They had an emergency use authorization, and we rolled them out, and we learned as we went. And with certain types of technologies that are life-saving, transformative, and dealing with diseases that are time-sensitive due to high mortality rates, then you need to adjust your strategy to deal with the populations that you're trying to treat.
Yeah, that's great. Dr. McKeever, just to come back to the question that I asked earlier, can you give us some examples? What are the commercial health plans doing right now? You've talked to so many leaders across the country. We are excited to hear that health equity is in mind and perhaps for some top of mind. But are there examples that are coming forward that we should all be aware of and really trying to mobilize some partnerships to even help further?
Thank you. Well, I'm glad I have a wonderful example here of what's happening in North Carolina, which is my home state, by the way. So what I'll share is, as I said, I started this role in July of last year, and I've had the opportunity to talk to about 45% of our membership. We represent most of the largest healthcare plans in the country, a lot of regional, mediums, we represent truly the health insurance industry. And there's so many examples. I don't know, I don't want to call out a specific example at this time, but what I'll say is, one of the things that I'm doing in this role is working to build our industry strategy. And so through bringing AHIP's first Chief Health Equity Officer, what we're really saying is our industry is doing the work, and now we're ready to take it to the next level. And so what we are doing is gathering input from our stakeholders on, with AHIP advancing our work in this area, what are things that we should have top of mind as we're going into this space of identifying an industry goal that we're all trying to advance together. I'll share, a lot of plans have done some great work in maternal health. I've seen a lot of plans that have innovative things that they're doing in that space. Certainly, we're all thinking about mental health and how we address that. Where I think, as I said, health equity is newer of mind for many. Social determinants of health, more people have finally embraced that on a different level. And so I'm seeing incredible, incredible work in every corner of the country to try and wrap our arms around the social determinants of health. So I would say we've made the most progress to date of trying to close those gaps, or aware of those gaps, and trying to work towards interventions. But when you take a bigger step back and think about health equity overall, I think there's still a lot of work to be done. The last thing I'll mention is, with health plans and the different contract modalities that they have in place, thinking strategically, how do you incentivize those that you're paying to deliver on these things to, for example, provide more culturally competent and humble care? How do you use those levers as a payer? People have some great ideas in those spaces that they're executing. So a lot of work is going on.
Well, yes, and it'll be a lot of work for years to come. Dr. Lawrence, we talked as we were preparing for this panel around the provider network is a huge part of this equation, and also workforce, right? So can you talk about maybe the two of them and how that fits into the closing of the gap with health equity, because how the provider network is constructed, how perhaps it looks like the community, all of those components matter to the health plan as well.
Yeah, no, I think that's a good one. First of all, I will say, as you heard in some of our earlier conversations, in many markets, federally qualified health centers are a big part of the care for our Medicaid and Medicare populations, and that is actually one of the major strategies nationally for Centene to work with our FQHCs, and obviously that's a unique partnership we have in North Carolina. When we think about entering a market, and like I said, understanding the provider base in that community, understanding where the strengths are, also understanding where the gaps are, and then using the resources that we have to supplant that, whether that is helping to build a workforce through, pilot programs, whether that is bringing resources from our care management teams, from our community health worker teams into those settings to help transition or to help, implement change in some of the individual practices. And then from the larger standpoint, working in collaboration with our bigger systems around understanding the data, understanding the patterns of care within, their sphere, and then collaboratively working on how we bring the resources to bear to improve those. The workforce itself, obviously, is an ongoing challenge. In North Carolina, we are working directly with our FQHCs in emerging opportunities to both put students in medical school into FQHCs with a curriculum around health safety net care to help generate more interest and commitment amongst students to providing that care when they graduate. We're also working with FQHCs to train medical assistants and other, ancillary workers to help fill some of the gaps in those communities, but at the same time build capacity in those communities for continued care. And then nationally, there are many other efforts. I would throw one out there is Peach State Health, which is our plan down in Georgia. They actually have a formalized program with the medical school there in Georgia that, supports, I forget how many, but I think it's either 3 or 4 medical students with scholarships with a commitment to serve underserved, residents when they graduate. So those are some of the things that we've been involved in.
Well, it sounds like health plans are involved with all of the components that we're going to need, right? The workforce, the providers, obviously, with their relationship. They have a huge role to play on even closing the data collection gap, right, and the analysis gap. So let me open it up to the audience because this is the money panel. I'm sure there are some questions that you might have. Are there questions from the audience for the panel? We'll give it a few moments here. Or reflections based on what you heard that might be the same or different from what you assumed would be the case. Okay, yeah.
Another question from YouTube. Social determinants of health data capture and standard data representation is severely lacking. So basically saying social determinants of health data capturing is lacking. And there's very low utilization of ICD-10 Z codes, which basically track, okay, you're familiar. Any solutions to address that?
So I guess in North Carolina, at least, that is one of the benefits that we have with this current model. There are direct incentives to trying to screen for SDOH because you've got something you can actually do about it. If I think back to practice days, there were always questions that I hated to ask because I didn't know what I could actually do for them. We're beyond that now. We recognize the importance of asking those questions and then helping people to utilize the services that are available. I think in terms of coding, that is going to be different plan by plan and market by market, how they handle whatever reimbursement is there for those resources. But I think across the board, because there's more recognition of the importance of SDOH screening, the benefits that it has long-term to the care of those members, that everyone is moving to make sure that there's credit for it, whether it's directly through reimbursement, whether it's captured in some of the value-based payment arrangements. Those are the types of things that are happening.
Great. All right, well, as we close the panel with a few minutes, I'm just going to pose one final question to each of you, and then we'll close that way. Andy, my question for you is, what should people be thinking about from a return of investment perspective? Should they be asking different kinds of questions? What's the takeaway for this group when they think about payment and financing for cancer care, for health equity, that might really help them to really accelerate their processes?
I actually want to connect this a little bit over to social determinants of health, because I think that this is one of the places of the biggest untapped potential. That as we've been extending payment rails for the ability to reimburse plans or reimburse providers for engaging in this area, this opens the door to all the pavement pounders that are out there collecting information to come to the table and to actually be involved. Right, that one of the things that we keep saying is that we need patient engagement, we need to be bringing in the populations that are most effective because they're going to allow us to get better return in the form of health improvements. And until we have these payment rails firmly established, it's hard to incentivize our providers to engage in this type of activity. And this doesn't just need to be for insurer providers, right? One of the places that we've talked a little bit about is a clinical trial and engagement and clinical trial improvement. And we have funding to run clinical trials, but we don't have specific funding lines for engaging with communities and with building these types of relationships. And what I've always found really interesting is that we don't do this with academic medical centers, but we do this with academics with agriculture schools, right? That there are explicit funding lines that go out for outreach, right? That part of your job, if you're faculty at a school of agriculture, is to go out and talk to farmers and figure out how to make them farm better. And we don't do the same thing with schools of public health you're going to be running a clinical trial, or with a medical school to say you're going to be running a clinical trial. Part of the job of this clinical trial is education and outreach.
That's great. Dr. McKeever, how should stakeholders work with commercial health plans? How do they approach their health plan as a partner? Sometimes it feels like a black box, difficult to engage. What would be your recommendations for how to engage to co-create, co-design solutions that matter at the community level?
So, from an AHIP perspective, we're representing like the entire system. And, as I shared, I've met and talked with many across the country, and what I'm hearing is many of them are doing some of what you're saying here, which is they are reaching into they're reaching into the communities that they serve in a different way. And so they are working and looking for opportunities to engage those who, are covered through their plans in different ways. And what you described is an example of that. So I encourage you, if you have a health plan, really try and find out what are the ways that they're looking to connect with you as a part of their plan, because they need your voice and they're often asking for it. But we talked about earlier that they're, a part of what we're trying to do through this effort with the Cancer Moonshot is this increased education of how do you access and benefit from these things. So a lot of times the insurers have things that would help, right? But closing that gap of, sort of connecting the dots. And the last thing I'll say is, as I said, there's a lot of work that's happening. I think as we talk about the payment conversation, it always feels, no matter what seat, as I said, that I've sat in, if you're a payer, you're not often seen as trying to advance things. It's like, it feels like there's this push and pull, but there's a change that's happening. And, through the work that's happening now, we have this opportunity to bridge equity across the payment system. And so, I will be in this role. I look forward to partnering with you all as we do this work together. Thank you.
Thank you. And then Dr. Lawrence, when you hear all the national conversations, does it resonate at the community, at the local level? Are these the same issues that you're grappling with when you go to work tomorrow? Or are we having a whole different set of conversations that are not even connected with what matters in your day-to-day?
Yeah, no, absolutely. I mean, when it comes down to it, what we really need is the right care for the right person at the right time. And however we go about getting that, ultimately, when we eliminate waste from our system and we concentrate the resources that are there on achieving that, what is really that right treatment? Who is that right person? And how do we make sure we get it to them at that time? When we're building our system and operating in accord with that as our goal, then ultimately we're going to achieve those downstream benefits that we talked about.
Are you optimistic?
I am.
Okay, excellent. That's a great note for us to close this panel. Thank you so much, Andy, Dr. McKeever, Dr. Lawrence. Really appreciate it.
Thank you so much. So my official task now is to bring us to a close. I can't do that, first of all, without thanking Marilyn and Adjoa and their staff for really putting together really a fabulous program. I also want to recognize the staff of NMQF, Salvo, and others here. Philip. I have this amazing team at NMQF. It's I just, you know, they're just absolutely amazing. Here's what I want you to think about as you leave here. First of all, that AI panel was just spectacular. That was like, oh my God, we got to do that, because that is the future. And so I want to thank David and that panel. That is the future of healthcare, and we need to make sure that our voices are shaping that, and the best way to do it is for us to do it, as opposed to asking other people to do it for us. So want to have lots of conversations about that. I think the practical solution that we offer, there are two communities right now that we have in mind, Flint, Michigan, and Arthur, thank you for your great work, and Houston, Texas. And we'd like you to partner with us with all of your various skill sets. And we're going to reach out, we're going to create some work streams and ask you to be a part of that. Because we want to show that we, in fact, can do this, that we can organize and sustain an effort to transform cancer care in those two communities, setting up a template for the future. When you look at cancer care, when you look at the technologies that are becoming available, both medical, digital, whatever, what you quickly realize is that over the next 5 years, cancer care should really transform. It should be a different thing. And I'm sure that's going to happen in affluent communities because they'll figure it out. But in those communities that we've underserved, that's really where the contest belongs. I think I've said to those who reimburse for healthcare, the honest thing is, we need to work with you and co-create together so that we're paying for outcomes in these communities. And so I think that's the work at hand. What I can say to you from the NMQF lens, we are going to be relentless in trying to get there. And in being relentless, we want to build structure, because the way you make things permanent is that they have to be structured, and structure requires good science, data collection, analytics, good minds working together. There's no substitute for that, because at some moment, we're going to have to go up to Capitol Hill and have a really hard-headed conversation about the permission structure that they've allowed, right? Those medically underserved communities are not there by accident, right? They're not, that's not an accident. It is the way we've decided to apportion things. And in order to make those kinds of changes, you got to have good science and data, and probably be a nuisance as well, all right? So please take this as the beginning of the conversation. We will be reaching out to you by email. We'll be posting on our website and doing social media and making a general nuisance of ourselves, because we feel responsible. We're part of a civil society, and at the end of the day, we're responsible to each other. And we should not allow anyone to think that they can take that responsibility away from us that they can give us permission to do really bad things in community and turn a blind eye to it for whatever the reason they come up with. You cannot allow yourself to be a party to that. Certainly at NMQF, we're not going to be a party to that. And so take this as an important moment when we're reaching out to you and saying, please help us, help communities. We will take your trust in us very, very seriously, and we won't waste it. We will not waste it. So anyway, I want you to have safe travels home, and you know that we'll be nuisances and really ask for your help. So thank you so much.
Just wanted to let everybody know that we have snacks outside. And we actually have the space until 4, so if you were wondering about networking or there was someone you haven't pulled aside yet, there's still time to do that, so take your time, eat, and enjoy yourselves. Thank you so much for being here today. Oh, sorry.
just come to in the next couple of days. So
I can wait.
make something happen.
So I shoot you an email, right?
I gave you the information to you. So we headed back to the hotel.
Streets. I have my sneaker level streets. Most of them all. Oh,
want me to take that live stream stuff home? What's that? You want me to take the live stream stuff home?
No.
Okay. Yeah, I guess you want that, huh?
I need it.
Okay.